and sharing this presentation. For the information of everybody, I am Dr. Gautam Zaveri, the President of the Bombay Orthopaedic Society. On behalf of the Bombay Orthopaedic Society, I welcome all the delegates who are seated here today in Bombay at the Jupiter Hospital, and delegates from across the country who have spent early morning on a Sunday to come and share this experience with us. For the first time in the history of Indian orthopedics, a seminar of this kind is being conducted where a live surgery course is being telecast to 15 different centers across the country. The goal of this program is, this is nothing but telemedicine. We want to reach out to different orthopedic surgeons practicing in different environments and try to spread the message of safe and precise surgery. Why hand surgery? All of us think that we are doing carpal tunnels. We are doing decurvance procedures. We are fixing metacarpal fractures. But you'll be surprised to know that almost 10% of patients with carpal tunnel syndrome require a second surgery. Probably because there has been inefficient decompression, maybe the procedure has not been adequately performed, but even something as common as a carpal tunnel decompression is often wrongly done. The goal of this program today is to get some of the top hand surgeons in our country to demonstrate common orthopedic surgeries which are commonly done by general orthopedic surgeons. These surgeries are not surgeries for which you will refer a patient to a hand surgeon. You will probably do these yourselves. And therefore, the goal of this program is to ensure that you do the surgery, but you do it efficiently, you do it safely, ensuring good outcomes among the patients. In this BOS live surgery course today, I would like to welcome the various centers which are participating. From Jalandhar, which is the historic city in Punjab, we've got Dr. S.S. Dhingra, who is going to moderate the procedures. From there, he is a joint replacement and trauma surgeon, currently associated with the DCM hospital and the trauma center over there. And his co-moderator is going to be Dr. Davinder Singh Lal, who is an MS Ortho and a consultant orthopedic surgeon at the Lal's Orthopedic Center. In Kanpur, which is, like everybody knows, one of the major industrial cities of Uttar Pradesh, on the banks of the Ganges River, we have Dr. Ajit Tiwari, a fellowship-trained orthopedic hand, brachial plexus and microvascular surgeon and practicing in Kanpur. From Rohtak in Haryana, we have got Dr. Pradeep Kamboj, who is the professor in the Department of Orthopedics over there at the Pandit B.D. Sharma PGIMS, Rohtak. From Bathinda, what is called as the City of Lakes in Punjab, we've got Dr. Nitin Bansal, the professor and head of orthopedics at the Adesh Institute of Medical Sciences and Research Center. We've got from Haldwani, Dr. Ganesh Singh, who is also the secretary of the Haldwani Orthopaedic Society. And then we move over to South India, in Pondicherry, the charming coastal union territory in Southeast India. We've got Dr. Dubey, who is the head of department of the Indira Gandhi Government Hospital and PGI Pondicherry. From Calicut, also known as Calicut, the city of spices, we've got Sibin Surendran, who is a fellowship-trained knee surgeon and an additional professor in the Department of Orthopaedics at the Government Medical College. In Kadapa, we've got Dr. Subramanya Rao Sirsala. He is a specialist in regenerative medicine, works for pain joints and is interested in relieving joint pains. He is ex-professor at the Fatima Medical College. From Coimbatore, which is famous for Ganga Hospital, we've got the young and dynamic Dr. Karthik Selvaraj, a joint replacement surgeon who is owner of the KS Ortho Care at Coimbatore. In Burdwan, which is located on the banks of the Damodar River, we have got Professor Pradeep Kumar Ghosh, who is a trauma care spine surgery joint replacement surgeon and a faculty in the Department of Orthopaedics at the Burdwan Medical College and Hospital. In one of the oldest continuously inhabited cities in our country, Patna, we've got Dr. Ritesh Runu, who is an additional professor in IGIMS. Along with him, there are co-moderators Dr. Praveen Kumar Sahu, Dr. Kumar Shashikant, and Dr. Ritesh Pandey. At Agartala, we've got Dr. Rajiv Debnath, who is an associate professor in the Department of Orthopaedics at the Tripura Medical College. Finally, moving to West India, where Mumbai is, Sangli is a prominent city, and Dr. Shrikant Deshpande, who is the head of department of the Bharati Orthopaedic University, is going to be with us. And finally, from Sholapur, we've got Dr. Akshay Hanam Shetty, who is a founder of the Guru Orthopedic Specialty Clinic. Welcome everybody. It is my great pleasure and it is the honor of the Bombay Orthopedic Society to have all of you with us. We now move on to the next presentation, please. I'm going to give you an introduction about the Bombay Orthopedic Society today. I would, in the meanwhile, while that talk is being loaded, like to give a big thank you to our faculty here in Bombay. The senior most among the faculty, hand surgery faculty, is Dr. Hemant Patankar, who needs no introduction. He is one of the most prominent hand surgeons in our country. Congratulations, Hemant, for becoming a grandfather last week. And along with Hemant Patankar, we've got Dr. Pankaj Ahire, who is the president of the Hand Surgery Society of India, a very prominent orthopedic surgeon, a hand surgeon. We've got Dr. Parag Lad, who is the convener of this whole show, who has put all of this together single-handedly with great efforts. Parag Lad is the director of Pinnacle Hospital in Bombay. We've got Dr. Rohan Habbu, again a very well-known upper extremity and hand surgeon. Dr. Kiran Ladkat, who is a hand surgeon at the Jaslok Hospital in Bombay, and Dr. Prashant Kamble, who is an associate professor at the very famous KEM Hospital in Mumbai, and he is also attached to the Reliance Foundation Hospital and has been treating the rich and famous of Bombay with his hand surgeries. And finally, not least, is Dr. Nikita, who is a fellowship-trained hand surgeon, and she is also going to be delivering and showing you a couple of videos today. A little bit about Bombay Orthopedic Society. I'm sure most of you have had some interaction with the Bombay Orthopedic Society over the course of your career. The Bombay Orthopedic Society in 2025 is celebrating its Diamond Jubilee, its 60th years of existence, 6 decades of excellence in clinical work, in academic work, in teaching, and in research. It's not going forward. So, the Bombay Orthopedic Society began in 1965, and over the years, 60 years, These are some prominent surgeons from Bombay who have shown and taken Bombay Orthopaedic Society to the heights that we have reached today. It is on the basis of this legacy and on the shoulders of these greats that we climb and continue to do well. It's not moving forward. So how did it all begin? The first orthopedic surgeon, one of the first ones in India, was Dr. R.J. Katrak. He was trained in the UK and came back with an FRCS. He established the first orthopedic unit, which was a pediatric orthopedic unit, at the Wadia Children's Hospital in Mumbai. This was way back in 1936. Later, in 1942, he developed the first academic orthopedic teaching unit at the KEM Hospital in Mumbai. From 1965 onwards was the time when the Bombay Orthopaedic Society was established to promote academic excellence and collaboration. It was the first orthopedic association in India. It predates the establishment of the Indian Orthopaedic Association. R.J. Katrak was the first president of this society. In its early years, Bombay Orthopaedic Society used to have bi-monthly clinical meetings. There used to be a lecture program which was held once in 6 months over a period of 3 days. And then in 1966, we started with VIROC. Over the next 3-4 decades, we saw rapid growth. The membership increased. And today we boast of almost 3,500 members. We have a clinical meeting where we discuss interactively cases, and we have a master series CME on a monthly basis. BOS runs a variety of basic courses. At one time, BOS used to run 27 different courses across the year. And people from all over India, from the Middle East, from the neighboring countries, and from Africa have joined us on our courses. We also run a monthly or bi-monthly postgraduate teaching program which is headed by Dr. Karkhanis, and he has been which is a legacy of our famous professor Dr. J.C. Tarapurwala. Bombay Orthopaedic Society also runs a variety of fellowships and observerships. Presently, we have 3 fellowships which are running. One is on joint replacement, one is on pediatric orthopedics, and one is on spine. If any person from all over India is interested in applying for these observerships or fellowships, please reach out to us through the Bombay Orthopaedic Society website. And finally, our premier event is VIROC, which is attended by almost 1,700 surgeons. The Bombay Orthopaedic Society journal comes out once in 6 months, and it is an index journal, and it is something which is worth reading because there are a lot of good symposia and good articles which are worth following. Dr. Harshad Argekar has developed what we call as the Protocols app. It is through this app that you can get consents for various surgical procedures. These can be downloaded and you can actually use these consents to take consent from your patients. Our research consists of some fantastic work on osteoarticular tuberculosis. The programs were headed by Dr. Vikas Agashe, and these papers have been published in various reputed journals. So where do we stand today? Today, Bombay Orthopaedic Society is an academic powerhouse. Directly or indirectly, we have probably influenced more than 1/4 of all practicing orthopedic surgeons across the country. Our legacy has been very strong, but with youngsters whom you will see presenting today, our future is even stronger. We have innovated. We have always taken pride in our ability to spread the message by educating people. We have collaborated with various associations in India and across the globe, and our goal has always been to elevate orthopedic care. In our 60th year, I have this vision that we should do something more for the orthopedic community. And therefore, we've started a program called as BOS Worldwide, where We hope to build bridges with associations and collaborate with societies across India and across the world, with the goal of sharing knowledge, sharing expertise and experience. The first of which is what is called as a worldwide webinar. This webinar is held once a month. It is an interactive case-based session directed primarily at the general orthopedic surgeon, and it is basically specialty wise. I would encourage you to follow us on the Bombay Orthopaedic Society website to get details of the webinar, and I'm sure you will benefit from these webinars. I'll give you a little bit more about the webinars incoming. The outreach program is a program where Bombay Orthopaedic Society sends its faculty to different second and third tier cities across our country. Last month, we had a session for postgraduate orthopedic surgeons followed by pediatric trauma in Aurangabad. This month, earlier, we were supposed to do a session on musculoskeletal infections in Bhubaneswar, which got cancelled because of the tensions we had with Pakistan. In June, we are going to Vapi to conduct a upper limb and lower limb, it's only an upper extremity surgery program. So we also are going to do these real-life spine surgery programs. This is what we are doing today. The hand surgery program. Similarly, there are going to be 3 more live surgery programs through the year. One is on shoulder and elbow surgery, one is on pediatric orthopedics, and the final one will be on ankle and foot surgery. All these will be available on the net, and if you just follow the Bombay Orthopaedic Society website, you will come across all these programs. In December at VIROC, we are releasing 6 monographs, which are specifically focus books on specific topics in orthopedics like tibial condyle fractures. We've got a monograph on giant cell tumor of bone. We have got a monograph on management of pediatric elbow fractures, on failed fixations, non-union and malunion, both in the upper limb and lower limb. These will be released at VIROC 2025. So do come to VIROC. You may actually get a gift of some free monographs. The clinical meeting is held once a month. The next clinical meeting is going to be on the 1st of June at the Bombay Hospital in Mumbai. The master series, the next master series is going to be on Sunday, the 6th of July. And here we are going to talk about failures of fixation in the upper limb and salvage of these failures. Another master series program later in the year is going to be at KEM Hospital, where we are going to discuss lower limb failures. The next worldwide webinar, as I said earlier, is on 8th of June at 2:30 in the afternoon. You will get the link from the BOS website for all those around India. In collaboration with the Asia Ankle Foot Society, we are going to discuss the management of common foot injuries on a case-based basis. As I said earlier, that we are going to have an outreach program in Vapi in June. The live pediatric orthopedic surgery symposium is going to be on November 9th at the Thane Hospital in Bombay, and we will be showing at least 10 recorded live surgeries of common pediatric operations. The live shoulder and elbow surgery symposium is going to be in January 18th. Finally, some courses. We just are running through our BOS basic. So in the past, our courses have been 2 or 3 days. But now we have introduced the concept of a 7-day course. The goal is that the person who attends the course should go back feeling that he is now confident of dealing with hand problems in his practice. Currently, we are running a 7-day course where delegates are going to be given lectures, interactive case-based sessions. They are attending this live surgery program. They are going to do sawbone workshops, cadaver workshops, and finally, they will be actually going to the operation theaters of leading hand surgeons to assist in these surgeries. Some of the other courses we have across the year are the arthroplasty course, the arthroscopy course. Delegates from all across India are welcome to attend these courses, upgrade their skills, develop an interest in subspecialty orthopedics. So this is a list of some of the courses we have which are still to be going. Please register for these courses because these are personalized courses. There are hardly 20 seats on each course. So if you want to attend these courses, you have to register early. The seats get filled up fast. Finally, coming to VIROC 2025. The VIROC is the crown jewel of the Bombay Orthopaedic Society. This year, VIROC is going to be from December 25 to 28. The main conference being on 26, 27, 28. Whereas the pre-conference workshops are going to be on 25. All details about VIROC are available on the Bombay Orthopaedic Society website or if you Google VIROC 2025. I encourage delegates from all across our great nation to register as soon as possible for VIROC 2025. To conclude, the Bombay Orthopaedic Society has a great legacy. A legacy of excellence in orthopedic education. We have a vision for continuing progress and continuing innovation. We invite orthopedic surgeons from all over India to join us to shape the future of orthopedics and improve outcomes for all our patients. Finally, I would be remiss if I did not acknowledge the fantastic help from Intas Aquila, the makers of Gabapen NT, makers of Goodrill, Baclo, Spin Free. So a lot of drugs, they have played a phenomenal role in helping the spread of education through the Bombay Orthopaedic Society. And before I end, I would like to also give a big thanks to the people who are helping us telecast these programs, such as OrthoTV, Mr. Ivan and his audiovisual team, and a special thanks to Jupiter Hospital in Bombay, where this program is being held, and they have made some phenomenal arrangements. Without much further ado, I've taken up a lot of time. I'm going to hand over the mic to the convener of this program, Dr. Parag Lad, and best of luck, Parag. I hope that this program goes very well.
Thank you so much, sir. Without wasting time, now there is a small change. We are going to take the second session first. I invite Dr. Heman Patankar, sir, and Dr. Kiran Ladkat, who will be moderating these sessions. Anybody who wants to ask the question, please feel free to ask the question. Dr. Kiran and Dr. Heman, sir, please come on the stage. And here I invite Dr. Nikita Shetty to present her first video about D. Karwan's release.
A very good morning, everyone. So I have pre-recorded my narration in the video. So I'm going to let the video play, and if anybody wants me to elaborate on any step, please feel free to stop me in between. I'll take questions in the end, but elaboration of the steps, yes, I can do it in between if you like. Thank you.
So while Dr. Nikita's video starts playing, just for the people who are watching us online, the first part will be that the speaker will introduce the case, talk to us about what is the patient's problem, what is the surgery he or she is planning, and what will be the challenges during the surgery. Then the surgery will be played, during which time the speaker herself or himself will stop wherever they feel they need to exaggerate a little bit and go on. At the end of the presentation, we will then open house for questions from our audiences as well as from other centers across the country. In each of the individual centers, the questions can only be asked by the moderator. The individual panelists will send their questions to the moderator. I would request the moderator to say that I am XYZ from Jalandhar. I have a question from Dr. So-and-so. The question is, so we need you to identify where you are from and who the question is from. Thank you very much.
Sorry for interrupt. Hello, sorry for interrupt. Your voice is echoing. Zaveri sir.
Hello everyone, I am Dr.
Okay. So I think every practicing every orthopedic surgeon, even practicing residents, have come across this condition not once but multiple times, called the decurrent stenosynovitis. So it is basically characterized by severe pain on the radius.
I will stop the voice from the laptop. Only her voice.
Severe pain on the radial side of the wrist, especially near the radial styloid. That is exactly where the first extensor compartment is. So this condition is basically characterized by thickening of the first extensor compartment sheath or stenosynovitis of the first extensor compartment, which consists of the abductor pollicis longus tendon and the extensor pollicis brevis tendon. So most of the times, both these tendons are in the same sheath, but various cadaveric studies nowadays have shown that 70% of individuals have a subsheath within this compartment. That means the extensor pollicis brevis can be in a separate sheath. So one of the cares that we need to take during surgery is to identify the sheath and release this sheath. Otherwise, the patient is going to continue with symptoms. So I'm going to show one such case.
Nikita Shetty and I will be guiding you through the steps of a decurrence release surgery in this video. Before administering local anesthesia, the correct side and surgical site are first confirmed. The radial styloid is first palpated
Echoing. Okay, so what I said here is, can you mute that please?
I think Nikita.
Yeah, I asked them to. I asked them to mute it. Just mute kar do usko. So these surgeries are most of the times performed under local anesthesia. We do have an anesthetist on standby in case the patient needs sedation. If they get uncomfortable with the tourniquet, these surgeries are done under tourniquet, so always have an anesthetist, because sometimes the patients do not tolerate the tourniquet and can get restless, which will make it difficult to operate on the patient. So before we start or before we administer local anesthesia, we check for the side and site of complaints. Because you have seen the patient in the OR, before that you have seen the patient in the OPD. Resident ne patient shift kar diya, staff ne patient shift kar diya, they've prepared the side. Always check the side before surgery because the patient is awake. Be sure that it's exactly what you're going to operate. Then next, the incision is marked, so we palpate for the radial styloid, and just distal to it is where the first extensor compartment lies. The incision is a transverse incision. We then inject the local anesthesia. I usually prefer a mix of 2% lignocaine and 0.5 anabin, 55 cc of each. And use a very thin needle, that's a 25 or 26 gauge needle. That's best because bigger needles can be really painful for the patient. So that incision is a transverse incision. Once the skin and subcutaneous tissue is incised, the assistant retracts the skin with a skin hook, and the next important step here, before we go forward, is to identify the superficial branch of the radial nerve, which courses very closely to the first extensor compartment. It's a very thin nerve, courses on either side of this incision, so make sure that you identify it and ask the assistant to retract it and keep it protected throughout the procedure, because any injury to this nerve can give a lot of trouble to the patient and to the surgeon later. So once that is done, right in the midline of this incision, the transverse structure that you can see is the first extensor compartment sheath. So once that is identified, we slowly dissect it with a good mosquito forceps, and we identify the junction between the extensor sheath and the tendons of the first compartment and start incising from that. So when you start incising, make sure that you're incising in line with the extensor tendon so that you avoid inadvertently injuring the extensor tendon. And making sure that the superficial branch of the radial nerve is under your assistance retractor at all times. All the dissection is done under complete vision, no blind dissection. So like you can see, the assistant has pulled both the retractors upward so that the entire sheath is seen and dissected. So the dissection, the sheath needs to be cut only till you can see the scissors, not beyond that. Now next, the septum that I was talking about. The structure on the left side is the abductor pollicis longus that the assistant has retracted. Can you see a tendon there on the right side? Yes or no? Yeah. So there is a thin sheath right on top of that. You see the tendon is completely separated from the abductor pollicis longus. That is the EPB, which is lying in a separate sheath. So I always prefer getting a sonography beforehand, which can help us with surgical planning. It can tell us if there is a subsheath. Even if you don't have a sonography, make sure that you're identifying the abductor pollicis longus and the EPB and see both of them are free and the EPB is not in a subsheath. You release the sheath, because without doing that, the symptoms might not go away even post-operatively. The patients will continue with symptoms of decurrence. Next, we carefully retract the extensor tendons and remove a small portion of the thickened sheath from either side to debulk this compartment. So that's what we're doing. Again, making sure that the superficial branch of the radial nerve is protected. That's the thickened sheath from one side. Usually these sheets are 1 to 2 paper thicks, but when in such cases, they can get as thick as 9 to 10 paper thicks. That's the sheath on the other side. Again, retracting the tendon to one side, so making sure that the assistant is carefully retracting the tendon as well as the superficial branch of the radial nerve. Now next is to confirm if we have released both tendons and to confirm the excursion of these tendons. So first, all the slips of the abductor pollicis longus are identified. This tendon can have multiple slips, so make sure that you've identified all the slips. Separate it and hold it up with a mosquito forceps. And then you pull on this tendon. So what you can see, the action of the abductor pollicis longus is to abduct and extend the CMC joint. So nothing is happening to the MP joint or the IP joint. So this is how you confirm that it is the abductor pollicis longus. And next, dorsal to it is the extensor pollicis brevis. So when I'm pulling on it, you can see the MP joint that is extending. So that is how you confirm that that is the extensor pollicis brevis. The skin is usually sutured with 4-0 absorbable sutures. I prefer Vicryl Rapid. After the dressing, the patient is put in a thumb spica slab. Is a functional position of the thumb, that is a little bit of abduction and opposition. The thumb from the volar side and all the fingers are kept free so that the patient can mobilize the thumb and fingers immediately post-op, which is very important to avoid any kind of stiffness and can affect the functional outcome later. Thank you.
Dr. Pankaj Aire has a question. Go ahead.
Thank you, Nikita. That was a wonderful presentation, a lovely video, I think. Can you tell us a brief history of this patient? What was the patient's problem and what did she come with?
So this lady was a 50-something old patient. She had come initially with pain on the radial side of the wrist. On examination, there was tenderness over the radial styloid. That is where the first extensor compartment is, where I mentioned. The second test that you do is the Finkelstein's test, that where you keep the thumb inside the fist, ask the patient to close the fist, and then radially deviate it. So this gives a lot of pain. And the third test that we do is the Watts test, where the patient is asked to flex the wrist and hyperextend the thumb. This test, a lot of times, is indicative of a separate sheath of the EPB. So this is one more test, and of course, we supplement it with ultrasonography. A well-done ultrasonography can help with it. When the patient comes to us and has not taken any treatment at all, the first line of treatment would always be anti-inflammatories. We ask the patient to do stretches in warm water. A lot of times, patients do get relief with this. The second line would be, sometimes I would consider a local steroid injection, but I would avoid it in patients who are diabetic with uncontrolled sugars, patients with inflammatory conditions like rheumatoid arthritis, because the tendons are already not very good. So steroids can eat up the tendon, cause adhesion ruptures, and we have seen that happening.
Nikita, today I am a spine surgeon, don't do this, but when I was a resident and I used to do these kind of surgeries, all that we were taught was take a transverse incision, go down, cut the superficial extensor compartment sheath, and come out. In your surgery, you've done far more than what was taught to us. Can you explain to us the importance of why we need to go so much more than what we used to do previously?
So the most important reason here is right under the skin, like everyone saw, the superficial branch of the radial nerve comes. It's a very thin structure. Sometimes in some patients, it's really, really thin. You need to identify it and retract it. Injury to this nerve can give rise to a neuroma that can be extremely painful for the patient and later becomes difficult for the surgeon to handle. So that is one of the most important things. And the second thing that I showed was we de-roof the compartment. Because once you open the compartment, there's still this thick sheath that is right there which can irritate the tendons. So we prefer to de-roof it so that we are sure that the whole thing has debulked.
And when you do these surgeries, can you decide pre-operatively, clinically? I believe you said you do an pre-operative ultrasound. But clinically, whether this is just a thickening of the tendon sheath with a nodule, or is there an element of tenosynovitis which has to be dealt with also during the surgery?
Yeah, a lot of times swelling is one of the indications. Some patients come with a lot of swelling. But in that case, I prefer to get an ultrasound is because then I can plan my incision. A lot of times if there's lots of tenosynovitis and I need to go in and clear the inflammatory synovium, I would take a vertical incision, maybe a longer vertical incision, so that I can have access to the entire tendon so that I can clear it out. Otherwise, routinely, with no tenosynovitis or little tenosynovitis, a transverse incision is something
We'll
that I
now
prefer.
open the questions to the house. Anybody in Bombay? Any questions? Yeah, Dr. Ahire.
Nice video, Nikita. Two questions. Why is there a necessity to take off part of the pulley, which I have never done? Two, why is it necessary to put a plaster post-operatively, especially when the patient is not under a proximal block and is only under general local anesthesia? Again, something which I have never done.
Thank you, sir. So to answer your first question, why take off a part of the sheath? Like I said, the sheath is, like you saw in this patient, it was really thick. So by taking off the sheath, we're making sure that the whole compartment is debulked. Secondly, I was probably trained to do that from the beginning, but debulking the first compartment is the whole aim. But I'm sure, like you said, you don't release them, and no patients have come back with any complaints so far.
Okay, Nick.
And yeah, to answer the second question, why the plaster is, see, the surgery is usually done under local anesthesia, so till the anesthesia is there, the patient feels like Superman कि मैं सब कर सकता हूँ. Thumb move कर सकता हूँ, fingers move कर सकता हूँ. A lot of times, lot of patients, when they have pain, the position of the wrist and the hand is not the most favorable. They tend to keep the hand like this because it's painful. They keep it away, they keep the wrist flexed, thumb is not in a good position. So we make sure that immediately after the surgery, when the breakthrough pain comes on, the patient is comfortable and in a functional position and can use the hand for most of his activities. These slabs we usually keep for 4 days till the first dressing. The patient is usually comfortable till the first dressing. They know that, yeah, they can move the thumb, they can move the fingers. We take off the slab, give the patient a very small dressing on the 4th day.
Okay. Dr. Nikita, can you tell us in brief, if accidentally I injure a superficial radial nerve, then how do I repair it, or should I leave it or bury it somewhere, or how do I manage it?
No, if you've seen that you've injured it, it's a clean-cut injury, then I would go ahead and repair it.
With what suture material?
I would use a 80 ethylon for that. It's a very thin nerve, so a 80 ethylon I think would be a good choice. And if you have a microscope in the hospital, or most hand surgeons these days have loops with them, so it has become easier for us to repair these nerves.
Okay.
We'll now open the questions to our online people. Any questions anywhere else, moderators,
Zoom. Yeah.
on our Zoom
Doctor,
connection?
I mean, doctor from Sangli wants to ask a question.
Yes, Sangli. Can you repeat the question, please, doctor?
Yeah, it is not uncommon to find an aberrant tendon in that compartment. So how do they deal with that?
That's a very nice question. So, Nikita, how would you deal with an aberrant tendon which is crowding the tendon sheath over the compartment?
So far, I have not come across where, it is crowding it so much that the symptoms have not gone away. So usually when we come across an aberrant tendon, if the sheath is open and if there's enough space for the tendon, we just leave it alone most of the times. A lot of times APL can have a lot of slips, but then so far I haven't had to do anything and the patients haven't complained after the surgery.
Thank you.
Yeah, Dr. Dhingra from Jalandhar wants to ask a question.
Yes, Dr. Dhingra, please go ahead.
Yeah, the question from Dr. Varun, that while you're cutting the tendon sheath, won't it make the strength weak of the tendon and the working later on?
Not really weaken the tendon more, but a lot of times it has seen that the tendon can slip volarly or subluxate volarly. That is why when we take off the sheath, we don't take off the whole thing, just a part of it. So we make sure that a little bit of it on the volar side is left behind, because many times there has been seen that the tendons can subluxate volarly. But weakening the tendon, the patients have gone back to doing everything that they were doing before they had symptoms. So.
Yeah, Dr. Karthik from Coimbatore, please ask the question.
Two questions. One from Dr. Mugundan. Why not a vertical incision as a routine?
Why not a vertical incision as a routine is because when you take a transverse incision, it's easier to see on both sides. So like I mentioned, we need to identify the superficial branch of the radial nerve. So it's easier to pull the skins on each side. There's a nice transverse incision. It's easier to look at the superficial branches of the radial nerve. In a vertical incision, even after you identify this, the assistant sometimes has to retract a little too forcefully for you to see the whole thing, which can actually cause pressure on the superficial branch of the radial nerve. So until and unless I have to go in and do an extensive tenosynovectomy, I would always prefer a transverse incision. And the skin here is quite mobile.
Second
Dr.
question
Parag,
is,
I'm Ajit from Kanpur.
Yes, Dr. Ajit, we are hearing you.
Yeah, so hi Nikita, hi.
Hi.
Hello. So my question to Nikita is that there are people asking that, have you encountered the volar subluxation of extensor tendon after, because we are seeing your video that you have completely excised the whole sheath. Have you encountered in your practice that the subluxation of extensor tendon on the volar side?
Not so far. Not so far. Like I said, a part of the extensor sheath is excised, not the whole thing. There's still a small thin sliver of it remaining on the volar side. So I have not come across any volar subluxation so far, but yes, I have heard of them.
So any particular precaution you take while taking out that sheath?
Yeah, so
the
you,
bulk of the mass.
any particular precaution? Yes, we clear out all the soft tissue that is there on top, because there can be very small branches, nerve endings that can be coming on the soft tissue. So make sure you're removing only the sheath, the thin films of soft tissue that is there on the sheath. Make sure you're clearing that out so that you're not cutting anything else but the sheath.
Okay, Dr. Joshi from Solapur, and then we will move on to next video.
Yes, Dr. Joshi.
Sir, if I can ask one more question. I've had one patient who had an injury of the superficial radial nerve and developed severe CRPS, like some allodynia and severe pain after the surgery. Have you seen such case and how do you deal with them?
Yes, I have seen one such case where the patient had come from elsewhere, had a vertical incision, the superficial branch of the radial nerve was injured. It was a young girl. In that case, because it was not too many days from the primary surgery, we did a sonography, saw where both the ends are. It looked like we could primarily repair it. We repaired it and then we covered it with a vein graft. So that protects that area, and symptoms of nerve irritation is something that subsides there.
Last question from Dr. Joshi from Sholapur.
From Patna also, sir, we want to ask a question.
Sure, sure.
माइक बंद है सर, माइक बंद है.
No, we can't hear you, Dr. Joshi. Clearly. Hold the mic to your... I can see my friends, Dr. Shankar, Shiv Shankar, Dr. Kotradia. Welcome, sir.
Sir, you are mute.
Sir, I'm from Patna, Dr. Ritesh.
Yes, Dr. Ritesh, please to ask.
We have a question from Dr. Yoga Ranjan to Dr. Nikita, that what is the risk of recurrence after release in these cases? And due to retraction of radial nerve, is there any pain the patient feels after the operation?
Risk of recurrence, again, like I said, once you de-roof the entire sheath, usually these conditions do not recur, but like Dr. Pankaj said, he does not de-roof the sheath and still they haven't recurred. So risk of recurrence is very low. Second is the retraction of the superficial branch. So yes, when the assistant is retracting it, again, like I said, a transverse incision. If you take a vertical incision, the assistant has to retract it quite a lot because he doesn't know where it is. He has to open the whole incision for you to see the first compartment. When it's a transverse incision, very lightly the superficial branch of the radial nerve is retracted. It's not pulled, it's right under the retractor. So you know where it is. You know it is under your assistant's retractor. He doesn't really need to pull it. And because it's a transverse incision, you can see the whole sheath properly.
Thank you, Nikita. That was a last question.
Yeah.
We have Dr. Hemant Patel.
Yeah, can I say the recurrence, so-called recurrences are because we have seen many times resurgeries which we do. The recurrences are because the primary surgery has been done without a tourniquet. And the EPB tendon is invariably missed to be in a separate sheath. So that is the primary cause of recurrence in most of the cases. Or else incomplete surgery done, and mainly it is because of the attraction of doing this surgery under local anesthesia without giving any sedation for the tourniquet. So then the recurrence occurs. Replying to the previous question, why not a vertical incision? In my opinion, vertical incision gives a very horrible scar, and that most of the people will appreciate your good scar also at the end of the surgery. So that's why I also go for a transverse incision.
Right. Any further questions?
One question from Calicut, sir. Hello?
Yes, sir. Please tell me.
Any differential diagnosis you have to keep in mind before you put the knife? Any differential diagnosis?
Decurrent tenosynovitis is pretty clear on clinical examination, but that other differential diagnosis would be only tenosynovitis of the tendons, any kind of growth in the first compartment sheath which can cause compression or, of these tendons within the sheath. Dr. Patankar wants to add something.
Yeah, to add to that, I always take an X-ray. If the patient has consented for surgery, I always take an X-ray of the wrist, AP, PA and lateral view to make sure that there is no roughening of the distal end of the radius or at the level of the styloid. So if necessary, you can take an osteotome or a nibbler and just smoothen out the radial styloid in these cases. I have done it about 1 in 10 cases we require to do it.
Right.
I usually get a sonography, and thankfully we have a very good sonologist. So if there's anything like that, he will definitely report it and we can operate.
Thank you, Nikita, for this very nice video and an excellent presentation. We will,
One last one, sir.
sir, absolutely the last question from Dr. Dingra.
Yes, it's a question from Dr. Vijaypal Singh.
Yes.
Sir, he said, what are the responders with the steroid? Like, in how many cases actually end up with the surgery, and how many people generally respond with steroid injections?
The first compartment tendons, when they're usually in the single sheath, they respond better to steroid injection. And like I mentioned, people with a sub-sheath or a separate sheath, they don't respond that well. But if the patient insists, we still give them a steroid injection, but that we do. If it's in a separate sheath, we do it under sonography, which is much more targeted. A lot of patients do get relief with that, but patients with a separate, with a intra-compartment septum usually come back with recurrence of the symptoms, and we have to go in and do so, operate on them. But people who have a single sheath, they get good relief with steroid injections too.
Dr. Joshi from Sholapur was trying to ask a question earlier, but the audio was not going through. His question is that for tubercular synovitis in this compartment, have you seen that? And is it something you have dealt with, or any of the other faculty has dealt with tubercular synovitis causing a decurvance?
We have seen rheumatoid tuberculosis synovitis causing this. For that, the diagnosis is totally different. It's a different condition altogether, as confirmed by clinical examination and sonography. So you take a formal zigzag incision or a vertical incision and explore the whole compartment and do the needful and send the material for biopsy.
Lovely. Thank you very much, Nikita. Wonderful. You look a little tired now. So I'm going to let you go.
Gautam, I just want to make one small comment.
Nobody can speak.
I think we should stop calling it tenosynovitis. It's a tenovaginitis. It's the inflammation of the reticular system, which behaves very differently from a tenosynovitis. When we have tenosynovitis, then yes, inflammatory, infective, and all those things come in the picture, and the treatment can be completely medical for tenosynovitis. It's a tenosynovitis which responds very well to injections. Once it is a mechanical problem of fibrosis and a tenovaginitis, that generally does not respond to the steroid.
It is a proper suggestion. The only problem is that the insurance guys will raise an objection why you are doing gynec cases.
Yeah, meanwhile, Dr. Pankaj comes from the stage to answer about tubercular synovitis versus decurvant synovitis. The Finkelstein test is not so significantly positive in tubercular synovitis, and the size of the swelling around the radial styloid region is extensive and large. So that is how we distinguish between the two.
So to move further, we have Dr. Pankaj Zaveri from Mumbai speaking on flexor tendon repair and in zone 2. Dr. Pankaj Zaveri is a hand surgeon from Mumbai practicing in Godrej Memorial Hospital.
Good
So
morning,
Pankaj,
everyone.
go ahead.
Yeah. Disclaimer, flexor tendon repair, especially in zone 2, is one of the most uncommon surgeries that I have done. Okay, if I list the 100 surgeries that I have done, this will probably rank the 100th. But I can be a messenger of somebody who has done it very, very well till now. I will take you, yeah. Are we good? Yeah, thank you. So I'm going to take you through what a good flexor tendon repair should be, and then I'll show you a video of a good flexor tendon repair. An ideal flexor tendon repair, since a flexor tendon is a very, very sophisticated mechanical unit, it needs two things: good gliding surface and strength to move the joint that it has to. So a smooth surface a definition of smooth surfaces, there should not be bunching at the repair site so that the flexor tendon does not get stuck in any of the flexor pulley system. And strength, how strong? Strong to withstand the forces for early mobilization. Now, why early mobilization? If flexor tendon is going to heal, it is not only the tendon is going to heal to the tendon, but the tendon is also going to heal to the surrounding tissues. And it is said that there is no effective way of avoiding adhesions. Adhesions will form no matter what you do. Volumes and volumes have been written on, ways to avoid adhesions after flexor tendon injury and repair. None having any conclusion as to what can prevent adhesions. Finally, the conclusion and the consensus is adhesions will form. You just have to make sure that the adhesions that form are not short adhesions, but they are long adhesions permitting adequate movement. And if you want the adhesions to form long, which will permit full movement, then you have to start moving early. And if you have to move early, you cannot depend on the strength of the flexor healing, but you need to depend on the strength of the repair. And therefore, the repair needs to be strong. So, the ideal tendon repair, as I said, should be smooth, and one of the ways to make it smooth is an epitendinous suture. Epitendinous suture should preferably be done with a monofilament suture, and it needs to be the thinnest material that you can handle. Typically, 5-0 or 6-0 monofilament, either a Prolene or Ethilon, works quite well. A core suture needs to, as I said, it should be strong, and a braided suture like Ethibond or a fiber wire. I'm sorry I'm taking trade names, but I think we are most familiar with these trade names. Either a fiber wire or a Ethibond works best. So as I said, the strength of the repair will depend on 4 factors: the quality of the end of the tendons. If the tendons are frayed, even a good core suture is not going to give you enough strength to move the tendon early. The way you put the core suture, whether it is 2 strands, 4 strands or 6 strands, addition of epitendinous sutures, and the material properties of the suture material itself, Ethibond being most ideal, fiber wire being the strongest. So the core sutures, the most ideal flexor tendon repair is a 4-strand repair with a 3-0 or a 4-0 braided suture. And it has 2 properties. The purchase. Purchase is the length through which your suture is traveling from the end of the tendon. In an adult flexor tendon in the digit, the ideal purchase is around 1 centimeter. So from the tendon end till the length that you travel in the tendon substance, it should be around 1 centimeter. Not always possible, because you are dealing with pulley systems as well. And when you are locking the suture, once you have taken the longitudinal bite, then you are taking a horizontal bite. The amount of suture that you see outside, or the amount of tendon that you grasp by this locking, should be around 2 millimeters. When you achieve that, you are likely to get a strong enough core suture for early mobilization. Epitendinous suture, as I said, 5-0 or 6-0 monofilament, and it adds about 20% to the strength of the repair. So this is a video by my mentor, Dr. S. Rajasabhabati. He's a hand surgeon par excellence. And he has kindly consented to share this video with all of you, so I will gladly share this with you. This is a mid-20s lady who injured her flexor tendon of the middle finger about 3 weeks ago. And she could not bend her DIP joint, but the FDS was intact. You can see that dotted line is the original wound which has healed in about 3 weeks' time. So when the wound has healed, you don't have to open the original wound. The exposure is by Brunner's incision. The Brunner's incision, the principle is do not cross any of the creases at right angles. It can be a combination of a bilateral incision and oblique incision going from one crease across to the other side. The digital neurovascular needs to be kept on the side that you start dissecting with and expose the pulley structure. The skin flap typically separates very easily from the pulley structure. Once the pulley is open distally, you can see that the distal end of the flexor tendon is very easily available. However, the proximal end has retracted because it is attached to a motor unit. Typically, the FDP will not retract beyond the palm because of the lumbrical attachment. So you are likely to find it mid-palm. Now, it's useful to do a sonography to ascertain where these tendon edges are. Near the A1 pulley, you will find the FDP. You can try and push it through the pulley system, but try and inflict as less damage to the pulley system as possible. Every damage that you inflict is going to lead to more adhesions. And therefore, instead of trying to pull through too much through the pulley system, you can do what is called as railroading. You can insert an infant feeding tube from distal to proximal. That is what will be done now. And then you can suture the distal end of the proximal part to the infant feeding tube and pull it into the incision site. So there it is sutured and then it is pulled here. Once it is pulled, you have to do minimal handling of the end of the tendon. Once it is grasped, you have to keep it held there instead of making multiple attempts to grasp it. You can fix the tendon with a hypodermic needle to the surrounding skin and have two ends of the tendons nicely in contact with each other, much like how you would repair a nerve or a vessel without tension. Do minimal sacrifice of the end of the tendon to get a fresh tendon edge. In a fresh injury, this is not necessary unless the ends are frayed. There are two ways from here on. You can either do a epitendinous suture first or a core suture first. In this case, the epitendinous suture is being done first using a 6-0 proline. In this, a running suture is placed on the back wall of the tendon. This can very well be done after placing the core suture as well, as long as there is enough place for the tendon to be flipped to see the front and back of the tendon, which may not always be the case in the fingers. It's very easy to do it in the forearm or the palm. And therefore, doing the back wall of with the epitendinous suture is a better idea. As you can see, it is a continuous suture. It may or may not be locked. Another thing that you need to notice is very minimal handling of the tendon edges. Now the back wall is done. You can flip and see how smooth the back wall is. Now the smoother the outer surface of the tendon you get, the less is the chance of adhesions. Then this is a 4-0 ethibond. That is the purchase, around a centimeter. And that is the grasp, which is about 2 millimeters. A centimeter of purchase and a couple of millimeters of grasp will give you enough strength for this tendon to be mobilized soon. So this is what we know as the modified Kessler suture. I actually do not know what is a Kessler suture. only know what is a modified Kessler suture. If somebody knows, can share it later. I never bothered to read about it. So that's again a purchase. And a grasp. Now the world is divided how tight you should suture this. Whether you should, there are proponents who say you should allow little bit of bunching of the tendon when you have tightened your core suture, saying that when you mobilize this tendon later, some degree of stretching is going to happen, and that bunching will actually straighten out. Whereas there are proponents who say no bunching should be allowed at all, so that the tendon can glide freely through the pulley system. In this case, you will see there is zero bunching that is permitted. Knot gets buried inside the tendon. And now a second core suture is being passed. So it becomes a 4-strand repair. A 4-0 4-strand repair is considered to be ideal for a flexor tendon in the finger. The more the number of strands, you can do a 6-strand or a 8-strand, but then the thickness of the suture material necessarily has to go down. So the optimum becomes a 4-0 suture with 4 strands. So that's a grasp again. So that's a second core suture that is completed.
Dr. Pankaj?
Yes.
So can you wait? So this is the difference between Kessler technique and modified Kessler technique. The knot is inside the tendon in modified Kessler. In original Kessler, it is outside on the sides of the tendon.
I'm so happy I never read about the original Kessler. For that one reason. Thank
because
you.
the knot used to irritate the digital nerve. So then they modified it and...
Perfect. Thank you, Parag. And now you take the remnant of your epitendinous suture, okay, to the front wall, and that completes your epitendinous repair. What is depicted in the video is almost an ideal, not almost, I think it is an ideal flexor tendon repair. The A2 and the A4 pulleys have been left untouched, and now it is ready for early mobilization. I'm happy to take any questions.
I would immediately, what a wonderful presentation, Parag, Pankaj. I think very clear, not only in the demonstration of the case, but the prelude to it which you gave us about what to suture to use, how much, where to come out was extremely useful and important. And this principle, though you showed it for the zone 2, I'm sure applies also for zone 1 injuries.
Zone 1 is a bit, actually this was a zone 1 injury, not zone 2, but yes, it applies everywhere. Yeah. As we go more distal in zone 1, the principles do change a little bit, yes, but wherever you have a cylindrical tendon to a cylindrical tendon anywhere in the body, this principle applies.
Any questions from the house over here? Yes, questions, not comments. Yeah.
Bipin, be kind.
Yes, sir. So I want to know how was the pulley vented here? No.
Yes, to some extent, the A2 pulley was partly vented and it was more dilated than vented.
So how much venting would you accept?
If I have to do it, I would vent as much as I want, but not complete. I will just stop short of complete. Okay. So even if I have to release 70% of the pulley, I would do it.
So would you release the complete A4 pulley and reconstruct it in case there is a...
No, I would not. I would not reconstruct, completely release and reconstruct, no.
Pankaj, can you elaborate what do you mean by the word vented?
Venting is partial release of a pulley in order to gain access to a flexor tendon, one, or in order to allow a slightly bunched up repair to travel through.
Right.
These are the two purposes why we would vent a pulley. There are different ways of venting a pulley. You can simply divide it at longitudinally at one edge or in the center, or you can do reciprocal flaps. One flap opening like this and the other flap opening like this, and at the end of your repair you just suture the end of the flaps, recreating the pulley.
Any more questions from the house over here before we move online?
So there is a question from from Haldwani region. What is your post-op protocol?
No, let them ask themselves. Let's move to Haldwani. Are you online with us? Can you ask your question, please?
Yes, sir. How many days plaster and other rehab protocols?
What is your post-operative protocol, Pankaj?
Yeah. My go-to protocol for last more than 2 decades has been the Kleinert protocol. Though I do not use the conventional Kleinert traction system of rubber band and hooks, initially the hand is kept with wrist neutral and MCP and IP joints flexed, thereby making sure that the tendon is completely relaxed. In this position, a passive flexion is allowed. Okay, the patient is allowed to passively flex the fingers and actively extend it. So it is passive flexion and active extension. This continues for 3 weeks with gradual straightening of the MCP and the IP joints. At the end of 3 weeks, this changes to place and hold. That is, wherever the finger is placed, the person is asked to hold, and from that position again, passive extension is allowed. Active flexion is allowed only at the end of 4 weeks. Your tendon repair is at its weakest at around 3 weeks. That's when the phagocytotic activity is at its maximum. Till that time, no active flexion is allowed. At the end of 4 weeks, the person is ready to do active flexion and passive extension, but there is no power grasp that is allowed. Once the person achieves a near complete range of motion, which should be at around 6 weeks, then the strengthening exercises are allowed. Now, there is a difference between a stretch that the flexor tendon feels during active extension and the stretch that the repair feels during active flexion. And that difference is what this protocol is based on. If time permits, I'll explain that. So whenever there is an active extension, whenever there is an active flexion, the muscle tendon unit, the proximal muscle tendon unit is actually pulling onto the repair site, that there is an effort and a load. Okay. And that can cause lengthening and gapping at the repair site. Whereas when you do active extension, again you are pulling against the suture line. But when you are doing active extension, there is something called as reciprocal relaxation of the flexor. The moment you start extending, the flexors start relaxing. So the force that acts at the suture line is not same as that would act when there is a active flexion, and therefore this protocol works better. There is another protocol where there is an active, early active movement, which I do not follow, but that today is probably the commonest protocol that is used.
Right. Any more questions, Parag, on the line?
Yeah. So there is Dr.
One
Bablani.
question.
Yes.
Yes, doctor.
It is sometimes seen that ethibond and prolene as a skin irritation, as it is superficial tendon and close to the skin. And how can we avoid this problem?
Okay. So post tendon repair, the irritation of the skin from prominent suture knots is a bigger problem than irritation of the knots to the tendon and the surrounding tissues itself. whenever you are taking a core suture in a cylindrical tendon like a flexor tendon, you have an option of burying your knots inside the flexor tendon, inside the tendon substance, which you should always do. That is one way of avoiding irritation because of the knot. If you are dealing with a flat tendon, like an extensor tendon, where you may not have a choice of burying the knot under the skin, then you should not place the knot on the superficial surface of the tendon. It should be on the under surface of the tendon. A knot on the under surface of the tendon will be tolerated better than a knot on the superficial surface of the tendon, causing adhesion to the skin.
Thank you. That was a wonderful question from Burdwan. Any more questions?
Can you use Vicryl number 3 for this repair?
Sorry?
Can you use Vicryl number 30 for the repair?
You require a suture material which will maintain its strength throughout the process of healing. So you do not want to use any absorbable material, which at variety of time will lose its strength. So no Vicryl for sure.
Yeah.
Question. We have a question from Patna. Like, what will be the position of the joints while you are doing the repair? Like, in what position you are keeping it so that the tendon doesn't get shortened or overstretched? Like, is there any recommended position?
Not really. When you are dealing with an acute tendon laceration, the joint position is that of comfort, and there is practically no risk of over tightening the tendon. Joint positioning comes in the picture when you are doing tendon transfers or late tendon repairs like two-stage flexor tendon repair. In acute repair, it's the anatomical position of comfort, where the end of the tendons can meet each other in a comfortable fashion.
Yeah, Dr. Bablani from Solapur wants to ask a question.
Dr. Pradeep, Dr. Kotaga had a few questions. What are your indications for reducing the length of the pulley in chronic cases?
What are the indications for?
Reducing the length of pulley.
Venting. So, if the concept of venting is that the repair site should move freely from complete extension to complete flexion without getting stuck anywhere in the pulley. If that is not happening, if it is not happening on table, it is not going to happen later on. The pulley is not going to get dilated by a bunched up tendon. That's a wishful thinking. So if the tendon is not gliding throughout the excursion, then you have to keep venting the pulley until the excursion can be seen by you on operation table, leaving minimal part of the pulley behind. If not, as I said, you can release the pulleys in a flag-shaped manner so that you can still repair it in a loose fashion. Pulleys will become tight on their own for the required amount of volume that it needs to give to the tendon, but it will not dilate on its own.
Wait, there is a question
Sir,
from
question from here.
Yeah.
Two questions. One is, I know it's a zone 2 repair. Suppose zone 2, zone 3, when both FDS and FDP are involved, would you repair only the FDP, leave the FDS off? What's the current take on it? And one more is, how will you, what is the position of the, like, where do you apply the plaster for the Kleinet protocol?
Sure. So, first part of the question, if there is a zone 2, I will repair only the FDP. I will leave the FDS alone. If it is zone 2 with FDS intact, I will not sacrifice a working FDS in order to repair the FDP. If the cut FDP with an intact FDS is hampering mobilization because of pain or adhesion, I will happily sacrifice and excise the FDP. That answers first part of the question. Second part of the question, after a flexor tendon repair in the digit, either zone 1, zone 2 or zone 3, I will maintain the MCP, I will maintain the wrist in about 10 to 15 degrees of palmar flexion or neutral, MCP joints in about 70 to 80 degrees of flexion and IP joint in a relaxed cascade position. I will not force flexion of any of these 3 joints to more than this. And then over next 3 weeks, gradually 1 joint at a time, wrist, MCP and IP joint will be straightened out.
Show it in your hand, sir. It's very difficult for us.
Okay, can you see? So okay. Yeah, can you focus on my hand? Yeah. So assuming I have done a repair in, say, my middle finger, my wrist goes 15 to 20 degrees, the MCP goes around 60 to 70, maybe even 80 degrees, and IP joint inflection. At 1 week, I will straighten the wrist. In 2nd week, I'll straighten the MCP. In the 3rd week, I'll straighten the MCP further and the IP joint. Till this time, there is no active flexion taking place. Okay. From this point, the plaster now, from the 4th week, the plaster gets reduced to short of the MCP joint. Till this time, the plaster is beyond the MCP joint. From 3 weeks onwards, the plaster goes short of the MCP joint. You should continue to maintain the plaster on the wrist in order to make sure that your focus of effort is on the digit, the MCP and IP joints. Else, there is always a false sense of achievement when patients start doing this instead of flexing in the fingers. So when you actually want the patient to start doing active flexion, it is useful to keep immobilizing the wrist, either in a plaster or in a splint.
Lovely. Thank you, Parag. Pankaj, I keep on calling you Parag, sorry.
As long as all of Parag's patients come to me after that, it's fine with me.
So there is one more question if you allow.
Yes, of course.
How do you ensure that the repair is strong enough? Like, is there any method you would like to do after repair to rule out any gap, or when would you consider to revise it? Like, how do you ensure that the repair is strong enough for mobilization? Is there any method?
Sure. There are 2 scenarios. One, if the patient is under a regional block or general anesthesia, where you have no option of testing inactive, then you have to make sure that the finger is stretched out to its maximum and you look at the repair physically that there should be no gaping. You can pull onto the proximal part of the tendon in order to exert a complete flexion and see that the tendon is gliding and there is no gaping. This is when the patient is under anesthesia and cannot do active movement. Other option is to perform this surgery under wide awake local anesthesia without excuse me. I'm sorry. The second option is to perform this surgery wide awake, whereby you can ask at the end of your surgery, you can ask the patient to make a complete grip and complete extension and see that there is no gaping. If there is gaping at that time, there is going to be gaping later on. The suture is not going to contract later on. If there is gaping, please revise your repair then and there, otherwise you're going to repair it, you're going to redo it maybe at the end of 6 to 8 weeks again.
Thank you. There is a question from Dr. Sibin Kozhikode. Yeah, Dr. Sibin. Then there is one more question from the Solapur team.
Yeah. In cases of old treatment, in old tendon cuts and stiffness of PIP joint, what is your protocol?
Okay. If you are planning any tendon repair, the prerequisite is that the underlying joint has to be normal anatomically and fully mobile. There is no role of doing any tendon surgery when the joint is stiff.
In cases of old tendon cuts with atrophy of the peritendinous fat, do you use silastic grafts and then go for tendon reconstruction, and what is the protocol in that?
So, can you just repeat the question?
For tendon reconstruction protocol, silastic rod.
Silastic rod, okay. If
you use silastic grafts and then go for tendon reconstruction.
Yeah. So if you are dealing with a delayed zone 2 injury, say beyond 3 months, There are reports where people have done acute repairs even up to 3 months. Beyond that, if the pulley system is adhered and collapsed, then you want to recreate the pulley system. In that case, putting a silastic rod between the two ends of the tendon and allowing the pulley system to form is the standard of care today. Typically, the two stages are separated by 6 weeks, and the silastic rod is then replaced with a palmaris longus graft. There are centers which are doing, even in a delayed presentation of a zone 2 repair, doing a acute grafting and a pulley reconstruction. But I think if you see the surgery of pulley reconstruction, it is not for the weak-hearted. It is probably for, later years of your practice when you have achieved that level of efficiency in reconstructing the flexor systems. So I would say in first 25 years of your practice as a hand surgeon, you should try to do a two-stage repair and then probably venture into doing an acute pulley reconstruction.
With that, I'm going to call this session to an end. I'm sorry, no more questions. I understand there are so many burning issues with flexor tendon, but we are running out of time. We would like to invite the next speaker, Dr. Ashok Godke, who is going to make a presentation on trigger finger, trigger thumb release. Dr. Godke, would you start by describing your patient and then go on to your surgery?
Yeah.
Yes. There is a comment by Dr. Shiv Shankar Iyer from Sangli regarding the question which had originally come from Burdwan. And he says the reason why 20 or 30 is not used for tendon suturing is because the knot size becomes very large at the cut end. And therefore, a thinner suture material like 40 or 50 is used. So Dr. Godke is going to present a case of trigger thumb release.
Yeah, thank you. So I'll be covering trigger finger. So trigger finger consists of, so I'll cover 3 parts. One is congenital trigger finger, one is trigger finger, and one is trigger thumb. So yeah, so it is a very common and relatively easy surgery. But more complication rate if not done properly. So here we are dealing with a congenital trigger thumb, an adult trigger finger, and an adult trigger thumb. So the first is congenital. It is staged into 4 stages.
I don't want all this, Ashok.
I'll
directly go on to your surgery.
Yes,
This is not a lecture program.
Yes, I'm going.
Okay.
Yeah. So this is the nodule which we see in congenital thumb. These are the pre-operative clinical photographs. These are the surgical steps where an incision is taken. We do the soft tissue dissection, see for the nerve, protect it. FPL tendon is identified and the Notta's nodule visualized. A1 pulley is released. This is preoperative range of motion where we see there is restriction of extension, and this is postoperative range of motion where we see it is completely released. Moving on to adult trigger finger, again it is classified into 4 types. This type 3 and type 4 where there is a demonstrable locking and it requires passive extension by other finger, and grade 4 where there is a fixed flexion contracture, a surgery is advised. So this is a anesthesia. This is a valent, wide awake, local anesthesia, no tourniquet. So we give this solution. Here there is no need of inflating a tourniquet, and this is the method in which we do stabilization of hand. So we use the gloves. The operative finger, which is the middle finger, it is been free and the thumb is also tied. So these are the various incisions which we can take in a trigger finger or in trigger thumb. So this is an operative demonstration. Here we can see there is a demonstrable triggering. This was done with a vertical incision and the pulleys are exposed. We cut the pulley and once the pulley is released, this is the tenotomy scissor which we use to cut the pulley, and the FDS has been taken out and we free it from all the adhesions. Further, we see there is always some fraying because of continuous triggering. The synovectomy is done. We completely release the flexor pollicis, flexor digitorum, and after this synovectomy, the triggering has been treated. Suturing done, and this is the final thing. Now coming to the trigger thumb, so this is our A1 pulley, and this is the radial digital nerve which crosses. If we see all other fingers, the digital nerves are along the side of tendon, but trigger thumb, we have to be very, very careful with this radial digital nerve. And this is the surgery. This is 46 years old female. She had triggering in the thumb. You can see the thumb is in a flexion attitude, and it is grade 4. As we described according to the green classification. Also, she had triggering in the index finger, and this surgery was done under Valant, wide awake, local anesthesia, no tourniquet. So, the marking, we will proceed towards the marking. Yes, it is. So we are doing the marking for the infiltration. And after, whenever we give Valant, the protocol is we have to wait for 26 minutes. So the bleeding, there will be vasoconstriction when we use adrenaline along with xylocaine and sodium bicarbonate. So this is the local anesthesia given with 26 number needle. We mark the radial digital nerve which has to be identified and protected. And we see for the pre-op triggering, this is the triggering which was evident, but after local anesthesia there is the flexion attitude has reduced. So we go on further. So the incision is taken. These are the instruments. We need all the fine instruments and skin hook. And now the incision is taken at the A1 pulley. This is followed by the dissection. We identify the digital nerve, protect it. So now the deeper dissection is taken. So here we have to identify the nerve, and now the FPL tendon is been identified and exposed. But still the A1 pulley is there, which we are going to release now. So this is that FPL tendon. These are the tenotomy scissors with which we are releasing the A1 pulley. And now the A1 pulley is completely released. We can see the radial digital now near the retractor, and now there is a complete release of the A1 pulley. We can see the flexor pollicis longus is nowhere in any adhesions. Wash is given. And now we do the suturing with 4,4-O-ethylone. So with this, there was a complete release of trigger thumb. She also had a trigger index finger, which was released later. And following this suturing, we do a bulky dressing. And then we immediately counsel them for mobilization. So we can see that the triggering is gone. So this is a surgery done under Valant, where we can ask the patient to mobilize and see on table. Sir, it is getting corrected right now. Yeah, we can see it is corrected. Thank you.
Lovely demonstration. Ashok, what is your post-op protocol? Do you immobilize these patients or mobilize them immediately after trigger finger or trigger thumb release?
In all these patients, immediately we give a bulky dressing just for the, if there is any bleeding, but we encourage to mobilize as early as immediately after the surgery.
And
no plasters, no immobilization.
as a general principle, in the hand and on the palmar aspect, when do you remove your stitches?
And generally, 7th or 8th day, 8th post-op day, we remove our stitches.
Yeah, because otherwise they get buried.
get
Actually,
buried.
removal becomes more difficult than the surgery.
Exactly.
Primary. A quick question for our audiences in Coimbatore. In Coimbatore, this question
Yes,
is for
please.
you. It's a quiz question. How many pulleys does the thumb have? A, 1 pulley, B, 2 pulleys, C, 3 pulleys, and D, 5 pulleys. Come on,
Sir,
somebody from the
We
audience.
need to know what is the price you're giving.
So there is a chocolate lying with the Coimbatore Intas person. He is going to give it to you. There is a 5-star over there. Demand it from the Intas guy.
So the hand surgeon among us says there are 3 pulleys.
Okay, please. Which are the 3 pulleys? Because in Ashok's lecture, I saw only 2, A1 and A2.
So there's a A1, there's an oblique pulley and an A2.
Absolutely right. That's the right answer. Who is there? Who is there in Intas? Praveen, please hand over the 5-star chocolate to the gentleman. Thank you. Let's move on to the questions now. Everything is open to the house. Anybody here in Bombay, it's a full house, 100 people sitting. And only the questions are coming from our panelists. Let's have somebody else ask.
So Dr. Jalandhar, Dr. Dhingra from Jalandhar wants to ask a question.
Yes, Dr. Dhingra, please go ahead.
Yeah, sir, what is the right age to release congenital trigger thumb?
Yeah, the right age is, it should be released before 5 years, because after 5 years, it becomes a fixed, it becomes very difficult to release. So before
What is
5
the
years,
earliest age that you operate? Because if you see somebody with 1 year of age, will you operate at that age or you will wait till 5 years?
No. The, whenever we see at 1 or 2 years, we can operate.
Thank you, sir.
Question from Solapur team. You can go ahead, please.
Your take on percutaneous pulley release with a maybe taking on the needle or something like that?
Sorry, we could not hear.
We couldn't hear.
Yeah.
Question I understand is about percutaneous release.
Yeah, Dr. Babladi, yeah. So, percutaneous release, there are chances of injuring the tendon. So, we would advise rather to do a quick surgery. That single needle, when we try to do that percutaneous release, we have seen that people have injured the tendon. So instead of doing that, I would recommend to get an open surgery and release.
Dr. Ghodke.
Yes.
From Sangli, Dr. Deshpande.
Yes, sir.
I wanted to ask, in one of your slides, you have shown a vertical incision. What are the indications of taking a vertical incision in a trigger finger?
So that was a very old video of mine. Nowadays, I don't take vertical incision. I take a horizontal incision. And as I showed in one slide, there are various methods in which an incision can be taken. So nowadays, what I do is
What are the pros and cons of horizontal versus vertical incision is what he is asking.
Yeah, that's what. So I am saying ki,
you don't do it, but why don't you do it?
So it gives a better scar. Horizontal incision gives a better scar, and I can see the pulley in a better way in a horizontal incision.
From Patna, Dr. Runu asks a question which has been put forward by Dr. Dinakar. Do you need to routinely remove the tendon sheath along with the pulley?
No, we have to only release the pulley.
You have to only release the pulley.
No
Is there
tendon.
any indication to do a tendon sheath excision?
There is no need, sir.
All right. So there is no need is the answer. Any other questions from anywhere else? Haldwani? We can't hear you, Haldwani.
Yes, sir. We are here.
No, you have a question, I'm told. No.
Sir, you are mobilizing thumb immediately after the surgery, or are you having any protocol to immobilize for a few days?
So for first 2 days, I apply a bulky dressing, no plasters, and we will encourage them to mobilize immediately as early as possible once the pain is.
And in your current practice, what is your ideal age to release a congenital trigger thumb? At what age you like to prefer?
So after 1 year, 1 to 2 years, I am comfortable to release the congenital trigger thumb.
Thank you.
To comment on that,
Hello.
One comment.
Hello.
Hello.
Sir, Calicut, one question.
Yes, Calicut, go on.
So what is the cocktail for violent that is he is giving for violent anesthesia? Is the routine thing 1% xylocaine or what is the cocktail?
Yeah. So 2% xylocaine, we take 4 ml. Then 4 ml of normal saline. Then we take insulin syringe and we take 0.1 ml of adrenaline and 1 ml of soda bicarb. So this becomes a cocktail with which we give in the Valant. So it comes to around 10 ml.
Yes, one more question from the audience. Dr. Runu at Patna.
We have a question from Dr. Shashikant that what is the risk of bow stinging after the release of pulley and how to prevent it?
There is no instance where we have seen any bow stringing after A1 pulley release, and it can be done safely.
Lovely. We have 2 comments from our in-house panelist, Dr. Hemant Patrankar.
We have seen that if the patient is having a trigger finger of a long duration, long standing, and then it is better to after release of the A1 pulley, it is better to identify the FDS and FDP tendons separately and mobilize them individually, because many times the result is not satisfactory if both the tendons are not mobilized to their full length. And then in that case, you may have to do some excision of the sheath, because the tendons are very sticky to each other.
Okay.
So that is an additional procedure which we can do it in a minute or so after the release of the A1 pulley.
Pankaj?
I have two comments. One was about the congenital trigger thumb. Congenital trigger thumb, if followed up to a period of 3 years with regular splinting, in most cases will not require surgery. So it is safe to wait till 3 years, and there is no clear advantage of operating before 3 years. That was one. Two, about the composition of valent solution. The standard, there are variations of adding hylase, adding soda bicarb. The essence of valent is use of adrenaline. And for that, the correct solution, if I may share, the easiest way to prepare is take 30 ml of lignocaine with adrenaline, the standard one that is available to us. Dilute it with another 30 ml of saline. That gives you 60 ml of 1% lignocaine but 0.5% adrenaline. Now, in order to convert this to 1% lignocaine with 1 in 1 lakh adrenaline, at present you have 1 in, sorry, not 0.5%, you now have 1 in 2 lakh adrenaline. Now, in order to convert this solution to 1 in 1 lakh adrenaline, you add about 0.045. So on a syringe, somewhere between 4th and the 5th mark of the ml, that much of 1 in 1000 adrenaline.
On an insulin syringe, so we can have that.
So even on an ordinary syringe. So once you add that, now you have a 60 ml solution of 1 in 1 lakh adrenaline with 1% xylocaine, to which now you may add xylase or soda bicarb. This is shared by Dr. Don Lalonde.
Yeah.
Lovely, thank you. Any other burning questions from anywhere across India?
Yeah, we
From
have a question
Pondicherry?
Yeah, I want to know whether there is any role for local steroid injection at the first shot instead of going for surgery directly.
Yes,
How effective
definitely.
is it?
Yeah, definitely there is a role, but if it is in the stage 3 or 4, I am more than happy to do an open release rather than doing a steroid injection.
Right. So if it's in the early stages when there is still inflammation and swelling over the joint, there is no formation of a nodule, then you may consider giving an injection. Now, what injection? Do you give it yourself or do you send it to the ultrasonologist to give an injection to avoid injecting into the tendon while you're putting it in?
If at all I am taking a decision of injection, I ask my ultrasound guy to do it under sonography control.
So one of the problems with non-ultrasound injections is the chances that your needle may go into the tendon sheath and your steroid goes there, weakens the tendon, increases the risk of rupture. And therefore, to a large extent, a lot of people prefer these kind of injections today to be done under sonography guidance. Next question, please.
Sir, I have a question from Patna.
Yes, please.
Congenital trigger thumb, should we wait for 3 years if it is fixed inflection?
If it is already fixed inflection, should we wait for 3 years? I think
Pankaj, sir.
Pankaj has told us that, he has found that splinting them and you can wait till 3 to 4 years. Dr. Godke had earlier told us that if the patient is fixed after around 1.5, 2 years of age, he doesn't really wait. He goes in and does the surgery. So there is a little bit of divide among the panelists. The general release do not operate before 2 years of age. Between 2 and 5, you can choose. If you are comfortable operating at that age, as Dr. Godke is, he does it. What Dr. Pankaj does is he splints this and he waits because he does not find any significant advantage of operating earlier. Next question, please. All right, we move on to the next session. Next case.
Thank you.
Hello. So we have Dr. Parag Lad.
So now the moderators for this next session is Dr. Pankaj Ahire and Dr. Nikita Shetty.
Hello.
Okay, so moving on to our next session. Dr. Parag, we don't have the questions on our phone, so the moderator questions, I think you'll only have to take. Yeah, so our first speaker is Dr. Parag Lad, who will be showing us a video on mallet fracture, open reduction, internal fixations.
Thank you, Dr. Nikita, and I thank all the centers who are attending today. So, in being hand surgeon, we definitely have a dilemma whether all mallets require fixation or they have to be treated. But the general consensus based on these two articles that if there is a gap or if there is a lengthening of extensor tendon at the joint by even 1 millimeter, then there will be a lag of at least 25 degree. Okay, so these are the oldest article, and so far you will realize even after your repair, I will show that. And the area of terminal extensor tendon is certainly avascular, and therefore there is a high chance of rupture or very difficult at this region to have a perfect healing. About the mallet injury, we know there are two types, soft tissue and bony mallets injury. Basically, it's a extensor tendon avulsion with or without soft tissue bone involvement. Mainly soft tissue mallet injury in the initial stage, we definitely recommend splinting, and depending upon the compliance of the patient. And these are the splintage that we use, and they have a better chance of healing if they use the splintage very properly. Bony mallet injury, the decision is taken as per the size of the fragment, the articular step, and the subluxation of distal interphalangeal joint. These are the decision making for surgery. Sometimes if the articular surface is large but the gap is not significantly widened, then you may treat in a cast. Nowadays we don't give a cast, but we can give a good splint and make sure that that we need to have a serial every 2 weeks X-ray and make sure that they heal properly. Then sometimes you get acute injuries where there is a displaced and largely avulsed fragment, and in these cases we can consider a closed pinning of the fragment, the technique called Ishiguro technique. Okay, the wire here that I am showing, it has to be still more inclined. The DIP joint has to be still in more extension so that the fragment gets sandwiched in between the distal phalanx and the extensor tendon. My surgery today is about the bony mallet fixation. It was a 24 days post injury. The young IT professional presented to us with a significant more than 2 millimeter articular surface incongruency and mild volar subluxation of the DIP joint. So that's a skin marking. We perform this operation under digital tourniquet and digital block. I use 10 cc of 2% lignocaine and 5 cc of 0.5 anavin. These are the H-shape incision. You can take vertical incision and retract the skin flap, but this is, I found, reasonably safe. Then once you take after the marking, you incise the skin flap. Please remember, these are the very thin dermal skin flap. Don't use more than any knife beyond 15 number blade, because if you use anything more than that, there is a high chance that you will straight away cut the tendon or the fibrosis that is happening underneath. Okay. Then you have to be extremely careful in raising the skin flap, and in fact the distal skin flap, which I am holding it with the skin hook, we have to be extremely careful because there is a germinal matrix underneath or just distal to that skin flap. And this proximal skin flap, we have to be extremely careful because in the chronic injuries, there is a adhesions formation between the skin flap and the extensor tendon, and you may directly rupture the tendon. So the bone fragment remains at one end, and while taking the incision only, you rupture the extensor tendon. Then try to walk, by a small needle, and try to go beyond the fragment before you really dissect the fragment. And sometime you may take a use of your C-arm to go just beyond the fragment, because there you will begin your dissection. You don't need to dissect these fragments all the time, but sometimes there is a soft tissue interposition, and that's why you need to dissect and have very good clarity about the fragment. In acute injuries, you can just clamp the fragment and put the screw or a wire. So this was the chronic injury, more than 3 weeks old injury. So I am now dissecting the fragment with extensor tendon, which was adherent at the wrong place, at the proximal end. Then once you finish this dissection, and then you raise that bony fragment with the extensor tendon properly, so that now it is free. But please make sure that you use small periosteum or a small osteotome to dissect this, because very likely you will rupture or you will break this fragment. So you have to have a very small instrument. Please consider or understand that we don't need to separate this fragment with tendon all the time. Whenever there is a chronic injury, then only we do it. Okay, then once you do that, now we have to prepare the recipient site also. So this is the recipient site, the distal phalanx, the dorsal aspect. We scrape it so that the bone to bone union occurs nicely. And after that, now the role of the fixation comes. So I am just clearing all the soft tissue and adhesions around the extensor tendon so that the excursion is reasonably good. So this was the fracture, and you nowadays have a small towel clips to hold it, or otherwise you can use a mosquito forceps or artery forceps to just hold it in place. Usually we use 1 mm or a 1.2 mm screws, cortical screws, to fix the fragment. It all depends on the size of the fragment. If the fragment is too comminuted, we cannot put a screw, then there are different techniques that we should use. So this is one wire, okay, and this is the screw. Usually we get 1 or 2 attempts to put a screw. Sometimes if the fragment size is larger, you can have you can put 2 screws, but mostly 1 screw. I understand there is a small step we can see, but sometimes these steps are not going to cause any arthritis. You have to accept this step. The purpose here is correction of flexion deformity. We are not worried about DIP joint arthritis in these cases unless they put too much load on that. So I accepted that intra-articular incongruency and I put a screw, because and after 3 months everything heals nicely and the flexion deformity or the DIP joint subluxation was well corrected. If you have a good cortical purchase on either opposite side, then you don't need to put an axial K wire. Otherwise, these are very tiny screws, 1 mm screws. Sometime for our satisfaction, sometime you put an axial K wire and then fix the screw. And if I was satisfied here, and this was the final X-ray, and this was the result. So there are ways to fix the mallet. If soft tissue mallet, they are not corrected well, you can use the suture anchor also. Acute mallet or little up to 2 weeks, you can use closed pinning, Ishiguro technique, or chronic or a large bone size fragment, you can fix it with the bones, 1 screw. Thank you so much. You're right. Yeah.
So any questions from the audience for Dr. Parag? Dr. Parag, I have a question. You said
Yes.
you do all these surgeries under a ring tourniquet. Does it affect the excursion of the extensor if you've tied a tourniquet?
No,
at the
no,
base of
no,
the finger?
no, I have never seen that. It doesn't affect. Yeah. Yes, there is a question at the back. Please give a mic.
Yeah.
Kiran,
Yes.
please give
How
a
do I
mic.
replace some stiffness?
Sorry? Okay. So here there is a tough, you have to be extremely careful. For 3 to 4 weeks, 3 weeks at least, I do not start any active flexion at the DIP joint till I have some soft callus formation, I mean, we can assume that, we cannot diagnose it on even X-ray. So for 3 weeks, the patient is only allowed to do proximal interphalangeal joint active movements, and we are not allowed, we don't allow to move them at the distal interphalangeal joint. I believe in lot of scar massages in post-operative period once the sutures are out. So if the scar at the surgical site in the hand is supple, most of the stiffness or tendon adhesions do not form, because here only we are worried about the skin getting adherent to the repair site or extensor tendons. So I believe in scar massage, and after 3 weeks or 4 weeks, I start very active flexion, gentle active flexion, and at 7 weeks I start passive flexion. So I do not start before 3 weeks, flexion at DIP joint. Yes. Yeah.
Sir, many a times this.
So the advantage of screw apart from K-wire, technically there is no advantage. If you are using the K-wire, if you are good in that, that's very good. But the screw is screw. It's a cortical bone. It has a dorsal cortex as well as a volar cortex. And if it is, the fragment is large, if it is fixed well, you can definitely mobilize well early. And in K-wires, you have to have an axial K-wire also along with the, to fix the fragment. And you can't start early mobilization. Dr. Patankar sir have.
So from Sangli.
So just a minute.
I think his question was, why don't you put a Ishiguro or something? I don't think he's asked whether the screw is better than a K-wire as far as interfragmentary fixation is concerned.
Interfragmentary fixation, screw or K-wire, is that your question?
Yeah, that was the question.
Yeah, so to answer that question, the K-wire does not have any hold. Even if there is any, if there is any static movement of the finger, the K-wire will become loose and the fragment will come out. So if you want to use a K-wire, you have to use something like a Ishiguro. You cannot have only a K-wire. That's of no use.
So what is Ishiguro?
So Ishiguro technique, it is a technique. How do we fix it? If you can show my finger. Yeah.
Basically,
yeah. So basically what we do, we take 1 mm or a 1.2 mm K-wire and we put it into the condyle of middle phalanx, oblique K-wire, around 45-degree angle. Then we hyperextend the DIP joint so that the avulse fragment is now compressed between the distal phalanx as well as the K-wire, and then we pass the axial K-wire. So that is what the Ishiguro technique is.
Yes, there's a question from Sangli.
Sir, there's a question from Dr. Dhingra from Jalandhar.
Yes.
That has been answered regarding the protocol.
Okay.
Thank you, sir.
Okay.
Somebody from Sholapur has a question for Dr. Parag.
Hello. There's a question from Dr. Sambarani. What is your protocol for chronic and acute tendon tears?
You mean to ask the tendon tear at distal interphalangeal joint?
Yeah, a mallet finger with a soft tissue injury.
Yeah, so there are 3 ways. There are operations like we do reefing of tendon. We explore the DIP joint and then we do reefing of extensor tendon, and along with that there is a procedure called tenodermodesis. So sometimes you take a elliptical incision on the distal interphalangeal joint and remove that skin and close it so that you technically correct the skin and achieve the flexion deformity. I do not perform any reconstructive procedures for chronic mallet because technically in my hand they have not given good experience. Rather, I discourage them from the surgery. And in case of chronic flexion deformity that is bothering his daily activity, sometimes we attempt, we recommend to have, the surgery recommended is explore, put a suture anchor and repair that extensor tendon to the distal phalanx. I would like to ask Dr. Pankaj or Dr. Patankar or Dr. Varade if they have any protocol for soft tissue chronic injuries, mallet.
Yeah, what you're saying is right. The only option that remains is probably reconstruction of the oblique retinacular ligament, which is a very challenging surgery, does not have optimum outcome. And unless the swan neck is getting stiff, you should refrain from doing it.
Okay.
Question.
In an acute case, is there a role if the fragment is too small? Is there a role for excision of the fragment and repair of the tendon? The question from Dr. Erickson Convener.
Yeah, remember that bone to bone union is always better and bone to soft tissue union is always doubtful. So if your fragment is small, you can repair the extensor tendon, but there has to have a opposite side tendon to repair. Then otherwise the only option remains is put a suture anchor or put a pull through button technique on the volar aspect of the distal phalanx to repair the tendon. So as far as possible, do not remove the bone fragment because the bone to bone healing is always better. Leave that bone and then try to repair the tendon.
Dr. Yes, somebody has a question?
Hello.
Haldwani?
From Haldwani?
Yeah.
Yes.
Yes. Yes, Haldwani, please go ahead.
Yes, yes. Sir, in cases of soft tissue mallet, acute soft tissue mallet, what is your treatment? Are you conserving this finger or you are going directly to the surgery?
Acute soft tissue mallet, my protocol is I will get the ultrasonography done and I will make sure that this is a partial injury or a complete injury. If my ultrasonologist says it's a partial injury, I will definitely treat in a hyperextension splint for 4 weeks and with active PIPJ movement I will start. I will keep on warning the patient that at 4 to 5 weeks, if the compliance is bad or if he doesn't wear the splint properly or even if he wears and there is a finger drop at the end of 4 weeks, if he wants to have a correction, I would recommend a surgery. That is a tendon repair and an axial K-wire.
Good. The tendon repair.
There is also, yes.
Anchor.
Sorry, please go ahead.
Yeah, tendon repair and we have to use suture anchor because these injuries are not ruptures. They are usually avulsion from the distal phalanx. So very less likely we have some stump there to repair.
Okay, thank you.
Dr. Dombe sir.
One question from Calicut. Hello.
Yeah.
So many times the compliance is very poor for this patient. So can we put cast, finger casting? What is the current?
So if you want to put a cast, you make sure that the PIP joint, proximal interphalangeal joint, you keep it in flexion and DIP joint, you keep it in extension. Then only the cast will remain in place. It is definitely you need to have a close watch on this patient about the vascularity issue and whether, if the skin gets macerated. I have done it only once in my life and I usually, nowadays splints are very good. So if the compliance is not good, better to offer a surgery. At least put an axial K-wire, they will have better result.
Parag, there is a question from Sangli. What if the patient comes a little late and is developing now with a swan neck along with that? What is the treatment? How does it change?
So if patient comes late and if he has a soft tissue mallet injury, I discourage them from the surgery. And if the patient has a bony chronic injury and if the fragment size is good enough, I offer them a open reduction and a proper fixation of the fragment. If they still insist, then there are reconstructive operations available. But result of having a good active flexion at DIPJ, they are not good in my hand. So I discourage them.
We have a question here from the audience in Bombay.
Can you please give us an absolute indication for surgery in these type of injuries?
Three absolute indication for surgery: more than 2 mm of intra-articular incongruency, joint subluxation, and in soft tissue, at the end of 5 weeks, failed conservative treatment. According to me, these are the 3 indications.
Do you make a difference functionally after your surgery?
Yeah, if the bone healing is good, they definitely, at the end of 3 months, they have active flexion and extension movement. Definitely, surgery makes the difference. At least the deformity gets corrected. There is no other way that the flexion deformity is ever going to get corrected unless the extensor tendon is back into the distal phalanx.
Yes, please. Sir, during surgery, what precautions we need to take?
Sir, there is a question from Bombay. Once that gets over, we'll come to Burdwan.
So during surgery, the precaution,
Splintering during holding the fragment, passing the screw. I got difficulty. Lot of times it get fragmented or.
First is try to use Addison's tooth forceps or a plain forceps to deal with the fragment. Second is don't try to crush the fragment and use minimum, the smallest instrument possible like a periosteum. Third is use cordless drill to fix. Don't use the man with the cord, because any maneuver is going to break the, basically the instrumentation and handling is going to give you the...
No holding with towel clip or all.
No, it all depends on fragment size. If you want to hold, you can hold a extensor tendon beyond the fragment, but don't crush the fragment. Yeah, sir, Dr. Patankar, sir.
To answer your question, there is no instrument that will not prevent splintering of that bone piece. The best instrument to hold is if you are getting these mallet fingers repeatedly in your practice, grow your thumbnail and use the thumbnail to push that piece back in place. That's the only instrument which will not fragment that nail.
Very good
Second,
No, because you have to remember that ultimately all instruments are extensions of your fingers.
Yeah.
So there will still be time
grow your
when you will have to
keep
use your
thumbnail
fingers.
long, that is good enough. That should work in every case. That does not cause any splintering of that piece. Second, I don't agree with Parag. Don't use a cordless drill. Only synthase E-pen. Only synthase E-pen is the only instrument that will not cause any fragmentation. That is a high torque, low speed drill. That's the only thing that will give you a very good result without any splintering. And use a 0.8 millimeter K wire. And you have to have an excellent tourniquet, no bleeding. It's you can have only one attempt at passing the screw. Just remove that K wire, see that hole, and just pass the screw in that hole. Only one attempt. Second attempt, you will cause splintering.
So I think some very important tips here from this thing which will be useful. I don't know how much all of you could hear over there.
Yes, sir.
The question asked was that these are small fragments, and when you are trying to reduce them, you tend to shatter them, splinter them, and then it becomes impossible. So what Dr. Patankar has recommended is that use a slightly, your thumbnail, if you have a little longer nail, the best thing to do is to push the fragment back in position using your nail rather than trying to hold the fragment with any instrument, because it invariably shatters. Requirement is a 1 mm K wire, and it has to be passed using a very good E-pen drill.
Pointed.
Gautam, 0.8
A
millimeter.
pointed K wire, and you use a drill, and once you've done that, you made the hole, then you replace it with your 1 millimeter screw. So this is the principles that is outlined. We now move to Burdwan. Burdwan, what is the question?
In soft tissue millet, after splinting for 4 weeks, it is sometimes in deformity is present. Then what we'll have to do? Can we refer the patient for physiotherapy for improvement, better result for either physiotherapy, sometimes do ultrasound or laser therapy? Have any role for this case?
So for soft tissue mallet, I told you the protocol. Usually they do well with the splintage. If not, then the surgery called tenodermodesis and suturing the tendon with the bone by anchor. Physiotherapy, do not advise any physiotherapy unless there is a joint stiffness. It is not at all required. And physiotherapy is useful only after after 2 months of surgery or splintage if the joint is stiff. Otherwise, there is no role of a physiotherapy.
Yeah. Dr. Parag, if you have a patient that has presented late, time-wise, what is your threshold for a conservative treatment?
See, if somebody has presented more than 2 months, he definitely never required that operation. He just wanted to join some army or police or cosmetic concern, they have come. So after 2 months, I really understand what was the reason of delaying the operation. And if I don't understand, if I'm not convinced, then after 2 months, I don't offer any operation to the mallet finger.
No, I'm asking about conservative treatment.
Yeah.
What is the time
3
period
weeks.
when you would still try conservative treatment when the patient presents?
If patient present to me up to 3 weeks, I will still try conservative treatment. Yeah.
Let us move to Agartala. Agartala, please go ahead.
Hello. Good morning, sir. This is a very nice demonstration of the bony mallet
Thank you.
fixation. Sir, what are the indication for block method to use?
Indication for digital
method,
block.
like, yeah.
Ishiguro.
Not digital block, sir. Like 2 K-wires you are using to block that.
Yeah. So the indications are comminuted fragments or acute injury. These are the 2 main indications to use the Ishiguro technique. And even if the fragment size is large, then also you can use the Ishiguro. So technically, all bony mallets can be treated by Ishiguro technique. All bony mallets can be used.
So Agartala, here is your chocolate question. A Bennett's fracture is a fracture of the head of the metacarpal. It's a shaft fracture of the third metacarpal. It is a head fracture of the fifth metacarpal, or it is a base of the first metacarpal fracture.
Base of first metacarpal fracture.
Very good. That's the right question. It's a fracture of intra-articular fracture of the base of the first metacarpal. And you should get a chocolate. Intaz, please do the needful.
Thank you, sir. Thank you.
Parag,
Question
that was
from
excellent
Patna.
case and discussion.
Thank you.
Patna, last question before we move on to the next session.
Yeah. One. Yeah.
Yes, please, sir.
Yes.
Hello, are you listening to me?
Indication for? Yeah. Indication, that's a wonderful question. In fact, any injury that has come to me after 3 months and with the significant joint stiffness, that passive extension is not possible at all. Active extension or active extension is impossible, but indication to fuse the distal interphalangeal joint, elderly gentleman, chronic injury more than 3 months old, and a stiff finger DIP joint in flexion, I would consider a fusion. Yeah.
Yes, Patna, please ask the question.
Patna speaking, Dr. Kanojia.
Good morning, sir. How are you?
Good morning. तभी से हम सुन रहे हैं हिंदी में बोलते हैं.
हाँ, sure, sir.
नहीं, बहुत सारे लोग हिंदी नहीं समझता होगा. Anyway, I am speaking in English. We have also experienced about the mallet finger, and somebody is showing that I will not operate after the 2 months or 3 like that. We operate in all cases, and if there is no bony avulsion, in many cases, in most of cases, this is just lengthening and the overstretching of the extensor tendon. In that sense, we fix the DIP joint with K wire and exploring the extension tendon, and we make.
Yes, agree with you, sir. That is one of the very old method and a successful method of treating a soft tissue mallet injury, even in chronic cases.
And when there is some avulsion, bony avulsion, distal phalanx, just make over extension and fixed with the K wire, it will work.
Yes, agree with you, sir.
Intensive surgery always spoils, and the most basic philosophy of the hand surgery is atraumatic surgery.
Yes, agree with you, sir.
Very, very, very good observations, sir. Coming from years of experience, thank you very much. We now move to the next question.
Sorry.
No. So
what the question here from the audience in Bombay is, what is the protocol for removal of K-wires when you do the Ishiguro technique?
So first K-wire, unless there is a pin track infection, I don't remove K-wire for first 6 weeks. First, I always remove the wire that is passing through the middle phalanx condyle, and axial K-wire I remove at 2 months, at 8 weeks. Yes, and I still after removing the condyle wire, I still keep the axial K-wire for 2 more weeks. Yeah.
Lovely.
Okay, thank you.
Yes, some more questions from the online, or should we move on? Lovely. That was a lovely discussion on mallet finger.
Before we wind up, Parag, that was excellent session. We need to stop looking at mallet finger as a DIP joint problem. Mallet finger is an extensor tendon problem. And most problems associated with poor treatment of mallet finger are associated with extensor tendon imbalance. And therefore, one of the indications for intervention remains an hyperextendable PIP joint. If you have a hyperextendable PIP joint, an untreated mallet will lead to severe deformities. Whereas if you have a PIP joint which does not go beyond neutral, then the problem of the mallet finger is likely to be limited only to the DIP joint and will not translate to rest of the finger. And the various options Parag said, wonderful. One of the bailout procedures that remains is a pull-out suture for any situation. And as Dr. Patankar very rightly said, using correct instruments, correct size of the wires, it's not a fracture fixation. It is a fixation of an avulsed tendon. Therefore, only a smooth K-wire is not going to work.
Yeah.
I think that more or less summarizes the discussion that we had.
Thank you.
Thank you, Parag. And the next speaker that we have is Dr. Hemant Patankar. He is going to speak to us about PIP joint distraction methods and fixation of the proximal phalanx.
Yeah, I'll be speaking on the method. This is a very controversial injury to treat. That's the PIP joint fracture dislocations, a fracture of the volar lip of the middle phalanx with a dorsal dislocation of the or subluxation of the PIP joint. There are various methods available, and nobody is still agreeing on what is the best method. Whatever works best in your hand, that should be done. It all depends on.
Sir, there is a request that we are not able to hear. The volume is very low.
Hello, can you hear me now?
Yeah, sir.
Yeah.
Now it's fine. Thank
you. So I'll be speaking on my method of treating these PIP joint fracture dislocations who present late with this external distraction method, originally described in 1994 by Dr. B.V. Joshi in a paper in the Hand Journal of USA. There are various methods, I understand, to treat these fractures of the volar lip of the middle phalanx associated with a dorsal subluxation or dislocation of the PIP joint. So the method which works best in my hands, which present in patients who present late or who are not reducible by closed means, is this external distraction method. I understand, I know many of you are doing hemihamate arthroplasties, volar plate arthroplasties, and other techniques or open fixations of the base of the volar this thing. This is not, my discussion will not be on these methods at all. So the first important thing to remember, and another very important thing to note, is that it's very difficult to take a video. So I'll just try to convince or show my present my case in the form of a short video and some slides of how to exactly pass the wire. The most important thing to remember, that is in a finger, the bone is in the dorsal half of the finger. The first thing. So the bone is in the dorsal half of the finger. So that is most important thing to remember when you are passing a K wire into the finger. This method has to be done by putting a trans fixation wire into the middle phalanx and one wire into the proximal phalanx. The most important thing to remember, as I mentioned, I'll repeat, is that the phalanx is in the dorsal half of the finger. Second thing is that when you pass the K wire has to go from one lateral cortex into another. If this technique is not mastered or perfected, then you will have problems with this method. So that is how the K wire has to go into each of the phalanges. Now this is a case which was presented to me in October 2000. He, as usual, presented, these are all cricket ball injuries or road traffic accidents, but mainly they are all cricket ball injuries here in Mumbai. So this presented after 3 weeks, and he was treated with this external distraction method. And 1.5 millimeter wires are used because 1 millimeter wire is too thin to sustain that traction, and 2 millimeter wire will cause fracture of the middle phalanx. So I use 1.5 millimeter wires and connected two distractors on either side of the finger, and just you hold them for about 3 to 4 weeks in extended position. At the same time, when you pass the K wires and you complete this assembly, ensure that your DIP joint is moving into active flexion and extension during the whole course of treatment. And this is the 1 year post-op, and that is 16 years post-op. The fracture is very well reduced. There is no arthritis or any other problem. He has come to me for some other problem. So this is 16-year post-op by just a closed technique of a PIP joint distraction. So this is another case who presented 6 weeks post-injury. Again, there will be opinions of whether this requires a hemihelmet or open fixation and all that. But basically, when you have a 50% of the articular surface intact, and you can do this method, that is how it is done. 1.5 millimeter wire is passed through the mid portion of the middle phalanx. And very important to note is this view you should always see on the C-arm. This means that the K-wire is not going under the bone or over the bone. So when you start inserting the K-wire, take a stab incision and just palpate the bone with the K-wire and make sure that you are not going dorsally under the or through the extensor tendon, and make sure not going on the volar side into the volar flexor sheath. And then on the lateral side, this requires experience and practice. And pass the K-wire mediolaterally, as I've shown you in the first diagram. And that is how you do it. So the K-wire is inserted like this. You take a stab incision on either side so that the skin is not puckered or not tethered to this K-wire. And then my assistant uses a gauze piece or a bandage or whatever is readily available. And because if you put your fingers, as shown in the second slide, if you put your fingers, then it will hamper the C-arm view. Another very important thing is that the hand is placed on the C-arm table directly. You don't have to have a C-arm coming later on. This is a closed technique. It has to be done only with the C-arm. So it is better to have a gauze piece or to hold the finger in traction so that the view is not hampered. Then the second K-wire is passed in such a way. Now remember, you are going to use a single block fixator. So you cannot have a fixator which is going more proximally, or the K-wire should not be inserted more proximal than the half of the length of the proximal phalanx. Otherwise, the fixator will hurt the web. So you go about 60-40 into the proximal phalanx. Again, the K-wire is passed lateral to lateral. And that's how you have a distractor on either side of the finger. If the fracture is on, every fracture is not in exactly anterior-posterior planes or mediolateral plane. So if you see the X-ray properly preoperatively, then you may have to do unequal distractions. And this is a short video which I will show you. So this is the, let me play. This is a very short video. This was a stab incision. You take a mosquito forceps and just dilate that hole. And you can see me, it's difficult to shoot through a iPhone. So just manage. See, you can see that K-wire is palpating. We are palpating this thing, and I am using a Synthes E pen, and this is a 1.5 millimeter wire. You can see I am going on dorsally and I am going volarly, and then I make sure that the K-wire is going from lateral to lateral. Sorry. Yeah, this is a very short video. Sorry, it is restarted again. Yeah, another very important thing is have only 1 centimeter of the K-wire out of the drill. If you have a K-wire which is long, you can see that I have shortened the distance of the K-wire between the drill and the finger. So that gives you a precise entry. Very important, another important point is that you should have a K-wire which is very sharp. I get these K-wires made from a local manufacturer so that the ends are not polished. If the ends are polished, the K-wires become blunt. Though they look glistening and sharp and all that, they are not really sharp. They don't cut. So this is how it is done. So you take time. You have to have, in all these surgeries, only 1 attempt has to be done. There is no second attempt in this. So this is how you pass the K-wire. And then once you enter one cortex, you will feel that the K-wire is going on the floor of the middle phalanx, and then it gradually comes to the second cortex. And at that place, you take a C-arm shot and ensure that the K-wire is parallel to the joint, and then you come out, and that's how it is done. That's the second K-wire which is inserted into the proximal phalanx. Now, if you go at the distance, if you go at the 60% length of the proximal phalanx, the extensor tendons are going at the dorsum of the bone, and so you not hurt them. And this is how the distractor is connected. Ensure that your distractor is connected in so that it faces on the volar side. The screw, the clamping screw is faced on the volar side, so that you can pull. When you pull it, the bone which is dislocated dorsally comes on the volar side. So always the screw should be facing on the volar side of the finger. Yeah, and then initially after, if you feel that you cannot turn the distractor on with your hand, you can use a plier and give good amount of distraction. If the patient presents late, because most of these patients present after 2 months, 2.5 months, so the finger pressure is not adequate, so you can use a plier. You can distract the joint easily up to 5 millimeters without causing or getting scared of the vascularity of the finger. Obviously, you can, you may or may not do it under tourniquet, and then you can keep on checking the distal circulation. If the finger becomes white or blue, you can just reduce the traction at the same time. And then you ensure that these locking nuts are in place so that the patient does not play around with it. Because we have had instances where the patient has kept on pulling the thing, so you have no way to know it otherwise. Tell the patient not to turn the distractor on its own at home or by somebody else. So you can take view. This is not done. This is only done for the purpose of the video, so this session. And that's how you do it. You can see that the distractor is not hurting the web now. And then you do a dressing. Yeah. So this is another case. He presented late. You can see this patient presented late. Now, another thing which we have found in practice is that though this volar piece looks united, in practice it is not really united, just stuck there. So with heavy traction, about 5 millimeter traction, you can break this volar piece internally and it comes down. So you can, this is very important, ensure that patient is having active flexion and extension of the DIP joint during the whole course of treatment. And you can see that this piece is broken off here in this view, and this piece comes down, and this is immediate post-op. You can see this in the lateral view, that piece is broken off, and that is 2 weeks post-op. At 4 weeks post-op, when you remove the fixator, because you cannot take a dead lateral view with the fixator on. So remove the fixator at 4 weeks and keep the K-wires on, because if you want, you can extend the fixator for 2 more weeks. So at 4 weeks, if you see that the joint is well aligned with no subluxation, you can remove the K-wires and then start mobilizing the finger. If he develops a flexion deformity later on, you can give a Kapner splint. And this is the picture at 6 months. You can see full flexion extension. And that is you can see excellent positioning of these K-wires, exactly lateral. So this you get with practice. I have also committed a lot of mistakes in the past, but now we ensure that the K-wires go lateral to lateral only. That's how. That is another case. He presented 2 months post-op, post-injury, and that is 2 weeks post-op. You can see here also, though it was 2 months post-injury, you can see with heavy traction, this fracture has broken off, and the volar piece has come into at the level of the joint. But at 4 weeks, when we removed the fixator, you find that there is a persistent subluxation. So at this stage, what you should do? The answer to that is, don't remove the distal K-wire, bend it like a hook, and then give rubber band traction to the finger so that the finger gradually flexes with the traction. And this is at 6 weeks, that all the collateral ligament laxity which has occurred because of the external distractor, that gets corrected. And you can see that 6 weeks in the flexion and extension views on the X-ray, the subluxation is reduced. And you can see a very well-formed volar lip. The intention of all the surgeries described hemi-hamate, volar plate arthroplasty, external distractor, anything is to create a volar lip in such a way that the joint does not have a persistent dislocation. So this is a very simple method to do that. He also had a mallet finger which we did not want to get treated. So this is 1 year post-op. And you can see an excellent result of flexion extension with this percutaneous method. This is a last case. I'll just run through it. This is same, treated in the same manner. And this is 5 years post-op with an excellent result. And that's, again, he had a mallet finger, which he did not want treatment. Thank you all for your attention. After this, after the questions.
Thank you, Parag. Thank you, Hemant. We will open it to the house in Bombay and we'll open it to the house thereafter across online. So any burning questions in Bombay?
I will require moderator's help to control the questions.
Moderator is here. He will give the final word. But Hemant, how do patients tolerate this fixator with you applying it in the middle finger, the K-wire sticking out on either side, hitting the other fingers? How do they tolerate it for the 6 weeks that they're supposed to?
Yeah. I would say the bonus for them is that no surgery has been done. No stitches, no surgery. Closed means level 3 surgery. Paisa bhi kam lagta hai. So everywhere it's a win-win situation for me and for the patient.
Sir, do none of the PIP joint fracture dislocations require open surgery?
If the fracture fragment is more than 60%, 70%, yes, they will require. Up to 50%, even I have gone up to 60%, they will not require open surgeries. And at 3 months also. Now, in fact, I have extended my indication to 3 months.
Open surgery?
Open surgery. No open surgery up to 3 months. Provided the fracture fragment is, I see a articular involvement at least 50%. It should be there. Some concavity should be seen. If the concavity is there, they will not require surgery.
And those who do not get open reduction, they always get an external fixation, or there are other means that you treat them by?
Yeah. I have got my own method of a volar plate arthroplasty, where I open the fracture and I regard that I treat this volar piece, volar lip, as a live graft. So I do through a Brunner incision, I do a shotgunning and I reduce this volar piece by open means and I fix it back with a screw.
So you do not
put an extensor block wire.
So you do not aim for a anatomical articular reconstruction. Instead, you just want...
I just want a volar lip to be formed.
Yeah.
And in those cases, I put a extensor block wire. And in those cases, there is no role of an external fixator.
So any role of non-operative treatment in PIP joint fracture dislocations? Are there any that you treat by non-operative? Just in the OPD and back?
Non-operative fracture dislocation, if they present acutely, if they are reduced, if I can reduce them by close means, if they present within 7 days, none of them require surgery. None of them will require even an extensor block pin.
Okay. And how soon do you send them to physiotherapy?
I don't send any patient to any physiotherapist.
Now I am slowly running out of questions.
Let's have questions to the...
Hello. Hemant.
Yeah.
Is it only for volar fracture dislocation or dorsal also?
No, dorsal fracture dislocation is an entirely different game. It's a totally different thing.
Sir,
in the dorsal fracture dislocation, an external distractor is used to protect the repair. Because the dorsal fragment is so flimsy, many times even after putting a screw, you are not happy. Or you feel that the volar, if I don't put a fixator, I have to control. In fact, there is a fight between the there is a fight between a thin, flimsy extensor central tendon and two strong, intact volar tendons. So if I don't apply an external fixator to restrain the PIP joint, I may have the PIP flexor sublimis and profundus working overtime and pulling out that repair. So I use an external fixator to prevent the PIP joint from getting into flexion.
Hemant, actually the question was that you don't send volar subluxations to the physio. What about dorsal subluxations?
No, I don't send any patient to any physiotherapist.
Just to correct the confusion, the whole of the talk was on dorsal dislocation with a volar lip fracture. What Dr. Karkhanis asked about was a volar subluxation with a dorsal lip fracture. Just for clarity, thank you.
Hemant, any ideas about how to prevent pin track infection for your K-wires?
No, if you don't take a stab incision, you will get pin track infection. Obviously, assuming that all the OT conditions are aseptic. But that's why you have to ensure a stab incision with a 11 number blade, expand the hole with a mosquito forceps, and then put the K-wire.
Another thing I remember in my good old days, they used to say that use tincture benzoin seals instead of.
No, you should not use. In fact, you should not have a seal. If there is any doubt of a pin track infection, let the thing flow out.
Okay.
So this is a question which was there in India, in Mumbai. I don't know how many of you heard the question clearly. The question was about pin tract infections, where Dr. Hemant Padrenkar said that please do take a stab incision. Do not put the K-wire without a stab incision. The risk of infection is higher if you do that. And then dissect with a mosquito till you reach bone and then put in your K-wire. Next question, we pass it on to the online. Yes, Jalandhar, please go on. Dr. Dingra.
Pankaj sir, there's a question from Kanpur.
Yes, please go ahead.
Yeah, Ajit, go ahead.
So there's a question in the audience that they're asking that can we use the Suzuki fixator at the place of these kind of distractor device?
In my opinion, wherever you think of using a Suzuki fixator, you can get these things done by close reduction itself. There is no role of a Suzuki fixator in those cases where, in the cases where a Suzuki fixator has been described. In my hands, all of them can be treated by close reduction. So there is no role of a Suzuki fixator in my hands. And secondly, Suzuki fixator in fact requires more precision than this technique because the K-wire is going very close to the joint. I am scared of the Suzuki fixator. I don't do it, I have not done it.
Yeah, we'll take a question from the floor here.
Neglected injuries. Is there any difference in the use of a handrail versus an electric drill while putting in a K-wires?
Hello, I didn't get your question.
Is there any difference while putting the K-wires to use a handrail or an electric drill?
No. With the handrail, you cannot get this precision. You should use only a very fine drill for this. You should not use a handrail for this.
Thank you.
Hello.
Next question is from Patna.
Patna. Sir, myself, Dr. Sasikant from Patna. So my question to you is, in two of the cases, you have shown that there was concomitant mallet finger. So is that real mallet finger, or it was because of over distraction of the digit that flexor tendon get contracted and that developed into mallet kind of contracture?
No. Patient had a long-standing mallet fingers, and then they developed these PIP joint injuries. They had a mallet finger which they did not get treated at all. So that was not connected with this.
So can we do concomitantly something for those mallet finger? Because
If they, no, in these cases, what I feel is that we'll be losing time since the mallet finger is 1 year, 2 year old, and patient has not taken treatment. As Parag rightly said, if they have not taken treatment for this, probably they are not having any morbidity because of the mallet. So patient has come to you or come to me for a treatment of a PIP joint fracture dislocations, telling me that this is an old injury, I don't want to get treated. So why should I offer treatment for him? Suppose he, after getting the treatment of the PIP joint, if he says that this is a deformity and now please treat it, I will treat him.
Okay.
Yeah, if there are no questions waiting from out of town, yes, please.
Oh.
What is the exact balance between how much, if you keep it for a long time, they get stiff. If you remove early, there will be some instability. So
No.
what should we do?
If you are asking me about
Ideal time of frame removal I want to
PIP
ask.
joint fracture dislocations, there is no role, there is no reason to get stiff because you are already started mobilizing. The MP joint is anyway mobilized because you are not applying any plaster to these patients. Secondly, the DIP joint you are mobilizing right from day one. So anyway, there is an intra-articular fracture. There is a 100% chance of stiffness if it is not handled properly. So you have to take care. In fact, that is why you are treating him for.
So 3 weeks, 4 weeks, when?
4 weeks. 4 weeks you keep the fixator and then mobilize him.
Yes, any other questions online?
They will develop stiffness if you send them to a physiotherapist.
And the cases where, sir, after 4 weeks you decided to put them in flexion, wouldn't they develop some flexion deformity after
Yes,
that? And how do you deal with that?
You have to be prepared to face this problem, to tell the patient that you are aiming for a flexion deformity actually. You aim for a flexion deformity and then gradually correct it with a capnal splint to get the extension. You want a flexion deformity. The problem is none of these patients have a flexion deformity. They all come with a stiff finger in the extension. So when they have a flexion, that means that the volar lip is well formed.
Pankaj sir, Dr.
Yes,
Ajit
Ajit.
from Kanpur.
Hi, Ajit,
when
tell
we will
me.
consider for the open reduction and fixation of the fragment in chronic injuries
Sir,
by shotgun approach?
sorry, can you just repeat the question, Ajit?
So when we will consider open reduction and fixation of the fragment, either it is malunited or it is fibrous non-union, and when we should go for the open reduction by the shotgun approach and fixation of the fragment.
Yeah, Dr. Bhatnagar.
Yeah, if the patient has presented very late, 6 months, 1 year, then I may consider open reduction. And we give a chance provided he has not had physiotherapy. Because if he has had physiotherapy, the passive movement 10 times in flexion extension will rub the head of the proximal phalanx, and then there will be no joint left to treat. So if the joint is good, suppose its patient is 6 months old, or suppose the fracture fragment is too big, then you should definitely think of open reduction, reduce the fracture, get it in line with the joint, and then fix it with a screw or a suture, and then block the extensor, block the finger with the extensor block pin. And then you can get a good result. The result is not very good in all these cases, but much better than by not treating it at all.
Yeah, let me just rephrase the question. Up to what stage from acute injury, in terms of time, will you employ the method that you described? Maximum. 3 months, 4 months, 5 months, 6 months?
Up to 3 months, I am definitely going to use a fixator, distractor.
It will work.
It will work.
Yes.
That's the right answer. Give a Cadbury to Hemant Patankar. Right? So this question is actually for Rohtak. You noticed, Rohtak, are you there?
Yes, sir, we are there.
Yeah. Hello, one question from Haldwani.
Before we ask the question, this question is for Rohtak. You saw the fixator that Dr. Patankar used for the surgery. What is the name of the fixator? Is the Ishimura fixator? Is it the Suzuki? Is it an AO fixator? Or is it a BB Joshi fixator? A, B, C, D. A consensus opinion is being developed.
BB Joshi fixator, sir.
Very good. I think Intas give Cadbury to everybody because now this was a consensus opinion. I don't think one person answered the question. Very good. That's invented by Dr. BB Joshi, who was a very famous hand surgeon, and under whom Dr. Hemant Patankar, Dr. Sudhir Warrior, a number of hand surgeons have trained and developed into excellent surgeons. So we now move on. Somebody else said they had a question. Was it Haldwani?
Yeah. Sir, for how long you are maintaining this distraction? Hemant sir, for 2 weeks or 4 weeks?
4 weeks.
4 weeks. So directly after 4 weeks, you are removing the fixator and then start mobilization?
No, after 4 weeks, we are removing the fixator, but not removing the K wires and taking a lateral views. Two dead lateral views, because many times we find that one lateral view is probably not dead lateral. So ensure that you get a dead lateral view. So once you are confirmed with the dead lateral view that the joint is not subluxating, the fracture is united, then only then you should remove the K-wires.
Are you applying any extension block splint in this post-operative period?
No, we are encouraging the patient to get flexion. So you give a dorsal gutter splint, but not a particularly an extensor block splint in particular.
Right. Sir, what's your protocol for treating, non-operative protocol for treating an acute PIP joint dislocation, fracture dislocation?
Okay, non-operative protocol is that once you are sure that you are getting a reduction, keep it into maximum flexion possible with a traction. I give a rubber band traction and keep the finger in flexion for 2 weeks. I find that by 2 weeks the patient is started developing a PIP joint flexion contracture. That is the aim of treatment. And your articular surface is well aligned, but ensure that your joint is well reduced at the end of 2 weeks with 2 dead lateral views. From both sides of the finger, you ensure that your finger is well reduced, and then gradually start him on active extension exercises only. Active extension exercises, he can have as much active flexion, active flexion as he wants, but just gradually allow him to actively extend the finger. He will always have a flexion contracture, which at 6 weeks, after you confirm with an X-ray that the fracture is completely united and the joint is congruous, then you give a Kapner splint and extend it completely.
Lovely.
But
So
no Kapner splint before 6 weeks.
So this was Dr. Patankar's protocol for an acute fracture dislocation. Any more questions, or can we move on to the next surgical demonstration? So I believe no more questions. Pankaj?
And before we move on to the next one, just one small comment. The basic difference between a volar lip fracture and a dorsal dislocation is that the volar lip is attached to a static structure called orar plate, and the dorsal lip is attached to a dynamic structure called extensor tendon. And therefore, the focus is on getting flexion to negate the action of the deforming force of the extensor. And therefore, whatever Dr. Patankar said, no forceful extension. Whereas when you have a dorsal fracture, an extensor tendon is attached to that dorsal fragment, which is going to pull apart the piece, which is not the case with the volar lip. And in those cases, the focus is on ensuring that the extensor tendon does not pull onto the dorsal fragment. And to prevent that, you need a stable fixation of that fragment. You do not have to acutely fix the volar fragment, but you almost always have to acutely fix the dorsal fragment. Over to you, sir, for your next demonstration.
Yeah. Yeah, again, this is again a very, very controversial condition to treat. That is the metacarpal neck fractures, also called as boxer's fractures in error. So this is a method which I have used, the bouquet technique, and this is a short video of 7 minutes. The very important thing is 1 minute. I want to stop the video in between, if possible. Let me play it from here. No, let me play it from here, please. No, I'm not playing it. Yeah, okay, sorry. No. So, very important is, oh shit. One minute. How can I pause it? Can you pause it? Yeah. So, Acha, space bar. Okay, sorry. So this is a fracture of the neck of the metacarpal, treated by various means. My preferred technique for a displaced fracture is to treat it with a antigrade intramedullary wires, also called as a bouquet technique, described by Guy Fouché in 1996. So it's a modification of the tens or the Ender's nailing for femur fractures. And so this is the technique, which is a percutaneous technique. It's a very safe technique. It's an extra-articular technique, does not hamper the tendons. For newcomers and for beginners who are not well versed with hand surgery, I recommend that they should practice the technique on the 5th metacarpal neck before they move on to the 2nd and 3rd or 4th. So this is the marking of the skin, which we do. That is at the base of the metacarpal. And you can take a transverse incision to give a good scar. You can also take a vertical incision. But the important thing is to identify, in the 5th metacarpal, case of 5th metacarpal, is identify the dorsal branch of ulnar nerve and identify the extensor digiti minimi. Save the nerve and go on the medial side of the extensor digiti minimi tendon, and then so that you can avoid injuring these two structures, and then make a hole in the bone which is about 8 millimeters away from the CMC joint. And then you can take an awl, or you can take a 2.5 millimeter K wire, because your intention is to pass at least 3 K wires into the shaft or into the intramedullary canal. So you can use a awl, or a small awl, or a 2.5 millimeter K wire. Make this hole, or you are using a C-arm all the time. And then I'll just show, this is the, some X-ray has gone somewhere. Okay. So then the same K-wire or the another K-wire can be bent in such a way in 45 degrees, 30 to 45 degrees, so that you can locate the canal with this. And like this, I'll go through the video now. I think what we'll do is we'll see you can see the entry hole, which is about 8 millimeters away. And then you're finding the canal with this K-wire. Now then you take 1 millimeter K-wires, 1 or 0.8 millimeter K-wires, don't use anything thicker than that, and cut their tips and bend the blunt end 30 to 45 degrees, like this. You can use a stout mosquito, you can use any bender, wire, pliers, something like that. And then the first wire, you can bend it with your hand. You can use this only as a handle. The first wire you can easily pass without the T, without the T handle, with your own hand. All the time you are using a C-arm, and now always invariably the wire will go on the medial side. At this point, at the fracture side, you turn the wire in such a way that, but very important thing to remember is that the close reduction has to be done by yourself. The wire will only hold the reduction, wire will not give you the reduction. And you can use this ice manure. And with your own hand, you just keep the MP joint in flexion, so that the pressure of the head, pressure of the base of the proximal phalanx keeps the reduction maintained. And then, because if you want to turn the wire further, that extra wire you have to cut, like I have shown you. The K-wire is rotated appropriately to support the reduction that is achieved. Yeah. You should push it. You can use a gentle hammer also to tap it inside. Ensure that you don't get any rotation of the little finger at this time. And this is a very important view, the supine oblique view, which tells you the exact location of the head and the wire. You cannot see the metacarpal neck in any lateral view, so you have to use the oblique views to ensure that your reduction is well maintained and the wire is well positioned. And very important thing is, once you are satisfied with the wire position, you should cut this end here, because otherwise you will cause inadvertent rotation while inserting the next wire. So you can see the wire has been rotated away from the fracture site so that it does not come out and is located well into the subchondral part of the head of the metacarpal. You cut the bent portion and you can use it to impact it. But don't keep the bent, otherwise your wire will invariably rotate inside. That's the first wire. Again, take a supine oblique view and a prone oblique view. The second wire, if you have difficulty in inserting with your hand, you can use it on a T handle and you can cut the end. You should cut the end, I would say, and then bend it between 30 and 45 degrees so that the entry is easy. This is a mini enders technique. You should have a short T handle, as I've shown you here. And the end of the tip of this K wire is impacted into a different quadrant of the metacarpal head, which ultimately gives you a bouquet effect. You can see both the wires are rotated away from each other. The fifth metacarpal can take up at least 4 to 5 wires because it's a very wide canal, but it's not compulsory to insert 5 wires in all the cases. So if you have to be confident of the stability, so you can, this is the third wire which I have inserted. That's the final impaction of that wire. Now, in order to know which wire has been inserted first, second and third, so you cut the wires at different ends and remember, and tell your assistant to remember also. Then the most important step is to have a very good wire cutter and cut the wires as close possible to the bone. If your wire cutter is not good, you should cut it under the skin but above the level of the extensor tendon. So I prefer to have a good wire cutter and cut it as close to bone as possible. So there is no question of removing them. So this is what we call as, or Dr. Joshi called as a segmental fixation. And I always give a dorsal slab to keep the MP joint in flexion. This is the same patient at 2 months post-op. This is photos sent to me by the patient on WhatsApp during COVID times. So K-wires maintain the reduction achieved by traction. They don't, the supine oblique view is essential. 1 millimeter blunt tip wires to be used. Entry point is 8 to 10 millimeters away from the CMC joint. And segmental fixation spares the tendon and the joints. I think we stop here. This is another case. This is another case just to show that how the K-wire was done in a different manner, a different person, different place, and immobilized in this unphysiological manner. And this should not be done. So this was treated by me with this segmental fixation, and that is 3 months post-operation. Thank you.
Sir. Sir, what should you eat before doing such a good surgery?
I think that was an incredibly elegant performance of the segmental wiring, or what he calls, do you also call it the metacarpal bouquet technique or something?
Yeah, it is also called as a bouquet technique.
Yes, so it's a technique. I'm sure all of you would love to do this and get the same kind of results. The talk is open to discussion. Any questions on the technique of surgery or for the indications? Let's ask the people in Bombay. Yeah, Rohan, come on.
Sir, what's the role for conservative management in these kind of fractures, indications and when not to do?
No, every fracture heals without the orthopedic surgeon. So it's not the question of conservative treatment. It all depends on whether patient is willing to accept that loss of knuckle. If the patient is willing to accept the loss of knuckle, the question of surgery is out. You tell the patient that you are going to treat it with only minimal access surgery, and he will have a good result without having any joint problems, without any stiffness, and he will have a good looking hand and good looking knuckle and a well functioning hand. And the other problem of treating these patients by non-operative means is that the fracture, if it is badly comminuted, then inadvertently the head of the metacarpal will be in the palm and he will have problems while gripping. So you tell him all these things. Yeah, function means patients in India will accept anything, surgery or non-surgery. So it is how you convince him.
Sir, 2 questions. Yeah,
Yes.
after you finish. Yeah, after your question.
Entry point not on the 5th, but on the 2nd, 3rd, 4th metacarpal when you're doing.
Yeah, so very important, a very good question.
So the question here was for the people online, maybe if you didn't hear it, that what if you had to do the same procedure on the 2nd, 3rd or 4th metacarpal, what would your entry point be?
Yeah, so after you graduate from the 5th, you should always treat the 2nd metacarpal, because that is the safest metacarpal to treat, because there is no extensor tendon right there. So the extensor tendon goes from the slightly on the ulnar side. So the important thing is to go 8 to 10 millimeters away from the CMC joint, make a entry hole 8 to 10 millimeters away, so that when your wire is sitting flush with the bone and you cut it, the cut edge of the wire comes exactly at the level of the CMC joint. If you take a entry point proximally, the other problem is that you don't get a 3-point fixation. So it's basically only a 2-point fixation and the fracture is likely to slip. So that is very important. For getting a proper 3-point fixation, your entry point must be in the metadiaphyseal area. So that is very important. So other part of your question, the most difficult metacarpal to treat is the 4th metacarpal, because it is surrounded by extensor tendon on all sides. So in this case of the 4th metacarpal fracture, you may have to cut the wire away from the bone under the skin. And then in that case, the wire will cause adventitious bursitis and you will have to remove it. But be careful of the extensor tendon only in the case of the 4th metacarpal, if done properly. Another problem which we have seen is that in the 2nd metacarpal, if the K wire is kept long, the tendon that is most likely to get ruptured is the EPL tendon, because then it comes very close to the bone when it is adducting the thumb. So your wire has to be, the entry point has to be perfect, and the wire has to be cut flush at the level of the CMC joint with a good cutter.
Sangli?
Yeah, so my question is there any scope for the removal of the K wires and also the size of the K wire? Can we use 1.2 millimeter?
No. 1.2 K wire has a temper of its own, and then you cannot control the wire. So it is better to use 1 millimeter K wires. You can use multiple K wires if necessary. In the 2nd metacarpal bone, the canal is quite narrow. So in that case, you may use a single 1.2 millimeter wire, because sometimes we have had difficulty in inserting even 2 1 millimeter wires because the canal is quite narrow. And
removal of the K wires, sir.
Pardon?
Scope for the removal of the K wires.
If the wire is inserted properly away from the CMC joint, there is no there is no need to remove the wires. If the patient has any fixation about removal of the wires, then you can definitely remove it. It's not very difficult, but there is really no need to remove.
Sholapur.
Question from Sangli.
Yes, question from Sholapur now.
May I ask one question from Solapur? How do you take malunited boxes fractures?
Hello.
Where audio is not very clear, Sholapur. Can you repeat it or send it to us by WhatsApp?
How do you take for a malunited boxes fracture?
Malunited boxes fracture. How do you deal with a malunited?
Malunited boxes fracture. There are various options to treat. One is you can open it, reduce it, and then you can use these antigrade wires. But then the fixation is not, because you have breached the periosteum. then you have to immobilize them till the fracture heals, then you have to undergo all the protocol of mobilizing the MP joint, mobilizing the extensor, flexors and so on and so forth. Other option is also you can use a plate and screws, but then the things start becoming more and more complicated and you will have extensor tendon problems and MP joint stiffness.
Yeah, moving on to Tirupati. Tirupati. Okay, Sangli has another question. Please go ahead.
Yeah. Your take on passing a screw. Nowadays, there are a lot of people, they are passing the headless screw from the metacarpal head directly into the shaft.
I think it's a very barbaric technique according to me. Because you are two things. Though there are a lot of pros, there are a lot of points which are experimental points given in favor of this passing the headless screw. First thing you have to remember is you are going to make a hole in the extensor tendon. Second thing is you are going to make a hole in the articular cartilage. If you can tolerate these two things in your mind, you can go ahead with that. But there is there are a lot of people who are advocating this, there are a lot of people in favor of this. I think it is a headless technique anyway.
Solapur has one question. Sangli has one more and then Burdwan. So Sangli, you start, then we move to Sholapur.
Good afternoon, sir. My question is sometimes patients present late. Sometimes patients present late and there is malunion of the neck and head of the fifth metacarpal. So how do you reduce it using gas maneuver and what are the...
No, if the patient is presented late and you cannot do a osteoclasis by closed means, then you have to be prepared to do all the techniques needed for open reduction and internal fixation. Then you may or may not be able to do antegrade wiring in every case. You may have to do even retrograde cross K wiring. You may have to do a combination of antegrade wire and a cross K wire. And there is no end to the amount of techniques that you may require to give a good stable fixation so that your extensor tendon and joint is not hampered.
So Sholapur.
Could the same thing be tried for metatarsal fractures, heads?
Can you try the same thing for metatarsal head fractures, Haiman?
Yeah, you can try it. I've done it for fifth metatarsal, but I don't get too many patients of other foot problems. But I've done once or twice in Rajawadi Hospital. But you can definitely do it for the metatarsals.
So
sir, we have a
The
question.
goal is to basically reduce and align it rather than to give a very stable fixation.
The goal is to not to damage the cartilage and damage the extensor tendon.
Right.
While doing any metacarpal or metatarsal fixation, as much as possible.
Let's move to Burdwan. Burdwan.
Good afternoon, sir. What is the exact cutoff point, that is the angulation, where you should go for this fixation?
No, actually, it's a very difficult thing to decide because you really cannot decide the angulation because you cannot see a lateral view. So the problem is, what is the problem with the patient is suffering? If the patient has a problem with the loss of knuckle, if the patient has a problem with the prominent metacarpal head, if he wants to have a good looking hand, then even 15-20 degrees is good enough for you to go in favor of surgery. If the patient says, I don't want to get operated by any means, then that's it. You can't operate him.
Doctor.
Sir, we have a question from Patna, sir.
Yes, we read your question. Please go ahead.
What should be the sequence of fixation if there are multiple metacarpal neck fractures? Question from Dr. Amulya Kumar Singh, Patna.
If there are multiple metacarpal fractures, what will be the sequence of fixation?
Yeah, you have to decide which is the most unstable one. And then you start fixing with the most stable one first. Because then suppose suppose there is a third metacarpal fracture. The third metacarpal, as you know, is at the height of the junction of the transverse and longitudinal arches of the hand. So you treat the third one first, so that itself starts giving some stability to the fixation. Then you treat the third, fourth, and fifth in that order. And in this case, you take a long transverse incision at the base, identify all the extensor tendons, and then identify the bases of the metacarpals, 8 to 10 millimeters away from the CMC joint, and then just insert the wires from there. The technique is closed. The reduction is closed by closed means. The fixation is by closed means. But the entry site is open so that your extensor tendons are not damaged.
Does that answer your question, Dr. Runu?
Yeah, thank you, sir.
Right.
Yeah, one more question from this side, Patna.
Yes.
Suppose you are fixing the fifth metacarpal with 3 K-wire. So is there any chance of fixing the other metacarpal with simple 1 K-wire only?
Yeah, it all depends on the size of the intermediary canal. So if the intermediary canal is thin, the fourth is supposed to have a thin intermediary canal. But in my experience, I found that the second has a very thin canal. But always, every patient is different. So you have to analyze the X-ray well in advance and decide. But aim for thin K-wires and number of K-wires instead of a single thick K-wire.
Hemant, what his question was that now that you've got stability by putting adequate number of wires in third, is it necessary to provide the same kind of stability in the others?
Yes.
Or just a single K-wire would offer it?
Adequate.
Is that, am I right? That is your question, isn't it?
Yes, no. Each metacarpal is different. Each metacarpal requires the same amount of respect. So you have to fix it with, it takes 2 minutes more. So it is not going to increase the surgical time at all.
Just to add upon it, if we fix the other metacarpals with single, then the rotation element can be a problem because you don't have a rotational control on that.
No,
the
actually,
bouquet, when it opens, that also helps
yes,
in maintaining the.
You have to take care of rotation in all these cases. So, but actually, when you have a transverse fractures or a slightly comminuted fracture, which are essentially transverse, there is hardly any rotational element in these fractures at all. So you have to ensure that you don't create a rotation by fixing it. That is more important than treating the rotational deformities.
Component then?
Pardon?
A comminution component is also there. Then.
Yeah, so for comminution you have to insert number of metacarpals, so you get a hat on hook appearance. So the hat on hook thing takes care of the comminution.
Right. Any other questions from the audience?
Haldwani,
yes, Dr. Haldwani, please go ahead. And then we'll have Dr. Karkanis from Bombay ask a question.
Sir, thank you. This is a beautiful technique I'm using since long year. Learn from you. Sir, one question. In delayed cases, 4 to 6 weeks, we are facing a problem while putting this wire. We are having distraction at the fracture site. So any tips to prevent distraction in delayed presenting cases 4 to 6 weeks?
Distraction?
After correcting the deformity, after correcting the osteotomy.
No, if you have a distraction at the fracture site, after you insert the first K-wire, you manually compress it so that your distraction gets corrected, and then you insert the second and third wire. But obviously, when you have 3 wires inside and your bone is still distracted, then probably it is difficult to get them collapsed. But with a single wire, you can definitely use that wire as a rail, compress the fracture, and then insert the second and third wire.
Thank you.
Yeah. Hello.
Yes,
yeah,
sir.
Dr. Patankar, I have heard of this bouquet technique from you for last 20 years. And I have used this without any problems for transverse fractures, oblique fractures, spiral fractures, B2 combination, B3 combination. And they have given excellent results. I am not a hand surgeon, but I have used this bouquet technique after hearing your lecture several times. And I am convinced about it.
Thank you, sir. Thank you, sir.
Yes, from where? Tirupati, please go on. Tirupati, are you on with us?
I'm sorry.
Yes, please go ahead. We can't hear you.
Hello?
Yes.
Yeah, it was about the number of K-wires.
How many K-wires should you put? Is that what you are asking?
Yeah, it's about that.
Is it okay to 1 KY or 2.5 or something else that can even manage the fracture reduction, something like that?
So can you use only 1 K wire instead of 2 or 3?
No, if there is, in the fifth, it is better to use 2 or 3, especially if there is more of combination, then it is better to insert more than this thing. In second, if there is in the rare case of only a transverse fracture, you can get away with a single K wire.
So you heard the answer that he prefers to use multiple K wires whenever possible. It gives additional stability, reduces the risk of subsequent displacement, especially if these are comminuted fractures. If, however, you still find that it is not possible like it is in the second metacarpal, probably just inserting 1 K wire is okay. Would you protect the patients post-operatively?
Yes, every patient is given a plaster slab, dorsal plaster slab keeping MP joint flexion, permitting IP joint movements for 2 weeks at least.
Okay. Yes, any other questions from our house here? No? Any questions anywhere else before we let Dr. Patankar go, showing us he is going to correct some floral bouquets from us instead of the metacarpal bouquets?
Last question, sir.
Yes, go on.
Yeah, what about the intra-articular extension of the KY? If there is some
I can't hear.
If there is intra-articular extension of this fracture?
No, this cannot be. This wire cannot treat the cannot achieve the reduction. So you have to do the reduction manually. If there is intra-articular extension, especially if the fracture is opening up, then you have to treat it by open means, reduce the fracture by the head fracture by a screw or a K wire, and then the neck element can be treated with this method.
Tirupati, does that answer your question that if there is a intra-articular extension, you will have to do an intra-articular stabilization of the intra-articular fragment through transverse K wires or transverse screw, and then put in K wires for the fixing?
I will add to this.
Yes.
If the articular involvement is not extensive, it is not in the, it is more on the, many times we have seen the articular extension is on the dorsum of the metacarpal head with a neck fracture. So in that case, what you can do is by judicious placement of the wire, the end of the wire can be directed away from the articular or the combination element, and you can direct the wire into the intact volar subchondral area, and still you can treat these patients without actually physically reducing the articular surface, and then also you will get a good result because you are essentially getting a close reduction.
Right.
But you have to make sure you see the X-ray properly and don't go out into the articular area when you are passing the K wire.
Sir, I have a question for you.
Yes.
You said plaster for 2 weeks. Why plaster? And 2, why in MP joint flexion?
Because you don't want good question. Because all these patients, when they have come to you, when they have got the injury, the metacarpal neck has hurt the extensor tendon somewhere or the other. So to prevent or to give rest to the soft tissues, after getting the correction, you always rest the hand in MP joint flexion, and that's anyway a safe position to get instead of dealing with the extension contracture of the MP joints later on.
Thank you, sir. Any other questions?
Before we move on to the next session, Dr. Kiran, who's a hand surgeon here in Bombay, is going to ask a couple of quiz questions. The first one is for Tirupati. Tirupati, get ready, please.
Thank you, sir. Thank you very much.
Thank you very much, Kiran.
Thank you.
In the context of Dr. Patankar's talks, now this is the splint which we have put up as a quiz question. Tirupati guys, can you identify what kind of splint is this? The options being the mallet splint, the swan neck splint, the Kepner splint, or a gutter splint or a extension block splint. Delegates from Tirupati? Anyone? Or we have audience in Mumbai saying unanimously it's a Kepner splint.
Kepner splint.
Okay, correct.
Who's that? Was that Tirupati which answered? Sangli answered it.
Sangli.
I think that was Dr. Iyer's voice, if I'm not mistaken.
Sangli.
Sangli, fantastic. Sangli, we
Yeah,
can give,
definitely.
I would request the INTAS rep to do the needful.
Thank you.
Right, let's move on to one more question of interest. Let's move to Sholapur. Sholapur, are you ready? Okay, this is a question for
Solapur, what kind of injury we are highlighting over here? Sharing.
What is this? What is the question?
The question is what kind of injury we are looking at here in the thumb, and any pointers in the MRI which reflects that injury.
Gamekeeper's
Solapur.
thumb.
Yeah,
The
Sholapur,
ulnar
what is the
collateral is
question?
avulsed.
Now if you answer this question, more chocolates, because he's not even giving you the multiple choice.
Game answers. Gamekeeper's thumb.
Is it gamekeeper's thumb?
So what is gamekeeper's thumb?
What is gamekeeper's thumb?
So the
What is the difference between skier's thumb and the gamekeeper's thumb?
A cricket ball and tape two thumbs to it and try to deviate it and see on X-ray one side the joint space increases, then you diagnose it. You don't need an MRI for this.
Okay, so what's the difference between skier's thumb and the gamekeeper's thumb?
No, if you are going to ask me one more question, we need more perks for that.
Yeah, so we will give you one more perk on that. Ek batatawada bhi de do to go with the chocolate. But anyway, we'll move on to the next talk. Let's move to the next session.
Yeah, and before we conclude this session, just one small comment. The procedure or the implant is never barbaric. Okay? It's the person who is using it is the one who introduces the barbarism. So, if you judiciously, even intramedullary screw fixation is a wonderful device. And if you do not use the intramedullary K-wire judiciously, they can be of lot of trouble. Dr. Patankar showed you a 7-minute video. If you ask him, the average surgical time for this procedure will not be less than 45 minutes. So it's a procedure which requires a lot of precision and a lot of practice. Thank you. Thank you, Nikita.
I thank Dr. Pankaj Aire and Nikita for this wonderful session. Now I invite Dr. Bipin Gangurde and Dr. Ashok Godke to moderate the session.
We now move on to the wrist session. During this session, we are going to show you volar plating, dorsal plating of lower end radius fractures. We will also show you a scaphoid fracture fixation. Anything else? And an open TFCC repair. That's how it's going to be. And this is going to be exciting because this is something which you all deal with on a daily basis. So without much ado, let me hand over the mic to Bipin Gangurde and Ashok Godke for chairing the session. I would request the chairpersons to be loud, slow and clear.
So I invite Dr. Nikita Chetty for volar plating of distal and radius.
It's not playing on the screen.
So I invite Dr. Nikita Shetty for volar plating of distal and radius. Yeah, Nikita.
I'm pressing please. I'm trying to feel it, it's not. So distal radius fractures, the bread and butter of every orthopedic surgeon. I'm going to take you through the steps of volar distal radius plating. So this was a 48-year-old female presented to us with an acute injury to the wrist with a fracture of the distal radius and a ulnar styloid fracture. So just a quick question, how many of you would consider this an extra-articular fracture? Nobody. So everybody agrees it's an intra-articular fracture. So my point is, intra-articular does not only mean extension into the radiocarpal joint. You can see that the fracture is extending into the DRUJ also. So that is also a very important joint for the movement of the wrist. So when you're classifying this, consider this as an intra-articular fracture. So that was the AB view. And that's the lateral view with dorsal combination, dorsal displacement of the fracture. Anybody who wants to conserve this? Just because I'm showing plating doesn't mean that all of you need to plate it. Anybody who wants to conserve it?
Doing any other investigation with this? Only X-ray?
Yeah, on the basis of this, would you conserve this? Okay, so nobody wants to conserve it, everyone wants to operate. Okay, so LaFontaine described 48. So there are criteria that describe and was described by LaFontaine where he said that, I'll just go back, sorry. Yeah, so where he showed that a dorsal angulation of more than 20 degrees, a radial height reduction of 5 mm or more, dorsal combination, patients more than 65 years or osteoporotic bones, ulnar styloid fractures and involvement of the DRUJ. These were the 6 criteria, and if they meet 3 or more of these criteria, an operative treatment is something that you need to consider. So operative treatment can be K-wires, external fixators and ORF with plates. With the advent of technology, we have well-polished, very low-profile plates available these days. So more and more patients and surgeons are opting out for this with very less hardware-related complications. So the incision is on the radial border of the FCR, just between the radial artery and the FCR. So before you inflate the tourniquet, it is important that you palpate the radial artery and make a mental map of where the radial artery is in relation to the FCR, because the distance can be very different in different patients. Sometimes it lies right next to the FCR, so you need to be careful, because once the tourniquet is inflated, you can't feel the radial artery. It's just the mental mapping that you have done before the inflation of the tourniquet. So that's the incision along the radial border of the FCR. At the crease, the incision is taken in a zigzag manner, so the advantage of this is we're not crossing the crease at a right angle, so chances of hypertrophic scars are very low. Secondly, the extensibility of the incision is much better. So if you want to get to the ulnar corner of the radius, it's easier with very little retraction, so you're not putting a lot of traction on the median nerve. And the third advantage is, sometimes these patients present with carpal tunnel symptoms after the injury, that come on after the injury. So first, check if the patients have tingling numbness in the fingers when they come to the OPD. If they do, I usually prefer to release the carpal tunnel at the same time as doing the distal radius. These patients respond better post-operatively. There are lower chances of CRPS if you release the carpal tunnel in patients who had symptoms. So the same incision, when you take a zigzag incision, you can extend it into the palm to release the carpal tunnel. So once the skin is incised, the FCR sheath, so there, like I showed the extensibility of the incision, you can get to the ulnar corner. In a straight incision, it becomes difficult because the white line that you see is the median nerve. So when you apply that much traction, the median nerve is getting compressed. Later on, the patient can have median nerve related complaints. So that's a zigzag incision. You can get to the ulnar corner without a lot of traction, and look at the scar. It's much better than a straight incision. So once the FCR sheath is incised, the radial artery is carefully retracted by the assistant. So until and unless you identify the FPL, do not let your assistant retract the FCR, because the median nerve is around 7 to 8 mm medial to the FCR, sometimes right under the FCR. There have been instances where I've seen the median nerve right under the FCR. So if you're retracting the FCR, the median nerve is also under pressure, or the assistant might just retract the FCR and the median nerve can be exposed to your knife. So look at the FPL first. So you can do a simple finger dissection. So that is the FPL. You can see moving the IP joint. So once the FPL is identified, retract the whole thing. So the median nerve is under the FPL, you're not causing any trouble there. Once the FPL is retracted, next is to elevate a flap of the pronator quadratus. The pronator quadratus is carefully detached from its radial most attachment, creating an ulnar-based flap. I always make sure to preserve this pronator quadratus and try to suture it over the plate after the fixation. So take it off as one single flap very carefully. You can use a periosteal elevator. But while you're doing this and when you reach the fracture site, be careful, because sometimes there are small fragments in this muscle. You're not dislodging the fragments or you're not taking them away. Be very careful when you're elevating the pronator. Any interposition of the pronator from the fracture side needs to be cleared. Next, once the fracture is fully visualized, a bone holding forceps can be used to control the proximal shaft. The fracture is then gently reduced with traction and manipulation. And this is confirmed on the C-arm. So now if you are happy with the reduction, the next step is to hold this reduction with a temporary K-wire. You can use 1 or 2 K-wires depending on how the stability is. Next comes selection of the plate. So these plates come in various sizes. The selection of the plate should depend on the size of the radius. Make sure that the plate is not too big and therefore does not cause any hardware-related complications. In this patient, because the wrist was very small, we used a narrow plate. So once you place the plate in a satisfactory position, we stabilize the plate with 2 1 mm K wires. There are designated holes, small holes in the plate to do that. Once those wires are in place, bend the wires and cap them. The best material to use is a 6-number infant feeding tube or a scalp pin. This is so that the wires don't pierce into your glove or the assistant gloves while the procedure is going on. So these wires keep the plate in position as you proceed with the fixation. Next is drilling the cortical hole. So the cortical hole, the first hole, I prefer drilling it in the oblong hole, because if you feel that you need to adjust the plate, you can still do it. Once you put it in the round hole, you won't be able to adjust the plate distal or proximal. So put it in the oblong hole in a position from where you can adjust the plate later on. So this is a 2 mm drill bit. The screws are 2.7 mm screws. Next, the length is measured with a depth gauge, and a star drive 2.7 mm cortical screw is used. So there you see, I'm adjusting the plate to come a little proximal and then tighten the screw. Now, once you're happy with the position of the plate, next, we go on to the distal fixation. So these plates are called variable angle plates because the distal screws can go at an angle of 50. So you have a provision of 15 degrees in each direction for you to put the screws. So the sleeve is a conical sleeve. It has slots that go and sit in the plate. So make sure you have secured them so you don't have to hold them while you're doing drilling the bone. So there is an X-ray with the sleeve on, and that is how much provision you have for the screw to go. So you can direct your screw to the appropriate position. The most ideal position to put the distalmost screws is 2 to 3 mm proximal to the subchondral bone. That's a good position where you can hold up the subchondral bone and the articular surface. Any more than that can cause it to cut through the articular surface. Or if it is lower than 3 mm, it has been seen that there is a chance of articular collapse later on. So this helps to support the articular surface. So there is in this patient, we put it right in the center of the sleeve, and we achieved a good position for the screw. So once we put the middle 2 screws, the next is the ulnar-most and the radial styloid screw. So these 2 screws are very critical. The positioning is very critical. Make sure when you're putting the ulnar-most screw, you're not going into the DRUJ. Check multiple times. Be satisfied with the positioning before you put in the wires. Next comes the radial styloid screw. This screw needs to be pointed to the tip of the styloid. So you can see there, that's the drill. The blue line is the distal end of the radius. And the drill is pointed towards the tip of the styloid. So you can drill it while you're watching this in the AP view. And always adjust the drill bit as per your convenience. If it is not going to the tip, you can adjust it, look under the C-arm, and then proceed forward. So that's after adjusting the drill bit to the direction that we want it to, and now you can see that it is going towards the radial styloid. In the lateral view, the red line denotes the radial styloid. The peak is the tip of the radial styloid, and you can see that the screw is pointing towards the radial styloid. That is the most ideal position for the radial-most screw. So once this is done, if you feel that the fracture is stable, you can remove the temporary K-wire and finish the fixation with putting the rest of the screws. The second last hole in the shaft is where I prefer putting a locking screw instead of the last hole, because it reduces stress risers. Putting it on the last hole can cause stress risers. So that's the locking screw in the second hole. That's a 2.4 mm locking screw, star head. So placement of the plate. So when you're placing the plate, there are Soong's grades which can help you to identify the ideal placement of the plate. Soong's grade 2 is when the plate is dorsal. The red line is the critical line. So when the plate is dorsal to the critical line, it's Soong's grade 2. This is the most ideal position for a volar plate to avoid any hardware-related complications. But sometimes there is some mismatch between the anatomy of the bone and the plate. These plates are anatomical plates, but there is some mismatch, sometimes some variations. So grade 1 is where the plate is volar to the red line, the critical line, but is still proximal to the rim of the distal radius. And grade 2 is where the plate is volar and distal to the rib. So the grade 1 and 2 is somewhere that I would advise the patient to get the plate removed once the bone has healed completely to avoid any hardware-related complications later. So while placing the plate, you have to be very careful of the positioning of the plate. So like I said, that's the rim of the distal radius. So the median nerve and the flexors are very close to the rim. So if the plate is at grade 1 or grade 2 Soong's, it can irritate these structures and cause adhesion ruptures of the flexors or can cause compression of the median nerve. So what happens when you can't get the plate to the bone? So when you can't get the plate to the bone, you try to get the bone to the plate, which we also call as plate reduction. So here was a 60-year-old female, came with a displaced fracture of the distal radius. After we put the plate on, we still could not get the volar tilt proper, or the plate was not sitting flush to the bone. So here what we did is we used joystick wires from the dorsum, put it into the fracture site, we used 2 wires and then used this to press the distal fragment onto the plate. And then went on with the fixation. So there's the plate sitting flush to the bone. The fracture went on to heal very well. The patient did not have any hardware-related complications and regained good range of motion. So this is another case where we've reduced the fracture, fixed it with temporary KYS, but we still saw that there is still some translation. Can I go back? Oh, sorry. Okay. So here what is happening is when I'm trying to press the plate down on the distal fragment, it is lifting off from the proximal fragment. That means if I press this down, this is going to stay off. So how do I solve this problem? So this problem can be solved with a simple technique known as a kickstand technique, which means that you press the plate flush on the distal end of on the distal fragment. Use a locking screw in the last hole of the plate without drilling the bone. So it holds the plate up like a kickstand of a bicycle. Now, as the plate is flush on the distal fragment, you fix the plate to the distal fragment. You put all the screws on the distal fragment. There, now the plate is sitting nice and flush to the distal part of the radius. This screw is still there, the plate is lifted off. So the next aim is to get the plate closed. So look what is happening. We removed the screw. Look what happens when we press the plate down. The Voedeler tilt automatically corrects itself. So this is exactly what we'll achieve when we tighten the cortical screw. So the locking screw is removed, the cortical screw hole is drilled, and a 2.7 mm cortical screw is tightened. When we are doing that, make sure that you're holding onto the bone and the distal end of the plate very firmly. You just don't leave the hand to flop here and there. Hold it firmly. And with the whole reduction, you need to get the wrist in volar flexion to give that additional support so that the screws don't back out from the distal end. That is the final X-ray. With a well-reduced fracture, the plate is sitting well. So here is one more technique that we used to reduce these fractures. After reducing it and holding it with temporary wires, on the lateral view, there is still some translation there. So how do we overcome this translation? We tried reduction, we removed the wires, we tried it again. It was not possible to reduce that translation. So what we did here is we used dorsal wires. So we went from the dorsum, very thin 1.2 mm wires from the dorsum, making sure that on the volar side you know where the nerve is, you've retracted the nerve, you've retracted the vessels, only the tendons, only the bone is seen. You go with 2 wires from the dorsal to the volar side, keeping all the soft tissues clear of it. Next, we bent the volar side into a small hook. So we use these 2 wires as hooks to pull it back to the dorsum. So these are the hooks that were created with the wire. Again, making sure all the soft tissues away from the bone. So that is how the X-ray looked. That is the hook that was created, the wire from the dorsum, and now both these wires are pulled back. And that is how the translation was reduced. Now you can see that there is a small fragment going there, but it was not creating any trouble. So that's the final fixation. So now don't forget that those hooked wires are still there to remove. You don't just forget them inside. So next, what we need to do is we push the wires a little volar. Again, making sure that the tendons and the nerve is away from the wire. We push the wire a little forward. We cut the hook with a good wire cutter, and then we pull out the wires from the dorsum. So that's the final X-ray at 8 weeks. The fracture went on to heal very well. The patient regained good range of motion. without any hardware-related complications. So coming back to our current case, after the radius is fixed, the next step, because this patient also had a radial, ulnar styloid fracture, if you noticed in the beginning, check for the DRUJ, check for how stable the DRUJ is. In this patient, the DRUJ was quite stable, so we left the ulnar styloid alone. So this is a different patient who also had a ulnar styloid fracture, and after fixing the radius, when we looked at the DRUJ, it was quite unstable. So this is one of the indications to fix the ulnar styloid. So here what we did, we used a very thin 1 mm wire to hold the styloid, because the X-rays, in the X-rays you see like this is a very big fragment, but when you're actually going in to deal with them, these are very small fragments and very difficult to handle, especially if it is done closed. We attempted a closed reduction in this. We used a 1 mm wire to hold the ulnar styloid and joystick it and pressed it down to the ulna and fixed it with a K-wire. So that's the present case that I'm coming back to. That's the final X-ray with a well-reduced fracture and a well-seated plate. So once the fixation is completed, like I mentioned in the beginning, you need to keep a good pronator quadratus sleeve that you can suture onto the plate. So the advantages of this is, one, that it gives a good cover for the soft tissue, so soft tissue attrition is much lesser. The second is when you're going in for a plate removal, so you have your planes defined, you know exactly which planes you need to go to. And third is that pronator quadratus is a dynamic stabilizer of the DRUJ, so you need to put back what you removed. It's always best to put back whatever you cut open. The skin is closed, and after the dressing, the patient is given a dorsal functional slab. Put thin wisps of cotton or cotton gauze pieces in the web spaces so that the skin does not macerate because of sweat. Next, a single roll of 4-inch plaster of Paris is what I prefer. It is covered in a single layer of gauze bandage. This helps in reducing plaster loss and also helps in easier removal of the slab during the dressing. The wrist is kept in 10 to 20 degrees of extension. The MP joints are kept in 45 to 60 degrees of flexion, which is a good functional position of the hand. And the fingers are kept free on the volar side to aid early mobilization. So once the plaster is applied, while the plaster is wet, we ridge the plaster on the center. So this ridging increases the strength of the plaster by 240%. So because we're using just one roll, this plaster might seem very thin. Textbooks say 12 layers and 14 layers. There are hardly 8 layers that come on in one roll, but when you ridge the plaster, it increases the strength by 200%. So now volarly, the bandage is cut up till the MP joint to keep the fingers free. And you can use a 1-inch micropore to stabilize the palm onto the plaster so that the movements are happening at the fingers. And the patient is encouraged to move the fingers as soon as they are out of anesthesia. If it's a block, once the block wears off, or if it's a general anesthesia, once the patient wakes up, the patient starts moving the fingers. These plaster, we do a first post-operative dressing on the 4th day, reapply the plaster. The plaster is kept for at least 2 weeks. At 2 weeks, if the patient is comfortable, if the X-ray shows a stable reduction, we remove the plaster, give the patient a removable splint and start mobilization. Thank you.
Oh, excellent presentation, Dr. Nikita.
Thank you.
Yeah. So how do you decide? I mean, the proximal and the distal screws, proximal in the shaft and distally, the number of screws, how do you decide?
Proximally, the best choice, my best choice would be a 3-hole plate. Distally depends on how comminuted. Sometimes you see that the radial styloid is a separate fragment. It's not stable. So I prefer putting the second row of the radial styloid also. And on the ulnar side, if the ulnar corner needs extra support, if it's an intraarticular fracture with the ulnar corner as a separate fragment, I prefer putting the second screw on that side. Otherwise, just the top row is what we prefer.
Yeah, doctor. Yes. Ask a question.
How do you fix a druge? Any transverse K-wire are you going to fix for fixation of druge, healing of druge or not?
Yes, I have used transverse K-wires, but once we've reduced, in this case, once the ulnar styloid is reduced, I usually give them a above elbow plaster for 3 weeks in supination, which keeps the DRUJ stable. But suppose there is no ulnar styloid injury and still the DRUJ is very unstable, that means there is some kind of DRUJ injury. I put a wire from the ulnar into the radius and maintain that for 6 weeks.
Okay, thank you. Same.
So, yeah.
Dr. Nikita, I think Dr. Warrior had himself said this, that if you put a wire from the ulnar to the radius, it will form a bone bridge and it will prevent pronation. I remember him saying that in a BOS clinical meeting in 2002 in KEM.
Yes.
So this was with Dr. Warrior, and now you are saying that you'll put a wire across from the ulna into the radius and keep it for 6 weeks.
I remember this question, sir, you asked this in the BOS meeting also last time.
Then what is the answer?
Yes. The wires are usually put proximal to the sigmoid notch. We try to avoid that so that there is no bony bridging there. And I have used these wires for 6 weeks. I have not seen any kind of synostosis post this wire. The idea is to put it proximal to the sigmoid notch. A lot of times we've seen wires that are put very close to the sigmoid notch. So if you keep it proximal to the sigmoid notch.
So there is a big controversy. Dr. Pankaj, could you answer this question
Pankaj.
in an elaborate way?
But the wire from the ulnar to the
wire,
radius.
should we use it? Whether to use the DRUJ wire or not to use? DRUJ K wire.
If the cause for instability can be addressed, it should be addressed. For example, if there is a foveal fracture and if it has not fallen in place, the easiest way to treat this is to fix the fracture. DRUJ wire is a good method if you think there is only a soft tissue cause of the injury, then it is very likely to heal with just a transfixation of the DRUJ. Likely, there will be cases in which it will not heal and may require an open TFCC repair later. We can always convince the patient to live with the problem, but if we don't want to do that, then we have to treat the problem. Personally, in my practice, I've never used a DRUJ wire except in cases of Galeazzi fractures, which are not very common in my practice. And at a time when I was not very familiar with TFCC repairs. But now that I'm far more convinced that you should address the problem rather than try to treat them indirectly.
Sir, in cases of only soft tissue injury, only the TFCC injury, have you ever primarily repaired the TFCC while doing a distal radius fracture, or you wait with the plus?
No, if at the end of my fixation, if the DRUJ is unstable and there is no styloid fracture to tell me where the TFCC is lying, then I have gone and repaired the TFCC.
So, Dr. Varade?
In these situations, we do wrist arthroscopy post-fixation of the distal radius, and if we found that there is a frank peripheral tear of the TFCC and frank displacement, then we repair it on the same time. Then it becomes stable.
In
I said that's what she said, that if TFCC is repaired and it's still unstable, then we think about a K-wire.
No, sir,
No, I was saying we don't repair the TFCC
any
primarily.
question
If
from
it is unstable, we just put a wire and leave it on for 6 weeks. The TFCC heals on its own is what. But there have been cases where they have repaired it.
No, I have also not put wire in any time. We just see it arthroscopically, confirm it and repair it. That's
So, arthroscopy is a very high level thing.
So when the injury is acute, and the healing potential is at its maximum, then there is no harm in doing what you are saying. Absolutely. Chances are that the TFCC may heal. but then there chances are that it may not heal as well.
So anything outside Bombay? Anyone wants to ask a question outside Bombay?
Question from Solapur team. Yeah, you can go ahead and ask.
Solapur, yes. Asit Chidugupka is there, I think.
Yeah, I feel that for dorsally displaced, especially with the dorsal convolution, a volar plate is not just a buttress plate here, and you've got good results with external fixator and good quadrilateral wires for the different fragments.
We are unable to understand the
No,
question.
the question is that sometimes in dorsally comminuted fracture, where there is a lot of comminution, use of a bone graft with K-wires and external fixator is a better. Is that correct, Sholapur?
Even usually buttress plate for Barton's fracture. For dorsally displaced fracture, it may not be an ideal option, as I feel.
Can you text the question, doctor, from Solapur?
Can you text the question, because we are unable to hear you very well, sir.
How do you explain a dorsally displaced fracture lower of radius which needs a dorsal buttress, whereas people are using buttress plate? How do you explain us? And we've got good results with fixators.
Sir, please write it on the chat box and send it to us. We will answer it definitely. But we are not able to answer, specifically hear the question. Can we move on to the next question? Any question from the house over here? Yeah, Burdwan, please ask.
Hello?
Yes, Burdwan.
I have two questions actually. If you have to fix the, drooch, that is, you have asked to use the K-wire, single K-wire, but single K-wire, is it sufficient to fix it up? Whether you would advise single K-wire or two K-wires, number one. Number two, if you have advised single K-wire, is there any incidence of breakage of K-wire in 6 weeks of time?
Yeah, thank you for the question. So to answer the first question, is a single K-wire stable enough? A good 1.5 mm K-wire. We keep the wrist in full supination and then pass the wire from the ulna to the radius. It is pretty stable. It is basically to avoid rotations at the wrist. And to answer the second question, yes, I have seen one case of breakage of the wire. It was not at 6 weeks. The patient had come around a year after his surgery. The wire had broken inside. He was using his hand. He was doing everything. So the one care that you can take is when you're putting the wire from the ulna to the radius, keep the wire a little proud on the radial side. So even if the wire breaks in between, you have something on the radial side to hold it and pull it out. So keep the wire a little outside the bone on the radial side also.
Hello.
Okay,
I'm
so there is
Dr.
a
Praveen
question.
from Patna. Hello.
Yeah, Patna.
Yeah.
Please ask the question.
Yeah. Sometimes there is still, despite plating, a good plating, volar plating, there is radio ulnar instability, DURJ instability. Then what to do?
So if there is a DRUJ instability after good plating, what to do?
Yeah.
So if there is DRUJ instability, it can be two scenarios. Either the ulnar styloid is fractured. So in that case, like I showed in one of the cases, we go in and fix the ulnar styloid. If the ulnar styloid is not fractured and if it is a TFCC injury, I put a ulnar radial wire in a supinated position. But like Dr. Varade and Dr. Pankaj Ahire said, these days you have an option of arthroscopic assessment of the TFCC. And you can go in and repair the TFCC if there's any kind of tear or instability at the DRUJ after the fixation of the distal radius.
So there is a question from Sholapur. How do you explain that a dorsally displaced fracture is fixed with a volar locking plate, whereas it needs actually a dorsal plate?
So that's a very good question. A dorsally displaced fracture, yes, but a lot of times you'll see when the fracture comes to you early. Once you achieve the volar tilt, the whole dorsal part falls into place until and unless the dorsal part is a separate fragment, it's an intra-articular fragment and it's not reducing. In that case, once you have done the volar reduction, you need to go in dorsally and reduce it dorsally and put in a dorsal plate. That is something that you need to explain to the patient. And in such cases where there is an intra-articular extension with a separate dorsal fragment, get a CT scan done pre-operatively so that you can assess these fractures and explain it to the patient. But a dorsal plate is always an option. So when I'm ordering my plates, I ask them to put in dorsal plates also, just in case I have to go dorsally and reduce it.
Yeah, Kari sir wants to answer or comment. Yeah.
Dr. Nikita, I had a question that if the ulnar styloid is broken, right, and it is displaced, and to that the TFCC is attached, then how do I assess? How can it be stable?
So then you go in and fix the styloid.
No. What I'm asking you is, if the ulnar styloid is avulsed or broken, it will be unstable or not?
That if the TFCC is attached to the styloid, 100% will be unstable.
Yeah, so any fracture which is displaced of the ulnar styloid, it will be unstable?
Not any fracture. Fractures mostly at the base of the ulnar styloid. The tip of the ulnar styloid, not so much, but fractures that go across the base of the ulnar styloid, there are chances that the TFCC may be attached to it and it can render the DRUJ very unstable. So go in and fix it.
In fact,
So you want to?
Yeah.
Dr. Patel.
Hello. Yeah, in fact, that question which is put up there, how do you explain a dorsally displaced fracture is fixed with a locking plate, whereas it needs a dorsal plate? That's not a good question at all. In fact, it means that we have not understood the X-ray. If all fractures of distal radius will invariably displace dorsally, if the volar cortex is not, if the volar cortex of the displaced or the fracture fragment is not attached or it not linked to the volar cortex of the distal of the proximal radius, so that means that the fracture is not conducive for a dorsal plate. Only when the volar cortex is hinged at the level of the fracture site and the fracture is angulating dorsally, and only in those cases there is a dorsal indication for a dorsal plate, or if there is a very badly comminuted intra-articular fracture, because intra-articular fractures cannot be addressed from the volar side.
Dr. Pankaj Ahire will also.
So this case was an indication for a volar plate only. If the volar cortex is displaced dorsally, it's a case for volar plating. If the volar cortex is attached or hinged at the distal radius on the volar side, but fracture is angulated dorsally, then it's a case for dorsal plate.
So if it is comminuted, sir, if it's a separate piece, dorsal, comminution.
Yeah, but if the whole radius is shifted dorsally, you can treat it very well with a volar locking plate, which is a gold standard. It's a very safe plate to do. Dorsal plates are not easy to do. If your instrumentation is not perfect, if your plate placement is not perfect, if your soft tissue handling is not perfect, you'll end up in much more problems than if you do a volar plating.
A lot of times, even when there's dorsal comminution, this is what I've observed.
can
It
get
comes
away
back.
with the-
Yeah, it comes back into place once you've restored the
Yeah.
anatomy.
In fact, another thing which I would suggest is if there is a lot of comminution on the dorsal, on the metaphyseal area without intra-articular comminution, wait for 7 days, let the swelling come down, and you'll get a very good result by just pulling on to the soft tissues with a volar plate.
Okay. Dr. Dhingra from Jalandhar. Yeah. And then we'll take one comment from Dr. Pankaj Ahire. First, Dr. Dhingra from Jalandhar.
Yeah. There is a question from Dr. Sanjeev in the audience that if there is a separate fragment of the radial styloid, how do you manage that?
Separate fragment of styloid.
If there's a separate fragment of the radial styloid, there are different ways of managing it. Once you provisionally reduce the fracture, see how stable that fragment is. A lot of times I have left the K-wire that we use to stabilize the fracture through the radial styloid along with the plate. So don't shy away from keeping K-wires. If it is still unstable, comminuted, you can always go in and fix it with a radial styloid plate. But that is something that I personally have never had to do. It has always stayed in place with 1 or 2 K-wires from the radial styloid. So you don't remove the temporary wires. You just keep them on, cut them close, bury them under the skin and take it off once the bone has healed.
Dr. Nikita.
Yes, sir.
Yeah. So I had asked the same question to Warrior on phone once, that do you require fixation of the dorsal fragment in a colossus fracture as you showed? And he said what all people have said over here, that if you fix the fracture volary, the dorsal fragment fall in place and they unite. So as you said, it is really, I think somebody said that it's not an easy job for a non-hand surgeon to do a dorsal plating, one should not venture to do that.
One
So
more
we
question
have-
from Sangli.
Yeah, Sangli.
How do you assess intraoperatively the screw lengths or in the distal fragment? Any different view you suggest to be taken on the image?
Yes. So the screw length, I'll come to two things. One is the screw placement and the screw length. Like I showed the screw placement, the best position is to be 2 to 3 mm just below the subchondral bone, not too close to it and not far away from that. The screw length, there's a very nice paper that mentions that the length of the distal screw should be as much as the load-bearing surface, length of the load-bearing surface of the distal radius. That means the AP diameter of the lunate. That is the area where most of the load is going to be on the distal radius. So the screw length need not be more than that. So the, if you can have, can you play the video?
Yeah, ma'am, just for the DRUJ, after 6 weeks you remove the wire. Have you ever felt there is still there is an instability, it has not healed? And has there been any case where you have felt to reconstruct the DRUJ using a palmaris tendon or maybe any?
Not in one of the cases that I have done, but yeah, there have been cases of long-standing DRUJ disruption where we've had, but I think in my experience I've seen only 2 of them being done. Most of the times when the DRUJ is stabilized, when the wrist is stabilized, most of these injuries heal well.
Thank you.
So,
Can you just show me? I'll just come back to the question of the length of the screw quickly.
Yeah.
Okay. Can I have a pointer? Oh, yeah. So length of the screw, you see this lunate? So the diameter of that lunate is what is going to load on the distal radius. When we see a lateral view, the AP diameter that we see is in respect.
Sorry, madam, we could not hear it.
So the AP diameter that we see is in respect to the Lister's tubercle. That is the highest point on the radius. But that is not the part that is being loaded with the lunate. So your screw need not go till the Lister's tubercle. The length of the screw has to be as much as the articular length of the articular surface where the lunate is going to load on the distal radius. That way, you reduce the risk of the screws being long on the dorsum, which will eventually rub against the extensors, especially the EPL, and cause attrition ruptures.
Thank you.
About the view. So we take
At-
Oya's view to see the length of the screws.
Yeah.
And we'll move on to the further talk. I invite, and thank you, Dr. Nikita.
Thank you.
And I invite Dr. Pankaj Ahire. He will be speaking on open TFCC repair.
I just want to make a small comment. The lunch is being served outside. You can take your plate and come inside. Okay, there will be no formal.
How dare you, Parag?
Moderators can see the moment you stand, they will not dare to go out.
No,
okay?
no, please. For first 5 minutes, I am not going to talk much sense. So please get your plates. Sir, remaining time, I am going to speak a lot of sense. Don't laugh like that. So just I cannot help but comment on the question from, I think, Sangli or Solapur about dorsal plates being used and volar plates being used for dorsal displaced fractures. Now, every fracture of the distal radius can be fixed either by volar or by dorsal plate. And the reason that we have that flexibility is because now we have angle stable plates. If we did not have angle stable plates, then if you wanted to plate a dorsally displaced fracture, you had to go dorsal. And if you had to if you had to treat a volar Barton's or a Smith's fracture, then you had to go volar. What the locking plate allows us to do is, it allows the plate to be used as a reduction tool. And therefore, you can treat a dorsally displaced fracture using a volar plate. That still does not spare us from using the correct maneuver for reduction. The reduction maneuvers for a dorsally displaced fracture and the volarly displaced fracture still remain different. We are simply using a volar plate to hold the fracture in its position, and it is allowed to do, it allows us to do that because the screws are angle stable. If the screws were not angle stable, then we will not be able to use volar plates for all the fractures. And dorsal fixation is not all that difficult. Okay, if you, but the good part is you don't need a dorsal fixation for most fractures, except dorsal shear fractures, where there is a dorsal subluxation and the volar rim is intact. There you have no choice but to go dorsally. Okay. Not necessarily. If those dorsally displaced intra-articular fractures are reduced well, they can be held with a volar plate. Sorry? Yeah, please.
So if there is a small styloid fragment which is stable and distal radius has been plated, what would you do in terms of immobilization post-surgery, or would you immobilize?
If the DRUJ is stable, then I would ignore the ulnar styloid completely and mobilize or immobilize the wrist on the merit of my fixation of the distal radius and nothing more.
Okay. Are we starting?
Yeah, but provided this, yeah. Tell me, am I ready? Yeah. No, it's not moving. Yeah. Okay. Since we did talk about a lot of TFCC repair in the talk, in the previous talk, I thought I will share this with you. So this is a typical DRUJ instability. Now this one was not associated with the distal radius fracture, and this is the typical MRI picture where, may I have a pointer, please? Yes. Oh, I think people they will not be able to see. Yeah. So if you see my cursor on the screen, that please don't move from there. No, I'm not. Yeah. If you see the cursor on the screen here, that is called the fovea, and that is where the part of the TFCC. That is where the part of the somebody is moving the cursor. That is where the part of the TFCC which renders stability to the DRUJ is attached. Whereas there are ulnocarpal ligaments which are attached to the tip of the ulnar styloid, which, though important, do not confer any stability to the DRUJ, and therefore small styloid fragments may not, even if they are displaced, they may not contribute to the stability of the DRUJ and may not require fixation. So this was a pure soft tissue injury, and this was subjected to an arthroscopic evaluation. So now, for any soft tissue problems of the wrist intra-articular, now wrist arthroscopy is kind of a standard of care. Though there is no harm in approaching the TFCC without doing a wrist arthroscopy like this, I think doing a wrist arthroscopy allows us to treat other aspects like the synovitis of the joint, which can be a great contributor to the pain. Now this is the foveal tear. You can see I can lift off the entire TFCC with a hook. You can see the struggle. It's a very tight joint. Yeah. So that's the TFCC which is torn, and this is. You can repair this arthroscopically, but you can also do it open, and there is not much difference in the outcome of the two. Yeah, as you can see, after the arthroscopy, I have chosen to do open repair for this. Now, whenever you are approaching the ulnar side of the wrist, your entry is through the fifth extensor compartment. You heard about dorsal plating of the radius, which is approach to the radial side of the wrist from the dorsum, and it is always to the third extensor compartment, which is the EPL. So the radius dorsally is approached through EPL, whereas the wrist or the DRUJ dorsally is approached through the EDM, extensor digiti minimi. So this is the line of, this is the extensor carpi ulnaris. There's two lines that I have drawn, and just next to it, that is the sixth extensor compartment. This line of the incision is the fifth extensor compartment. That is where the incision will be placed. I don't know why the cursor keeps moving without, no, something's happening to the cursor, darling. Okay, my hand is not shaking that much. I don't have those many tremors yet. See, again, I do not know why the cursor keeps moving on its own. Yeah, please do something. So that's the incision. It's a liberal incision, good 5 to 6 centimeter incision over the fifth extensor compartment. You identify the extensor digiti minimi tendon. That's your extensor digiti minimi tendon, and that's your DRUJ. So your right extensor digiti minimi tendon or the fifth extensor compartment is right over the DRUJ. You open the extensor compartment so that you can flip the tendon on either side. It should be very easy to retract. There should be no struggle in retracting the extensor digiti minimi. Just follow the path of extensor digiti minimi, and the tendon is kept aside. Now a plane is developed between the extensor retinaculum and the underlying DRUJ capsule. It's a gentle dissection. In chronic cases, you will find that this division between the extensor retinaculum and underlying capsule may be very difficult because the capsule will be completely attenuated. Now, once that plane is developed, you start walking a hypodermic needle from the ulna, and where it enters into a soft spot, that is the under surface of the TFCC. Same thing you start doing from distal to proximal, from triquetrum to the TFCC. And where it enters, that's the top surface of the TFCC, distal surface. Between the two is your TFCC. Now this is the structure you don't want to cut transversely. This is the dorsal radioulnar ligament. So you open this capsule using two L-shaped capsular flaps. So these are the two L-shaped capsular flaps, one distal and one proximal. In between is your dorsal radioulnar ligament, which you don't want to cut transversely. The distal L-shaped flap opens the ulnocarpal joint, whereas the proximal L-shaped flap will open the distal end of the ulna under the TFCC. This will open the DRUJ, the vertical limb of the L. You can see the glistening ulna head inside. You will see it when I lift the flap. Yeah, that's the ulnar head inside. So that is how it is. So TFCC, ulna head here, and the triquetrum there. Okay, and in between is the TFCC. Just ignore this. This is for the peripheral tears. This patient did not have peripheral tear. Okay. Now I am holding the TFCC back of my spike. Okay. It is detached from the fovea here, where my nibbler is now removing all the fibrous tissue and the granulation tissue. making sure the tissues that I want to heal, I'm making them raw again. Okay? Now that's, the TFCC is behind my spike, and I'm inserting a 2.2 millimeter anchor with a 2O suture, 2O ethibond into the fovea. Now you let the TFCC come up by removing this spike. The TFCC has come up. Now I'll place a very bold suture, a very broad bite into the TFCC so that the TFCC gets pulled onto the fovea again where it belonged. When you have an ulnar styloid fracture, the advantage is you can use ulnar styloid as your template, and then you don't need to take this approach. Then you can approach the ulnar styloid through a straight incision between the ECU and the FCU, straight away onto the bone. So that's the second bite. And now when I tie this, the TFCC will get anchored to the fovea. You put a sliding knot. You put a sliding knot. Now when you do this, you place the hand vertical. All this while it was lying horizontal. Now you place it vertical in a mid-prone position. Because in mid-prone position, the tension on the volar and the dorsal limb of the TFCC is equal. And that is the position in which you want to fix it. So you slide the knot into the fovea and then tighten it. When you pull the other limb, it locks. And then you throw 3 more knots, and that completes your TFCC fixation. TFCC alone is not enough to stabilize the DRUJ. You will again need to repair the capsule. And one of the very good contributors to stability of DRUJ is your dorsal extensor retinaculum. Dr. Ravi Gupta from Chandigarh has described use of the 5th extensor compartment retinaculum, double breasting, as a method of stabilization of DRUJ, and that should be added to this procedure. So now the 2 L-shaped capsular flaps have to be sutured back where they belong. There is no double breasting done here. They are sutured in their anatomical position. So the L-shaped flaps are sutured. That's the distal flap being sutured. And then, now we leave the 5th extensor compartment tendon, which is the extensor digiti minimi, out of the compartment and repair the extensor retinaculum underneath it by double breasting it. I'll just show you one stitch of double breasting. So this adds to the stability of the DRUJ. So you can see the overlapping of the edges of the 5th extensor compartment, and thereby that too adds to the stability. And that's it. And then it's closure. That's the repair.
Thank you, Dr. Pankaj. So all this while...
Just a moment.
Yeah.
Just one slide. So there is no difference between the open and the TFCC repair much, except that the open TFCC repair may be associated with transient ulnar neuritis, transient, otherwise not. Having said that, an arthroscopic repair is a far less morbid procedure than the open one. Okay, thank you.
Good presentation. So
Thank you.
there are two questions from my side. First question is that you repaired the TFCC in mid-prone position, and the remaining things again you kept on the table.
Yeah,
like
because they were repaired in the anatomical position that they were.
So okay, so double breasting was also done in.
Yeah, double breasting was was all about just tightening the dorsal tissues, which will push the ulnar head back to where it belonged. It will not determine the final position of the DRUJ. The final position of the DRUJ will be determined by the foveal attachment.
Okay. And what about the ulnar nerve?
Yeah, so in this approach,
approaches.
Yeah, in this approach, the ulnar sensory nerve practically does not come in the picture.
But you said there is a direct approach for the styloid fracture fixation.
Yes.
Where it might come. So
Yes,
any tips for that?
That is the structure under danger, and it should be visualized, retracted, and kept under vision all the time. And therefore, sorry Nikita, the method that you showed of percutaneous fixation of ulnar styloid, I somehow do not agree with that, because percutaneous fixation of ulnar styloid is fraught with chances of dorsal sensory branch of ulnar nerve. Except, see, somebody who is very, very familiar with that anatomy of that place will know the surface marking of the dorsal sensory branch of the ulnar nerve, and you will avoid it. Somebody is not familiar with that territory is much better off placing an incision, identifying the nerve, retracting, and then putting a wire.
Yeah. Any questions from audiences here and outside Bombay, Mumbai?
Very interesting and very elegant display, a demonstration of TFCC. Till now, I had only heard of TFCC as something as a structure. Didn't even imagine what it would be. Looks like it was a meniscus over there.
It is a meniscus.
Between the ulna and the carpal bones. So first time I've seen it in my life. It was very nice to see it. Anybody? All right, Dr. Phadnis.
Hello, nice video. I enjoyed it. I had never seen TFCC featuring any time before. I have a simple question. A lot of times we get a patient who probably had some injury some time back, and he has a dislocating ulnar head. Now, one question is this related to the TFCC injury, or a lot of times we have done taking a graft and suturing the ulnar lower end to the radius with a, tendon going across. This operation was described long time back for preventing the dislocation and making the patient uncomfortable. Now, I wanted to ask you whether you have any other alternative for this, or is it because of the original TFCC injury or anything else? Thank you.
So a dislocating or an unstable ulnar head is almost invariably a result of a loss of control of TFCC over the DRUJ. There are other contributors, but if other contributors fail and the fovea is intact, the ulna cannot dislocate. So these could be acute or chronic injuries to the TFCC. I'm not very sure I understood the question, part of the question which said tendon passing through the step for stabilization. Okay, so the reconstruction with the ECU sling was for an unstable ulnar stump after the ulnar head was excised. In that situation, there is no DRUJ. So the mobility of the DRUJ, that is supination, pronation, will not be affected. If same thing we were to do with an intact ulna, it will probably not work, and it has not been tried. Though a tendon graft reconstruction of the DRUJ has been tried, where we need to create a ligamentous structure between the radius and the ulna. Just having the ECU holding onto the ulna and leaving a disconnect between the radius and the ulna is not going to work, because every time there is a supination or a pronation force, the ulna will subluxate. It will also depend on the anatomy of the sigmoid notch on the radius. In which area it is flat, the ulna will dislocate on that side. So the ECU sling will not work with an intact ulna. Okay. Is there any part of the question which I have not answered? Yes. Yes. Yes, it has. It definitely has. And even up to 3 months, I feel there is good chance of giving a trial of immobilization in a plaster cast above elbow for 6 weeks for these patients to heal. Though literature says that up to 1 year you can go ahead and repair it, and after 1 year you should consider a reconstructive procedure, I have found even up to 3 years from the index injury, the TFCC remains in a perfectly repairable condition. So unlike a dynamic structure like a supraspinatus tear, the TFCC does not degenerate after tear. Okay, so it is very much repairable. So reconstructive options for DRUJ are quite rare.
Let's move to Jalandhar. Jalandhar, Dr. Dhingra.
Hello.
We are waiting for your question.
Sir, that was last time.
Many times we are saying that, hello, are you listening?
Yes, we are listening.
Yeah, from Haldwani. Sir, many times we are seeing that MRI is reporting that TFCC is tear patient is having medial wrist pain, but DRUJ is looking stable. In that situation, should we go for this repair, or we have to go for conservative till?
Good question. So a TFCC repair is required only to render stability to the DRUJ. So if the DRUJ is stable, there is no indication to operate or repair the TFCC. I'm not saying there is no indication to operate. Occasionally, chronic irritation because of tear of the TFCC of that portion which is not contributing to stability can also lead to wrist synovitis and may require arthroscopic synovectomy. Now coming to the MRI reporting tear, MRI done in an acute setting will overdiagnose soft tissue injuries. So refrain from doing MRI within first 3 weeks of index injury. It will overdiagnose. Having said that, given the expertise of the radiologist in reporting wrist MRIs, take their reporting with a pinch, with a fistful of salt when they say there is a TFCC tear. Your decision should be based on clinical suspicion alone, supported by the MRI. Do not act only on the MRI report. Yeah. Does that answer your question?
Thank you, sir. In cases of your repair, TFCC repair, in cases of DRUJ instability, are you augment your repair with some K-wire or some slab, just above elbow slab for 6 weeks?
Yeah, not with a K-wire, always with a plaster, above elbow plaster in mid-prone position for 6 weeks. There is no compromise on that. Patients who do not agree for this preoperatively, they do not get a surgery.
Let's move to Agartala now. Agartala.
Pankaj sir, Ajit.
Hi.
Ajit is speaking.
Kanpur, please wait.
Yeah.
Let Agartala finish, and then we'll come to you.
Good afternoon, sir. My name is Dr. Joita. Sir, I wanted to ask the screw size, the anchor suture size you are using, and the point of entry.
So for TFCC, I have used a 2.2 millimeter metallic anchor with a 2O fiber wire suture. Okay, I would not hesitate using any other anchor as long as I get a 2-0 suture with it. Yeah.
Thank you, sir.
Right.
And the entry point, sir?
Entry point.
Entry point is right in the fovea, where the original fovea is a easily identifiable structure at the base of the ulnar styloid, you will find a slight crater where the TFCC dips into the bone. It's a easily identifiable structure, but in a chronic injury, it will be filled with fibrous tissue. So needs to be cleared off all the fibrous tissues to create a fresh injury with a maximum healing potential. But it's a easily identifiable structure at the base of the ulnar styloid. It is almost in the middle of the upper end of the ulnar surface, almost in the middle.
Right, let's move to Kanpur. Ajit, go ahead.
Yeah, Pankaj sir, so you do open arthroscopic repair, you do arthroscopic TFCC repair. So what is the difference you find in the open versus arthroscopic repair of the TFCC one? My second question is that how often you go for the stabilization of the ECU subsheath by putting the anchor in the ECU groove? Many times you need to, that the deepening of ECU groove and putting the anchor and stabilizing the ECU subsheath. So what's your take on this?
Yeah, so I will answer it one by one. Between open and arthroscopic, I did open repair at a time when I did not know how to do arthroscopic foveal repair. So arthroscopic, there are two ways of repairing TFCC. One is a peripheral tear, in which we do a capsuloligamentous repair, which is fairly technically easy. Arthroscopic foveal repair is technically demanding. But now that over the years I have been able to do that, I have not gone back to an open TFCC repair. Having said that, literature says that there is no difference in the outcome of the two procedures, except that there is a bigger incision on one and there is a smaller incision on the other. So very little to choose. But as I said, you are disrupting far less number of soft tissues in arthroscopic. So post-op recovery is probably a little smoother course when it comes to arthroscopy. But the immobilization protocol for both is same. Okay. The ECU subsheath, have I deepened it for a ECU subluxation? Yes, I have. Have I anchored the subsheath anytime? No. Ajit, as I am getting older and older, I'm resorting to more and more simple immobilizations for the soft tissues to heal. And I realize that good external immobilizations work as well as very extensive internal fixations.
Thank you. That's a very good message coming from a very experienced hand surgeon. And let's move on to Jalandhar. Jalandhar, any questions? Burdwan has a question, but before that, we'll ask Jalandhar. Jalandhar, how is the Josh?
How is the food?
Fantastic, sir.
Josh is good, right? So please go ahead, ask us some questions. No, you are all right. You are busy enjoying the meal. Please go ahead. Burdwan, we'll move to you.
Sir, will you tell us something about the self-Kafanji procedure in this context?
Okay. Sowe-Kapanji procedure is one of the salvage procedures for the DRUJ. It is a procedure where if the DRUJ cartilage is not amenable for a good function of a joint, essentially an arthritic joint or a large malunion into the DRUJ, especially from the ulnar side, where we would fuse the DRUJ and create a pseudoarthrosis proximal to the distal ulna. It is a technically demanding procedure, but it is one of the salvage procedures where the DRUJ is painful because of arthritis or destruction. Other options for Sowe-Kapanji are Dara procedure, where you excise the distal ulna, just maintaining possibly the ulnar styloid and the TFCC intact. And there is another third procedure which is quite favorite with Dr. Patankar, where he just does a cuff resection of the ulna and doesn't touch the DRUJ. Is that right, sir? So these are the three options available, the other two being options to the Sowe-Kapanji. Sowe-Kapanji is a technically demanding procedure, and the success of your treatment ultimately depends on fusion of two bones. So you are leaving something to chance again. So therefore, my preferred salvage method is a Dara procedure.
Thank you very much, Pankaj. That was very enlightening and a lovely demonstration of TFCC repair. We now move on to the next.
Thank you, Dr. Pankaj. So we move on to, I request Dr. Kamble to come on the stage. So there is a lot of fear about dorsal plating in distal. I request Dr. Prashant to elaborate on this.
So we heard that dorsal plating is difficult, not to be done by if you're not doing routinely. It's quite easy. I would say it's more easier than doing a volar plate also. What you just need is know the anatomy very clearly. That's it. And for that matter, everything what we do in orthopedic is knowing anatomy correctly. 80% of the time you just need to know that correctly, and rest 20% is your experience, whatever rest other things, principles and everything. Not this. The second one. So the most important aspect of dorsal plating is, one is indication. This patient need, yes, this one. So dorsal. Okay. So the only indication for dorsal plating is dorsal combination, dorsal shear, that what we discuss. So you're playing from there, or should I? Here. Okay. So, yeah. Is it on? Can we go back? All right, start now and let me handle. So the indication for dorsal plating we will see in subsequent X-rays. And as I said, knowing anatomy and everything, rest other things are you must knowing that. So dorsal plating is required in all the patient who has a dorsal displacement, dorsal shear fracture, but indicating that intact volar cortex. As you see in this X-ray, all the volar cortex are intact and the fracture fragment is displaced dorsally. So there is a dorsal die punch, lunate has sink down. So all those become and this is what important is one should look on the CT scan, that your dorsal cortex is sheared off and there is an intact volar cortex, because what it need just a dorsal buttress. And what is the advantage? You can see intra-articular impaction, you can elevate, fix, buttress, and rest other things. These are all the parameters that one should be keeping in mind. So this is the case. This patient is a pathologist, had a history of fall 2 days back. As you can see, there is a dorsal combination and the volar cortex is pretty intact. So this is dorso-ulnar fragment is quite comminuted and there is a lot of comminution in the metaphysis. So again, the axial CT suggestive there is a dorsal combination and there is a dorsal shear sort of the radiological picture. So surgical, this patient had other issues so the bone quality was also relatively poor. The patient is under general anesthesia. On the dorsal side, you mark your incisions. So either you can take a straight incision, a slightly curved incision, or you can make proper zigzag incision where you are distalling the extensor tendon likely not to get adhered to the skin scar. But over a period of time, I found that it doesn't make much of the difference. It is just which corner that you want to address that decides your incision. So either dorsal ulnar or dorso-radial. So you can curve incision on that site. So once you start taking the skin incision, what you see is a dorsal vein. They're quite prominent here. Prefer to ligate, because even if you cauterize them, once you release the tourniquet, they start oozing. So better you ligate with the Vicryl or stay sutures, whatever way you want. So again, to prevent the skin dehiscence, you take incision just below the fat pad, where you can see your veins and the fracture hematoma. Moment you reflect all those things, because this is what we want. At the end of closure, you want your plate to have a good soft tissue cover on that. So you see there is hematoma start coming out. That is again is a good plane where you can go. So after this, next step is to identify the entry to dorsal side. That is identifying your EPL tendon. To find that, you need to cut your extensor retinaculum in a S-shaped manner, so that once your procedure is done, you can put it back with a good amount of length, and that will prevent the bowstringing of your extensor tendon. So one limb going vertically, one limb transverse throughout all the extensor retinaculum, and the other end going inferiorly. So this is like something, it will open up like this, and at the end you close the end to end. So there you find the EPL tendon. So you can see there is EPL, thumb is getting pulled. So that is your gateway or entry to dorsal side. So continue your retinaculum incision, and then you will find the dorsal second compartment, that is ECRB and ECRL here. This one. So these are the second compartment, this is the third compartment, that is EPL. That is your fourth extensor compartment, EDC. And here you come the upward vertical incision of extensor retinaculum. Once you've done adequate incision, radialize the EPL tendon, so that will give an access to the dorsal side. Take out from the groove at the level of Lister's tubercle and completely radialize it, and post closure also you just keep it on the radial side, don't put it back. So third and fourth compartment. There you see your posterior interosseous nerve terminates. This is like a sensory to the dorsal part. You just cauterize it, denerve it, partial, and there you see your fracture hematoma. I can felt it with the flexion and extension, that is intraarticular, the radiocarpal joint, and here see the impacted fracture fragment. So that is just radial to listus tubercle. So I'm going more and more towards the styloid fragment. That is one styloid fracture fragment, dorso-ulnar side. This is at the center. This is more on here, is dorso-radial side. So double door open technique, where the dorsal radial, dorso-ulnar, you just open and you see the amount of combination, what you can see. It is completely impacted, and this is what exactly is all those patients require the dorsal buttress plating. So what you need here is just disimpact. So that's a metaphyseal defect, indirectly indicating you need to put bone graft there. It's a carpal bone, radiocarpal joint. So we use here bone graft substitute. So your assistant give the traction and disimpact the fragment. So whatever is available with you. Put plenty of bone graft so that it will buttress, it will add on to your buttress. Once you are happy about bone graft, this is how it is looking now. Even with the bone graft, all the restore, it looks like it has restored. Now it is time to just put the door closed now. The dorso-ulnar, dorso-radial. So you see the adequate size of plate. This is a pre-contoured plate. Place and see under C-arm about the length going to dorso-radial and dorso-ulnar side. So look like plate has gone little ahead. So readjust and slight traction, and then you can pass one cortical screw, so that will buttress the entire construct. Once that is achieved, you just need a cortical screw that will buttress the dorsal surface, and this is what has been done. So you have, if you pass that screw, you have a length where you can adjust your plate forward and backward. So that is the advantage. So the plate is little taken on back side, since it was going a little in the articular surface. Once that is done, what you need, just pass the rest of the screws. All locking screws. So scrutinize your construct under fluoroscopy. It's quite stable. And then what you need is just a closure. So important point here for the closure, I don't put back the EPL tendon from where we have reflected. Just dorsal capsule is important point because all the dorsal-radial ligament, they are attached. And this is what retinaculum, which I have told, once you cut in a S-shaped manner, you get an adequate length to close it. Here I have used drain because patient has a lot of other metabolic issues. Otherwise, I don't use. So absorbable subcuticular sutures with sterile tapes. Post-operatively, give the slab to reduce the pain and swelling. Once the patient is good, means in terms of the pain and swelling, remove and start the range of motion. So this was the range of motion at the 6th week. Doesn't look that good, especially the palmar flexion. But the issue with the dorsal plating is you will get some amount of restricted palmar flexion in the post-operative period. But she's back to do all her activities, and there is a good functional range achieved. So understand the fracture pattern where this dorsal plate is required, and you can execute just what it needs in a good exposure, and it is as simple as like a volar plate.
And the other is at 90 degrees on the radial styloid, right?
So that totally depends on the fracture configuration. Pre-operatively, you have to decide about that based on your CT finding. So if you have this kind of plate in one where the T is, the distal part of T and vertical limb is attached, then it can be done with the one plate only. If you don't have access to those plates, in that scenario, you can use dorso-radial and dorso-ulnar as a separate plate. But again, as I said, it totally depends on your fracture configuration, what you see on the CT scan.
This is which company plate?
This is Arthrex plate.
Right.
These are pre-contoured, highly polished, low profile. So this sits very nicely on the back.
One more thing, like there is a problem with the extensor digitorum tendons, which might rub, and that is the main fear what is going on in our mind. So if we do a subperiosteal resection, I mean,
yes.
If we dissect it and we lift along the periosteum, then there is no question of ED being rubbing on the plate. Any comments on that?
Yes, theoretically, answer is yes, subperiosteal elevation. But when you put your plate, it is quite difficult to get that completely covered. You will have some part of plate is exposed. And that where the part of extensor retinaculum comes, where you can just put underneath of that, and in between that you can keep your extensor tendon. So there is a sandwich between extensor retinaculum itself, between the plate tendon and again extensor retinaculum. There you can put all those soft tissue, which whatever you get to get close over the dorsal part.
Yeah. Any question from the house?
Yeah.
When we are dealing with unstable comminuted distal radius fractures, can you highlight some, sir, any pre-op on the X-ray or on the CT scan, or any intra-op assessment that now, along with the volar plate, maybe this patient also requires a dorsal plate for stabilization. So any markers on the X-ray or CT or any intra-op assessment that will help us to know whether now a dorsal plate will be needed. Yeah.
I think pre-operative CTs can only help you with that. Based on X-ray, sometimes we see the patient with the X-ray, and moment we give the traction, it aligns everything. Okay, but once you start putting the plate without, of course you have done the CT. Once you start doing the volar approach, once you put the plate, if you find those all parameters are okay, then you check the stability, take the fixation through the complete range of motion, and whether it is stable or not. If it is unstable, dorsal combination, dorsal, like those 2-3 fragments where you cannot have a purchase from the volar side, then yes, you need to go dorsally and fix that as well.
Okay.
Out of Mumbai, any question? Yeah, Dr. Karkhanis.
You are leaving the external policies as such. So normally I find that it's coming from the leg side and going to the off side. I will say it's a leg break. Now it is in the straight line. So does it cause any weakness in the EPL action?
Initial few days, yes. Initial few days, there is some kind of extensor lag you can expect, but over a period of time, that is also overcome. They get full extension without any problem. But there is a problem when you put it back in the groove. There is a high possibility it may scar and may have a less excursion of EPL there.
Any role of ligamentous in this case?
For this, I would say no. There is highly comminuted fragments. Then those preoperative only we can decide. Where the intact volar cortex and the dorsal combination is unlikely to work with ligamentotaxis.
So we have a question from Sangli. Shrikant, Dr. Shrikant.
Yeah. Here, I'm here.
Yeah, you have a question, right?
Yeah, I have a question regarding the styloid fragment many of the times has got a coronal splits, especially when you are approaching from dorsally. So they have advised a separate styloid plate.
That can be fixed with the very well with the K-wire. It's like a hybrid fixation along with your plate. You can put in K-wire and you can just get away with that only.
Any questions from anywhere else? Yeah, I can see Kanpur. Kanpur is asking a question. What is the role of strut grafting in lower end radius fractures? When do you decide to do it, especially in the time of locked plates, which offer so much more stability? Do you really need to do strut grafting for any of these fractures acutely?
There are two school of thoughts on that. There is one school of thought that says you just put a plate, no graft, it will heal. They have published. There is another school of thought, you need a lot of graft, put a plate. Both work well. If you put a graft, it will give you ease of mind at the end of day that it is not going to collapse along with your reconstruction.
Patna, I see a hand up from Patna. Any questions? Dr. Runu?
Can we ask from Sholapur?
Yes, absolutely.
In a given case where is dorsal subluxation with crushing of the dorsal rim, is there any role of suturing out dorsal capsule to the plate as we do in a volar rim plate? Or if there is a persistence of dorsal subluxation, do you reduce it, fix with the KY temporary?
We, if you have seen the video, we sutured it where we have cut intra-articular to see the intra-articular impaction. So yes, you can suture back from where you have cut, or you can suture it back to the edges of the plate. But it is for dorsal side, you can easily suture back to the capsule.
So, Dr. Karkhanis.
Prashant, you said that on the volar side, the fracture has to be, the bone has to be intact so that you can put the dorsal plate. But now in a volar and dorsal comminution, it is, I think only Warrior only had told me that you have to fix the dorsal side because the volar screws will not have any hole dorsally. So then how does that plate fit dorsally when there is a volar combination intra-articular?
In that scenario, sir, I would suggest to go both side plate, because once you have constructed one side, then you can address the other side only. Then either way, you just need a buttress, you don't have to put the screws. You just need something that is holding there.
So there are no screws in the plate, just the plate and no screws?
Either if you are putting the dorsal plate with the screw, then you just need a volar plate with no screw in the
Without
metaphysis.
screws.
Yes.
Like an anti-glide plate. Right. Okay. So any other questions? Right? Otherwise, we can move on. Thank you very much, Dr. Prashant, for a lovely presentation.
Now, next we call upon Dr. Amit Varade, who will present bone grafting in scaffold non-union. Scaffold non-union bone grafting.
So we are going to see, every time you press this, because it shuts down on its own. We can't hear you at all.
Okay, so we are going to see scaffold non-union bone grafting.
So we are now going to see a very, very common fracture, mistreated, poorly understood, missed, everything. And that is the scaphoid fracture, which has always been a point of lot of controversy, discussions among orthopedic surgeons. And Amit Varade here from Nasik is going to actually demystify the approach to the scaphoid fracture and how to do a nice bone grafting for that.
Okay, a very good afternoon. Thank you, BOS, for giving this opportunity. This scaphoid non-union is a very common problem. As Zaveri sir said, so this patient is 26-year-old young patient. He had scaphoid fracture before 6 months. And he was treated by giving cast, by conservative management. But later on, after removing cast, he noticed that there is no union. It has gone in non-union. So we can see whenever we approach these patients, first we have to see where is the fracture, whether it is in the proximal pole, whether it is in the west, or whether in the distal part of the scaphoid. So in such cases, we do iliac crest bone grafting and fixation. Fixation is either by K-wires or by headless compression screw. So the approach is very much like the approach of distal radius. So here I am palpating the flexor carpi radialis tendon. Take a hockey shaped incision along the FCR tendon and curve it slightly on the lateral side. So like distal radius, expose the FCR tendon first. Identify the FCR tendon and open the sheath from the volar side. Once we have opened it, retract the FCR tendon on the ulnar side. Here, as compared to distal radius, we have to go a bit distally on the carpal side. So now with open the sheath of the FCR. And now we have exposed the capsule of the wrist joint along with the radioscaphocapitate ligament. So this is the marking where I have put K-wire. This is the scaphotrapezial joint. It's just a marker up to where we have to take incision. So this is a zigzag type of incision which we have to take on the capsule because it contains radioscaphocapitate ligament, and it is a very important ligament and which we have to suture it later on because it acts as a fulcrum during flexion extension of the wrist joint. So once we reflect, now slowly reflect the capsule from the scaphoid. And the whole scaphoid is now exposed. So a lot of times we cannot see non-union. We can see non-union very well on the X-ray, but now we cannot see any non-union over here because there is a lot of fibrosis at the non-union site. So you see the waist part, central part. This is the part where I have put K-wire inside and slowly open up the non-union site with the help of osteotome. Whenever we deal with scaphoid non-union, the challenge is to maintain the vascularity, and lot of times scaphoid don't unite due to less vascularity. So when there are some principles which we should keep in mind. The margin of the non-union site is sclerose. So whenever we do dissection, just remove the sclerose margin. And we use this technique, we use this 1.25 wires in proximal and distal pole of the scaphoid. It helps in taking hold on both the fragments because whenever we nibble out the fibrosis and sclerose part, we need to nibble it on both sides of the in both inside of the scaphoid poles. And we use this technique. We pass we do multiple drill holes into the proximal and distal pole of the scaphoid, just to increase the vascularity, like we all do for all the cases of non-union. And here. For this case, we have used iliac crest bone graft. We can use lower end radius bone graft also, but generally we prefer this iliac crest bone graft because it gives a very good quality and quantity of bone graft. So this is a corticocancellous type of graft which we have used over here. So this is cancellous part. Nicely impact the cancellous part in the proximal and distal pole of the scaphoid in the cavity which we have created. And this is a very good instrument, McDonald's, which gives very good, in hand surgery, this instrument is used at a lot of places. So once we have filled the cavity of the scaphoid, now the central non-union part, this is the corticocancellous bone graft, very small, 2 mm or 3 mm only, and nicely impact it into the non-union site. Once we have done this, next is method of fixation. There are a lot of methods are there. We can use K-wire, we can use headless compression screw system also. For this case, we have used 2.4 mm headless compression screw system. Pass a guide wire in the central axis of the scaphoid. Confirm the position of wire in 3 positions at least, in the PA view, lateral view and pronated oblique view, because scaphoid is like a twisted twisted structure. So we need to confirm the wire in all the positions and we drill it. We do this thing before passing drill. We just pass the K wire into the lower end of radius a bit, 2 to 3 mm, because lot of times when we remove the drill, it just comes out. So after measuring the required length of the screw, suppose whatever length we are getting, we just subtract 4 from that length. Suppose if we are getting 26, then take 22 size screw only, because we are burying the screw in the scaphoid and there is compression at the non-union site also. Rest of the part also filled with the cancellous bone graft. And this is the radioscaphocapitate ligament which I was talking before exposing the scaphoid. We repair it with 3,0-ethylon. And this is our post-operative protocol, thumb spica plaster cast by keeping the thumb IP joint free, and we do once a month X-ray, and for after 1.5 months to 2 months start active range of movement, but by continuing the splint, and after bone union passive range of movement and muscle strengthening exercises can be started. Thank you very much.
Amit, how do you decide the choice of a graft, whether to use a cancellous bone graft or a strut bone graft?
See, there is, if we talk about scaphoid non-union and bone grafting, there is a lot of debate. Debate on using vascularized bone graft, debate on using non-vascularized bone graft, debate on using cancellous bone graft or cortico-cancellous bone graft. So, at this stage, if we are using only cancellous bone graft and nicely fitting it, then it will serve the purpose. Like what we do in arthroscopy. In arthroscopy, we are not using cortical bone graft. We are using only cancellous bone graft, but we take bone graft 5 times the defect, so that it is nicely impacted.
Okay. Okay. And your choice of fixation is always screw, or depending on the fracture where it is, you decide?
Yes, regarding fixation of the scaphoid, we can use, as I said, we can use K-wire, we can use screws. Suppose there is a proximal pole fracture of the scaphoid, and lot of times the size of the scaphoid pole is very small. Then in such cases, it is better to use K-wire. But when the scaphoid there is a waist fracture or distal pole fracture, then we can use screw. Whenever we use K-wire, it should be always 2 K-wires, because if we use only 1 K-wire, then there occurs rotation and it will not give adequate stability. So whenever we are using K-wire, 2 K-wires, otherwise screw in such case.
And how long you immobilize them?
Generally, scaphoid takes long time to unite. It takes 2.5 months to unite, but generally we keep it immobilized for up to 1.5 to 2 months, depending on the follow-up X-rays.
What is the starting point of the screw?
It is, yeah.
How do you decide where to pass the screw from?
Yeah, if it is a proximal pole fracture, then we do start from distal. We start from proximal. And in rest of the cases, we can pass from distal to proximal.
Is there some point on the distal, like there is a tubercle or something, or it's just general, there is a waist, like there is a broad end of the scaphoid, start in the middle and just pass it?
In the scaphotrapezial, just distal to the scaphotrapezial joint.
Okay.
In the edge of the scaphoid, that is the starting point of the distal scaphoid. Yeah, yes, Ron.
Does your bone graft choice depend on the level where the non-union is? Waist versus proximal pole?
Yeah, that's what I said. Previously, there was a lot of debate that vascularized bone grafts are more superior than the cancellous bone graft. But now enough literature is available, and all is saying that only cancellous bone graft is sufficient, even if it is a proximal pole fractures.
Let's move it on to the, while Dr. Karkhanis asks this question, let me also ask the online people if there are any questions. Scaphoid fracture, beautifully demonstrated by Amit Varade. Excellent exposure, release of the radiocarpal ligament, a protection, exposure of the scaphoid, making drill holes, bone grafting, and then a nice screw from distal to proximal. So, any questions? Patna, Sholapur, let's have the question from you.
Solapur, Dr. Amit, very nice presentation, video presentation. Can you show us the post-operative X-ray, please?
Yeah, thank you, sir. Post-operative X-ray I have not included in the video, but there are intra-op C-arm images which we can see.
So, that intraoperative C-arm image, are you trying to tell me, sir, from Sholapur, that you felt that it was still slightly distracted and opened? Is that the reason why you are asking the question? And that it looked a little displaced compared to, it wasn't like an anatomic reduction. Is that what is bothering you?
And if it is so, then what is the post-operative immobilization protocol that he follows in both the situation, when it is properly fixed or it is not such a great fixation?
Yeah, just a point that Gautam sir has raised, it is a very nice point. It will always look like that, gap at the non-union after fixation, because we are putting cancellous bone graft over there. It will not be seen in the X-ray or C-arm image immediately. It will be seen only after union.
So you will not get a typical bone-to-bone contact which you expect in a fresh fracture. Yeah. There has been resorption of bone, and he's filled up the defect with some bone, and therefore that is not going to be seen, so it will appear as though it's a distracted fracture. Is that correct, Amit?
Yeah, yes, sir.
Yes, yes.
Absolutely.
Any other questions?
Yes.
Dr. Runu, tell us.
Sir, we have a question that while putting the screw, while tightening the screw, how to prevent the humpback deformity due to compression? How to prevent it? This is the question from Dr. Rajendra Prasad.
Very good question, Dr. Prasad.
Yeah. Very, very nice question. So, scaphoid non-union, whether it is presenting in early stages or late stages, whenever it presents in late stages, there is often a humpback deformity. Humpback deformity is a deformity in which the scaphoid distal pole is flexed, and there is a wedge-shaped defect on the volar side. So, whenever we treat these conditions intraoperatively, first do wrist flexion and pass a radiolunate K-wire, and then gradually extend the wrist joint. And in such cases, what happens, there is the wedge-shaped defect opens up on the volar side, and then we fill the bone graft, and then after do fixation. And if we do this, the scaphoid deformity and humpback deformity gets corrected.
Hello. Thank you. That's a yes. Yes.
Haldwani, sir.
Yes, please tell us from Haldwani.
Sir, is there any role of radial styloidectomy in late presenting case of scaphoid non-union? Or what is your take on for the proximal pole non-union?
Yeah, sir, very nice question. See, scaphoid non-union, if we don't treat, then what happens? Then it is called as a condition called snack wrist, scaphoid non-union advanced collapse. And the stage 1 is arthritis of the radial styloid. So, in such cases, we can do radial styloidectomy, but I have done it for only one patient till now, and we generally don't see this. There is no need for doing this. And second, what was your second question regarding proximal pole?
Proximal pole non-union, what is your take on how to proceed in these cases?
Proximal pole fractures.
Proximal pole fractures or non-union?
Non-union, sir.
I will tell you both. Proximal pole fractures. So, proximal pole fracture, acute scaphoid fracture, is an absolute indication for fixation. If we fix it in the first attempt, then there is a lot of chances that it will unite nicely. Conservative treatment, lot of chances that it will fail. Then in case of non-union, the treatment is same, open reduction and iliac crest bone grafting like what we have seen, and no need to put vascularized bone graft. We can put cancellous bone graft only, but nicely impact it and put it.
You are going for antegrade screw passing in proximal pole or a retrograde?
If we are putting screw, then we put it from the proximal pole to distal pole, that is from proximal to distal. But if we are putting K-wire, then it doesn't matter. We can put it from either side.
Thank you.
Dr. Karkanis over here.
Sir.
Yes, Dr. Dhingra, please go ahead.
Sir, is there any impact of avascular necrosis, and do we look for avascular necrosis before fixing these non-unions?
Yes, lot of times we send patient for MRI, and MRI reports that there is avascular necrosis of the proximal pole. So, see, a plain MRI will not give you a diagnosis. If at all you want to do MRI, it has to be gadolinium enhanced MRI, number one. But if you ask me, the one indication which will give us vascularity, whether it is vascular or not, then it is to see intraoperative punctate bleeding. If there is intraoperative punctate bleeding, then it means that it is vascular. Otherwise, it is avascular. And lot of times, it is vascular only. So, better to put a bone graft and wait.
So you are not, the treatment should be like a scaphoid non-union. Don't worry at that point about the avascularity. Is that what you are saying?
Yes, sir, yes.
So therefore, no point in then doing an MRI either.
No point in doing MRI.
Okay.
Only scaphoid, X-ray is sufficient.
Dr. Karkanis? नीचे का वो ग्रीन चालू हो जाना चाहिए.
So I can hear, sir, no problem. I can hear, sir, you please. Yes.
Do you require to? So the question from Dr. Karkanis is that in order to get the correct direction for the scaphoid screw, do you need to do a little bit of coring of the trapezium? Then only you will be able to get a good direction for your scaphoid screw.
If we give wrist extension and nicely do ulnar deviation, then we can put a central guide wire in the scaphoid. That is one. But if you are not experienced enough, and if you are putting it for the first time, then if you are putting guide wire through the trapezium also, then that is also okay.
Dr. Sibin, your question, please. Dr. Shibin?
From Haldwani, one question.
Can you hear?
Yes, yes, we can. Kozhikode, please go ahead.
For bone grafting, is it sufficient we go for lower and radius instead of going for iliac crest?
Sir, if we are using a lower end radius bone graft or iliac crest bone graft is same. The quality of bone graft is also same. It will not change. But if you take iliac crest bone graft, then you will get a good quantity bone graft. That is the only difference what I found. Second thing, if we are taking distal end radius bone graft, then you need to extend incision a bit more, which I think should not be done as a cosmetic purpose only.
Right. Going to, yes, continue, please continue, Shibin.
Yeah, we can take graft from the same incision, isn't it?
Yeah. So that is what has traditionally been recommended, that you could use the lower end radius to graft the scaphoid. As Dr. Amit said, that you can definitely do that because ultimately both grafts have osteogenic potential, both have some osteoconductive potential, but probably the volume of graft you get from the iliac crest is a little better, and you probably get a better, if you want a strut, which is a small cortical chip in order to fill up the gap over there, then you are probably better off getting it from the iliac crest. But certainly one appreciates what you are saying, that you could do this through a single incision.
What I found, just a comment, what I found, if you want to succeed in this scaphoid non-union bone grafting, put lot of bone graft, nicely impact it. And that's why you need it from the iliac crest only. That's why.
You require bigger volumes.
Yeah.
Yeah. Okay. Yes, in Haldwani, there was a question from Haldwani.
Yes, sir. If you see avascular necrosis is in X-rays, then how do you proceed, sir?
If preoperatively there is already evidence of avascular necrosis.
X-ray, yes.
That's what we cannot see avascular necrosis on the X-ray.
Assume
avascular, Dr. Amit.
Yes.
Avascular necrosis will
You
take
can
place.
see the white sclerotic bone of proximal part of the fracture.
Yeah. That's what I want to say. See, there are a lot of how we are taking X-ray. What this MA you are using, that is also one thing. And second thing, even if you are seeing only white sclerotic proximal pole, it doesn't mean that it is avascular.
No, let us ask his question, let us phrase it differently, Amit. His question is that in the presence of a scaphoid non-union, there is avascular necrosis of the proximal pole, already established, now what?
Yeah. So, in such cases, if you, we can say that if scaphoid is not salvageable, then we have to go for another surgeries such as proximal row carpectomy or radiocapitate fusion, something like that.
Right. Anybody else wants to comment? Yeah, Nikita?
You said in case of avascular necrosis, you would rather do a proximal row carpectomy, or then why not try a vascular graft before you go ahead?
I will always try, but his question is very specific. He is saying it is avascular.
It is established avascular.
Yeah. I will always try.
Yeah, avascular bones heal if they are put in a good vascular environment.
Hello.
Like your bone graft is essentially avascular and you are expecting it to heal at two poles. So vascularity should not preclude attempt at bony union. Okay, unless the fragment is necrosed, fragmented and not salvageable, then you have to decide by excising the fragment how are you going to reconstruct. Whether you want to do a salvage procedure like a PRC or a reconstructive procedure like replacement with a vascularized medial femoral bone graft. The reason probably you did not mention that, then it gets too complicated for today's discussion. So that's fine. But I think avascular necrosis should not preclude an attempt at union.
Yeah. This is a very good message.
So while I am at it, can I make one more comment?
Yeah, please.
About the screw positioning, which Dr. Karkanis was also mentioning. It is not about where the screw enters from distal to proximal, or whether it is lying in the center, or whether it is the longest screw. It is about where the screw end lies in the proximal fragment that has direct bearing on the number of scaphoid fractures that are going to heal after fixation. So that is one of the most important parameters for a good screw placement, where it lies in the proximal fragment.
So where should it lie, Pankaj?
It should lie more or less in the center of the proximal fragment and the longest screw that can go in the proximal fragment.
Lovely. Yeah. All right. That was a great presentation, Amit.
One question from Coimbatore.
From where? From Coimbatore. Let's move to Karthik. Karthik, go on.
Sir, fantastic presentation. See, there are instances where when you put a chunk of iliac bone graft and then fix it with a screw, we usually take a wedge-shaped graft. And the post-op X-ray, we see that the graft slowly starts moving. And sometimes it actually comes and hits the distal radius as well, and blocks movement sometimes because we put the graft and it's holding quite well with the screw, but then probably it's the screw is not in the center of the graft and the graft starts moving. Have you seen that, and what are the ways to prevent it?
I'm going to spare Amit now a little bit and move to somebody who is recognized as India's expert in scaphoid fractures and ask Hemant Patankar to come and answer this question. So
his question is, he has put a bone graft from the volar side and it has break while putting screw or fixation, and it just comes out on the volar side, something like that. That's what I understood.
In fact, when Amit said iliac crest bone graft, and sir did not say anything. I assumed he had gone home.
I know he take distal radius only.
We cannot hear you.
I think there is a lot of fun going on because as we said that Dr. Patankar is has one of the largest series of scaphoid fractures that is known, both primarily acutely treated and non-unions. And obviously after 35 years of practice, he has some fairly strong opinions. So that's the reason why I called him out here to help us sort some of the problems out.
Hemant sir, is there any scope of scaphoid excision in
Before just take that first question, Coimbatore, what is the...
Till what duration? Yeah.
Sir, after a month, if you see in the X-ray, the graft actually was flush. When you put, I'm quite, my favorite technique is to put an aliquot bone graft. I take a bigger chunk to correct the humpback deformity and place the graft very snug and then fix it with a screw. But in a couple of cases, I've seen that the graft was not so tight, but it was folding quite well in the initial intra-op, and then after a month when we see the graft has slightly moved from its place, and it is probably now sitting in the radiocarpal space and trying to block the movement.
So you are talking about a displaced graft from its original location, and now it is sitting in the radiocarpal space.
Happens more commonly with the proximal pole fracture than the...
Yeah, it has happened more commonly with the proximal row car. Let me just stop the questions here and let me just get Dr. Patankar to give his philosophy. Hemant, let us first talk about acute scaphoid fractures. When do you operate? Do you operate on day 1, day 3, day 6? When is the latest you will operate on these fractures?
Acute scaphoid fractures, if the fracture is seen on an X-ray, it requires surgery. If it is seen only on a CT scan, hello? Yeah, if the scaphoid fracture is seen only on a CT scan and not on an X-ray, it will most probably not require surgery. It can do well with a plaster. But you have to repeat the plaster after 3 weeks or at least 2 to 3 weeks. Remove the plaster and take an X-ray again. Many times the fracture which is so innocuous or undisplaced on the first day will start opening up on plaster, because we have to remember that the scaphoid is connected to both the rows of the carpus, and any slight wrist movements in spite of a plaster will cause movements at the fracture site. So many times so-called fracture scaphoids which are so-called stable in a plaster will keep on moving, and you will get innocuous delayed union or non-union like thing appearance after 2 to 3 weeks. So if the fracture is seen on a X-ray on the first day,
sir, we are not
advise surgery.
Here, sir.
Hello, if the fracture is seen on the first day on the X-ray, please advise surgery. It does not matter how you fix it. KVR or screw is good enough. Both are good enough. Both give equally good results. The difference scientifically is only 2 weeks. Screws take 10 weeks to heal. KVR take 12 weeks to heal. It is same.
And what is the latest you will operate with this technique? If the patient has come with an acute fracture,
yeah.
What will be the latest you will operate?
Yeah, you can do a closed fixation of the scaphoid with a screw or a K-wire. I have done it up to 8 months and they have united without bone grafting. I have done one patient from Thane itself who refused any sort of open surgery in spite of the fracture becoming loose, the plaster becoming loose. He removed it on his own, and at the end of 8 months, he said, I don't want it to be opened. You do anything without giving me a single stitch, and I'm willing to operate, otherwise I don't want to get treated. So we just put in 2 KYs with the thing written from him, got a written consent that if this also does not unite, you will have to undergo bone grafting and formal procedure. But he united.
But, so the first message that Dr. Patankar gives you is that if it is a scaphoid fracture which is seen on X-ray, it must be operated. There is no question of conservative treatment. If it is on CT scan, you can choose to treat, and you're not seeing it on X-ray, you can choose to treat this non-operatively, but you have to repeat the X-ray without a cast after 3 weeks and have a look at what is happening to the fracture line, and then again immobilize if it seems to be healing fairly well. This is the first message we got. The second message we got, in an acute situation, is there ever an indication for bone grafting in an acute situation?
No, unless the fracture is very fragmented, which I have probably done once.
Okay. So,
but not.
in an acute situation, bone graft is almost never necessary.
No, never.
You can fix it with screws, you can fix it with 2 or 3 K-wires. The outcomes are essentially similar. The healing process with K-wires may take a longer time. That is the second message.
Only 2 weeks time, only 2 weeks difference. In practice also, it does not really matter.
Right.
There's some scientific paper which I read.
Now the third question is
No,
about...
one more thing. It does not matter. There is nothing like a compression for a scaphoid. All you require is a interfragment stability. You don't require compression. And I think that HCS does not stand for headless compression screw. It stands for headless cannulated screw.
Okay.
Question to Dr. Patankar, sir.
Yeah.
Yes.
And this
Question to
question I would
Dr.
like to
Patankar,
answer.
sir.
Till
Yes.
what duration we can attempt open reduction and bone grafting? I have done it up to 17 years. There was an orthopedic surgeon. There is an orthopedic surgeon from Nasik whom I have operated, who had a 17-year-old non-union.
Amit here is feeling very bad because that patient from Nasik has come to him, Patankar. But I was telling him that that was before you were born, 17 years ago.
No,
right?
no,
So don't worry.
No, I have operated him 10 years ago. But he had a non-union, 17 years non-union. But he took long time. He took
Let's
4.5
move to
months.
Sangli. Sangli, question from you.
Sir, question to Patankar, sir. After fixing with the K-wire, do you bury the K-wires under the skin? Because you have to keep it for a prolonged
No,
period.
good question. I cut the K-wire under the skin, but over the bones, the K-wire is inserted just medial to the insertion of the APL tendon. So you have to take, there is a digital branch of the radial sensory nerve there. So you just identify that nerve and see that you are not going through the APL tendon and just cut it under the skin. You can easily remove it at 6 months. There is no
Alright.
problem.
Any other questions from
Sir's inputs on avascular necrosis?
your inputs on avascular necrosis?
Pardon? I immobilize every patient for 3 months. Every patient. On the first day, 3 months or 90 days, whatever the patient chooses.
So, so 3 months of immobilization to get a good this thing. Now your question now is that what about avascular necrosis? If suppose clinical X-ray or MRI, X-ray you may not see, are showing evidence of avascular necrosis already.
X-ray
and there is a scaphoid non-union.
Okay.
What should we do? How should we proceed?
In about 250 cases of scaphoid non-unions, I have not seen a single case of avascular
Calling from
necrosis
Patna.
on X-rays. They all have been reported on MRIs as avascular necrosis. In fact, the MRI is the greatest friend of hand surgeon because the patient will invariably go to an orthopedic surgeon. He will take an MRI. The MRI will be reported as avascular necrosis and the patient will be referred to a hand surgeon. So it's the greatest source of getting
How does it
scaphoids.
change your treatment? The presence of MRI-based
It does
avascular
not matter.
necrosis.
It does not matter.
It
I
does
don't look at the report. Just patient shoves it in front of your eyes.
Does
Ye
it
dekho sala.
then do you if it is avascular necrosis on MRI?
No.
Do you and you
I
it
take
doesn't matter. You still treat it, but do you do
No.
anything differently for these patients?
No. You just take a proper 4 X-rays, except the lateral view. Don't take a lateral view in a scaphoid; it's useless. So just take AP, PA in ulnar deviation. Take supine oblique and prone oblique views. You will see the proper lattice work in all the cases. You see the X-ray. Take an X-ray properly. Ask the technician to give proper exposure. See the nice lattice work. I have not seen a single avian in any case. None of the X-ray has come with an avian and none of them have been, I have caused an avian in any of the cases. Avian I have seen only when there is a carpal instability. When there is a transcaphoid perilunar dislocation or other problems associated with the carpus, we have seen avians and then the treatment is different.
Thank you, Hemant. I think we'll move on to the next session. Thank you, Amit,
sir. Thank
for
you,
a
sir.
very
Thank
nice
you.
video of scaphoid bone grafting and screw fixation. With your permission of our friends from all across the country, we'll move to the last session of this day today, in which we have two presentations. The first of which is going to be by Dr. Rohan Habbu, and Rohan is going to show us about radial tunnel decompression. I didn't even know that a radial tunnel existed till I read it on the program today. So let's hear from Rohan what a radial tunnel decompression is. Before I allow Rohan to go ahead, I have a pleasant duty to do on behalf of all of you seated at every center across India. I would like to thank the faculty of today's program before we go into the last session. And we are going to thank them with this chocolate here. That's all that Bombay Orthopaedic Society can afford to give them. Right? So we'll start with Dr. Hemant Patankar, the senior most chocolate deserving person. Even if you don't eat it, you can give it to your 7-day-old grandchild. And then we move on to Dr. Pankaj. He's going to claim he has diabetes. He doesn't eat all this. That's fine. You can pass it back to me. And to this sweet lady who's done some wonderful cases today, Dr. Nikita and Dr. Amit Varade, who is going come all the way from Nasik. Next time we'll have this workshop, we'll have it in Nasik at the Sulla Vineyards. And then we'll have Prashant Kamble here, who showed us this wonderful case of plating the distal radius. And Kiran, who's been here since morning, patiently helping us to deal with everything. Bipin, who is going to show us the next case. Anybody else left? Parag actually. Parag we will do little later. But Ashok is there. Ashok. Catch. And then there are 3 senior people who have been here. Dr. Phadnis, that reached the right mark. I wanted to reach you only. He's been here. Dr. Phadnis, a past president of the Bombay Orthopaedic Society. Dr. Karkhanes, another past president who has been patiently sitting here. And they've all been attending. And now to all of the rest of the people, I can see Abhay. Abhay is here. He's also there. So all of them, we will pass it on. And on behalf of, personally, on my behalf, where is my bag? Can I just take my bag? And it is on my behalf and on behalf of the Bombay Spine Society, a special gift to the organizer of today's program, Parag Lad, for putting it all together for all of us. Thank you, Parag, for putting together a wonderful program. All right, so we now move on without much ado to Rohan. Did I give you your chocolate or no?
I'll take it later.
All right.
He doesn't eat chocolates anyway.
Okay, I'll be talking on the posterior interosseous nerve release. It's we'll go about. So a radial tunnel syndrome is a bit different, but yes, it does involve releasing the same nerve, but at a different level. You're talking about PIN because that's quite not commonly, but still there in the orthopedic clinics. It can be just idiopathic. It can be after a proximal radius trauma, or occasionally it can be after a proximal radius fixation. So right now we'll just talk about the PIN. We had a 34-year-old lady, absolutely no trauma.
Sir, please adjust your mic, please.
This was the dominant hand. She presented with just dull pain in the proximal forearm, multiple times diagnosed as tennis elbow, somebody diagnosed as radial tunnel. With time, she started developing weakness of the finger extensors and the EPL. It was not a very classic finger drop, but if you do it against resistance, so she had weakness. However, the wrist extension was okay, and the rest of the motor parameters were okay. Interestingly, her sensation was fine. X-rays were normal, no bony issues. MRI was done absolutely normal. It shows the classic tennis elbow kind of picture of inflammation, but the EMG NCV was done primarily because of the weakness, and it did pick up a compressive neuropathy of the proximal interosseous nerve, the posterior interosseous nerve in the proximal forearm. Everybody knows the radial nerve divides into the superficial branch of the radial nerve, and we commonly discuss this because we see it, say at the decurvence release, we see it when you do a proximal radius fixation, but we rarely talk about a PIN because everybody knows it wraps around the radial neck, and when you're doing a radial fixation, everybody wants to keep the forearm completely pronated so that it is away, but rarely anybody tries to see it. You end up seeing it when it's actually injured. So we'll talk about how to approach a PIN for releasing it and maybe repairing it if it's injured. This is under a block and a tourniquet. It's a very it's a classic posterior approach, the Thompson's approach to the radius fixation. You mark the lateral epicondyle, you mark the radial styloid, and you make an incision about 3 to 4 centimeters distal to the lateral epicondyle for about 10 to 12 centimeters. So this is the incision length. Don't hesitate, this is a fairly simple approach. If you know the planes, you will be able to get down to the PIN, and it's quite simple. The superficial dissection is blunt dissection. What you end up seeing is just the deep fascia of the common extensor muscles. There's nothing there to look for. Maybe in the proximal part or the dorsal, the anterior part, you might end up seeing a small nerve somewhere here. That would be the posterior cutaneous nerve of the forearm. But as long as you are dissecting right over the deep fascia, you will not injure it. So don't hesitate to dissect it down. The common problem with this approach, and I'm sure everybody has seen it when you're trying to fix the radial head, is wrong intervals because there are so many muscles lines stacked against each other. Despite doing this a few numbers of time, me and my colleague Dr. Bipin ended up going into the wrong interval because this interval was right there. You dissect it down and you see that interval and you feel, wow, I found the interval. But as you keep going down between this muscle and this muscle, you just keep seeing muscles. If you go down a centimeter and if you don't see fat, stop. You are in the wrong interval. Remember, the PIN is not somewhere here. This is quite dorsal. The PIN is somewhere here. Okay? So when you make the dissection down, dissect underneath this flap. You will find a definite interval here between the brachioradialis and the ECRL. We don't like to see in the outskirts of the field of dissection. We like to see what's right there. But this, once you get down there, you'll never forget this interval. So you can see this now. So this was a wrong interval we took. Now that's the ECRL, and that's the brachioradialis. Okay? So you don't even need a dissecting scissor. You can use a simple little finger or your index finger, and you go down with blunt dissection, and you end up seeing something like this. It's quite easy. Now once you get here, now comes a little trickier part. Like I told you in the small animation, that there are 3 nerves that the radial nerve might divide into. So how do you identify what is what? Everybody knows the superficial radial nerve. So try and identify the SRN first. It's one of the easily identifiable nerve all through its course, right from the proximal forearm all the way up to the radial styloid. Once you dissect that, see, it's quite big. It's not small. I think it's one of the thickest superficial or the cutaneous nerves, like the sural nerve. So once you dissect that, you start dissecting it proximally. Oops. You start dissecting it proximally, and you find a confluence of nerves here. You see one nerve, your SRN is right underneath the brachioradialis. So this is 1, this is 2, and there would be a nerve right underneath here. And that would be your the posterior interosseous nerve. So just do blunt dissection in line with this. You can see it right here. I don't think so we did this under loops. I think we did this with naked eye, so it was quite easy to identify. So the first thing that you see, everyone, can I pause it? Okay, everyone knows the PIN can get the PIN can get stuck underneath the ECRB tendon. There could be a vessel leash, and you have a supinator edge. So there are three things that you need to release when you end up releasing the PIN. Luckily, in this case, we did not see any vascular leash, so we didn't have to cauterize or anything. The first thing we released was the ECRB edge. The next thing that you release would be the supinator edge. So how do you know it's the supinator edge? You keep pronating and supinating the forearm, and you can see this. And it's quite sharp. The supinator edge is not a muscular edge. It's a fairly sharp edge of fascia. And once you release that, you get a fair bit of space. So that's already released, and you can see the two edges here. I hope it's quite clear. So that's the edge that we have released. There's no endpoint for a PIN release, like you have, say, in a decurvence or you have in carpal tunnel. Here, you have to rely on the space that you create when you release all the compressive pathologies. So you can use a dura, you can use a sound, you can use an artery forceps and try and pass underneath. If you're able to pass it underneath easily, you should be comfortable about what you have released. You release the tunicate, everything is, if your dissection is good, there's not much bleeding. You end up closing directly the skin. We don't end up closing the subacute tissue, just the skin. We'll do a light dressing, no compressive dressing. The patient starts using the hand the same day, but absolutely no lifting weights for about 6 weeks. The key is the recovery takes time. It's not something that would recover overnight. So in our practice, we have seen the patients do recovering completely at about 6 to 9 months. So you have to counsel the patient well that it's not something that you will see overnight. It will take time. Typically, we don't do physiotherapy for this. We just do passive and active range of movement and just counsel the patient about the time to release. I thank you for your time. One thing I would add, suppose you have had a proximal radius fixation done. This would be the same approach, but you would go further distally so that next time when you put a plate, don't hesitate to look at the PIN. It's right there. So once you visualize the PIN, it'll be easier to put your plate underneath the PIN. All right. So this is one technique. You can actually make your life easier for plating the dorsal aspect of the radius. Thank you.
Rohan, I would like to ask you a question. How do you distinguish between a lateral epicondylitis and a radial tunnel syndrome to decide about surgical intervention?
Okay, so these two things I don't operate. So, okay, lateral epicondylitis and radial tunnel syndrome primarily are painful syndromes, but there is no motor deficit in these two syndromes. This was primarily a PIN compressive neuropathy. So this is primarily a motor weakness, but no sensory involvement. Coming to your question of lateral epicondylitis versus radial tunnel, I have unable to make any difference. The only thing would be the resisted wrist extension is classically painful. You keep the wrist and hand extended and just try and extend the wrist against resistance. It's painful in a tennis elbow or a lateral epicondylitis. As against, it's not painful in a radial tunnel. Radial tunnel will have a dull aching pain in the ward of 3, and you might have a dull tenderness, but which is diffuse. Tennis elbow will have a very classic tenderness as the lateral epicondyl.
Okay. Any questions from the audience?
How do we clinch the diagnosis? Because motivating a person to get operated, we need to be very sure about the diagnosis. Do we, in general, get the nerve conduction studies and EMG studies done, or anything MRI to look for any cervical component, or just on the symptoms we just go ahead and operate? And do people agree for that?
Sir, you're talking about this particular case?
No.
Yes, sir.
Okay, so this particular case was classically had weakness of the extensor digitorum communis and the EPL. Now, if you're getting a weakness, I would always do an EMG NCV study first, assess where the lesion is, and then maybe do an MRI or not do an MRI. So in this case, the MRI was already done. So luckily, there was no obvious space-occupying lesion compressing the nerve. So that was ruled out. So the only thing that remains is an anatomical compression of the nerve by the anatomical variance of the different structures next to the PIN. If your question is regarding the radial tunnel syndrome and the lateral epicondyle, I usually don't operate either. I just counsel the patient that this will take about 6 to 9 months, and I wouldn't operate them. Some people might have a different opinion.
So I would like to answer and comment about this. Is we have to consider, of course, a clinical judgment once we are very sure, a dynamic sonography and find out the diameter of a radial tunnel or a localized pain, the sonography at the localized pain by comparing on the opposite side. Commonest reason is sometimes we see a lump or a cyst in the around the posterior interosseous nerve. We have seen lipoma also around the posterior interosseous nerve. Small
Sir,
schwannomas
your mic is
also.
not working. We are not able to hear. So please.
Parag, you want to come here?
So what I am trying to say is dynamic
Thank you.
ultrasonography is the investigation of
Let him talk from here.
Yeah, the dynamic ultrasonography is the choice of investigation to identify the diameter of radial tunnel on both sides. Second is to rule out intra-regional pathologies like a ganglion cyst or a lipoma or a small schwannomas. They can give isolated motor deficit of a PIN nerve. And then we decide about EMG nerve conduction study unless there is a motor deficit and it is of no use in such cases. To diagnose radial tunnel syndrome, EMG nerve conduction study does not help. Yeah.
Sir, Rohan sir, Dr. Ajit from Kanpur.
Hi Ajit.
Hi sir. So how to differentiate clinically that many times radial tunnel syndrome mimic as a tennis elbow. So how to differentiate it is the tennis, you are dealing tennis elbow or you're dealing radial tunnel syndrome?
So one thing is clinical. Tennis elbow tenderness is at the lateral epicondyle. For radial tunnel, the tenderness is about 2 to 3 centimeters distal to it. And the second one is what Parag discussed. You do an ultrasound and you look at the thickness of the posterior interosseous nerve on dynamic ultrasound. So if it keeps changing as you pronate and supinate, that would be an indication for a radial tunnel syndrome versus a lateral epicondyle.
And second thing, Ajit.
Sir, sir, we are working in the, we don't have such a trained ultrasonologist that who can do the dynamic ultrasound and differentiate the diameter,
No,
So
Ajit,
we are completely dependent on the clinical diagnosis, sir.
I would like to answer another thing is if there is a middle finger passive resistance extension is painful, ask the patient to extend the middle finger passively. You put the hand on the middle finger and ask the patient to extend the wrist and if extend the finger and if there is a pain in the proximal dorsal aspect of the course of PIN, that could be the one diagnostic criteria for radial tunnel. There is something called, there is a scratch collapse test which has been described by many, but Dr. Vijay Malshikhare, hand surgeon from Pune, he has YouTube videos. That is a fantastic test to diagnose, differentiate between the lateral epicondylitis as well as a radial tunnel syndrome. And third thing is, we know the cause of radial tunnel compression is a supinator muscle. So passive resisted, supination action, if that gives a pain, that is also a cause of, that is how one of the criteria of radial tunnel syndrome. Second, third, last thing is intervention. Like if you give local anesthesia for the lateral epicondyle and if the pain goes away and then check for the tenderness at the proximal forearm, if still patient has a tenderness, then it could be the reason apart from lateral epicondylitis. And if the patient, if you give local anesthesia into the proximal forearm where there is a maximum pain, then check the tenderness at lateral epicondyle. If the patient does not have pain at the lateral epicondyle and radial tunnel pain is gone, that is another criteria to diagnose a radial tunnel syndrome. Any other faculty wants to add?
I want to ask you, where is the tunnel? For example, tarsal tunnel, there is a medial retinaculum. Now everybody knows there is a carpal tunnel. Now how can the muscle compress a nerve? You are saying in the supinator is such a flimsy muscle.
So the supinator muscle has a tendinous edge. It is not the compression of the tendinous edge is not very sharp, but it can definitely, the moment you release, we have surgical videos where we have seen constriction of the nerve because of that supinator muscle. Yeah. So controversial topic. I would like, if there are no other questions.
Yeah.
I
Any
would-
questions from
question-
anywhere
one
across
question
India?
is-
Coimbatore,
Yeah.
Calicut,
One
Patna,
question from
I
Patna,
can, yeah, please
Patna.
ask.
Yeah. Sir, two questions. Number one, how to decide extent of release? Up to what extent we are sure that
No, you have to decide the extent of release is the length of the supinator muscle, that's all. And it is like you can see by putting a mosquito or a blunt forceps, or the best instrument is McDonald's Dura retractor. And if you can identify that the nerve is free, and after your release into the entire length of supinator muscle, you check the pronosupination and see whether there is any compressive effect or any transverse fibers going across or over the nerve. That is how you decide.
and the post-op rehabilitation protocol, any specific?
Rohan,
mobilization
anything specific
protocol,
about the post-operative protocol?
I would avoid weights for 3 months, no lifting weights.
Hello.
And
Yes,
in
yes,
radial
Patna.
tunnel, if you have done a tennis elbow release or a lateral epicondyle release also, then I give above elbow slab in full supination for 10 days. And after, in full supination. And after 10 days, we just start, routine mobilization without having weight bearing activities. And if I do only radial tunnel decompression, I do not give any protection. But I try to tell the patient that try to do pronosupination activity so that it doesn't cause any
Right.
adhesions.
Let us, Parag.
Sir, one more
It's
question from
Rohan's
Patna, sir.
presentation.
Professor Kanauji, I will ask.
Talking about radial.
Dr. Parag,
You have a question?
Yeah. Yes, sir.
have you explored the arcade of Rose where there is a compression over the posterior introducer nerve?
Arcade of Frosch.
Yeah, usually it is there, sir, but we do not,
Go outside.
Yeah.
And the scenario is entirely different from what it is in the arcade of Rose, and we have some cases where we have operated and we have found good result, And lipoma, we have also cases of lipoma, something like that you told before, So just to say that outside it is compressed in that supinator tunnel, I don't have much experience. Okay.
Yes, sir.
Thank you. Thank you very much for everybody.
Sir.
Yes.
I have one question.
Please go ahead.
Which is the best approach, whether it's a dorsal approach or the Henry's approach to isolate or to press the PIN?
Rohan,
Which is the safest one?
What exactly is the safest approach for this?
You can go volar by a very proximal Henry's approach. Here, the brachioradialis will be a fairly big chunk of muscle. You have to really retract it laterally. While doing that, be careful for the SRN. Then you have a really big leash of vessels right on the volar side. So in my hands, I always do a dorsal release the way that we showed. I'm a little skeptical of going volar, unless there is a big mass which is pressing on the PIN on the volar side. But all other aspects, I feel the dorsal aspect is far safer.
Right. Okay, thank you. We move to the next presentation, that is from Dr. Bipin Gangurde. Bipin.
So after extensive bony presentations, we will go to some fingertip injuries. ये हिल नहीं रहा So fingertip injuries are very important here.
नहीं कॉस्टली का मार्केट ऑफ के कारण होता है कंप्रेशन में एक आदमी ने पूछा भी कि कंप्रेशन है कहाँ आपका यहाँ तो कोई कंप्रेशन है नहीं
Okay, Patna.
Mute. Can you enlighten somebody from for CMCR?
Yes.
Hello.
Yes.
Yes. So fingertip amputations are very important, and we need to preserve the nail. Basically, these flaps are to preserve the nail, fingertip of the nail. So so here I will be, ये घूम नहीं रहा, हाँ चलो. So here I'll be presenting VY. So you need to know this. How to control? नहीं इसको पीछे खींचने. Space. Pause it and take. हाँ ये दे. Yes. So VY plus T is specifically for this type of amputations. So a fingertip always, when you see a fingertip injury, you need to know what type of amputation it is. Whether it is a transverse amputation, whether it is a dorsal oblique amputation, whether it is a volar oblique amputation, and whether it is a lateral amputation. This is one way to classify a fingertip injury. Another way is according to Allen's type. But here, all the flaps which are being are presented are up from Allen's 1, 2, and type 3. Type 4 doesn't usually need this type of flaps. It needs something else. So type 4 is usually only when the amputation is through the germinal matrix and the nail will not grow. So if you see this dorsal abluque, so if you see this type of injury where there is a dorsal, always look from the lateral side of the finger, what type of amputation it is. So if you see a volar skin like this, so you can bring this volar flap dorsally and you can cover the finger, the bone there, and so that a proper nail grows. So this is a VY type of flap. So what you do is you have to cut it till the fat pops and then transpose it dorsally. Here, as you can see that this is amputation, and laterally you can see here that there is it's a dorsal oblique amputation. The bone, there is a bone loss, and there is nail bed which is present here up to here. So this is a classical dorsal oblique which can be taken care with a VY flap. So as you go forward, yes. So what you do here, first do marking. So remember this fact that once you are at the transverse line, crease, basically the finger crease, you should stop your V there and then convert it into Y. So here I'm showing you this approach. You take this incision, remember not to go across through the fat. So usually you might not need the longitudinal incision here. So this V is itself converted into a Y, but you can extend this incision little proximally. So once you go transversely, deep inside, you cut the skin fibers and see the fat. However, do not go through the fat. If you go through the fat, then you are going to devascularize this flap. So important point here is that the blood supply of this flap is through the fat. So you need not have to go through the fat. So as soon as you see the fat, you stop. Do not go through the fat down. Only cut the transverse fiber of the skin. The fat pops like this. Also cut on the edges. Now, after you are sure that it is
release completely and there is only fat, you can see that it transposes easily on the dorsal side. Now you can take the suture from the flap to the nail bed. So you can take absorbable sutures, or you can take 2 corner stitches, which are very important. Here the corner stitches are very important. So you can take the corner stitches with nylon and the rest of them absorbable sutures. You need not have need to suture the volar side, as they heal with completely with secondary intention. Or you can take some staggered sutures if required, because every stitch can cause avascularity of the volar flap. So I usually do not take volar stitch. Keep the volar side unsutured and then do the dressing, and open the dressing only after 10 days when everything is healed. So this is VY flap for dorsal oblique amputation. Of the fingertip. Thank you.
Thank you. I think that was very, very elegantly shown. For when we were in residency training, we used to have constant fights with the plastic surgeons. When we sent them open tibial fractures to cover, they would say first debride, build up proteins, etc. So what we started doing was, we started fixing all mandible fractures ourselves, and we started doing these small flaps, this VY plasties, the cross finger flap, and the thinner flap, which I think every general orthopedic surgeon must know, and they should be easily able to do these flaps in their own practice. I think that irritated the plastic surgeons so much that they started sending us, taking the open injuries more easily from us, because they didn't want to lose all these attractive flaps and attractive mandible surgeries. So this is one of the reasons why I was so keen that some flaps should be shown today, because these flaps are something which you can do in your practice on a day-to-day basis. So any questions from the house in Bombay, Rohan?
Yes.
How much can the flap be mobilized in terms of distance? 2 millimeters, 5 millimeters?
So for a VY flap, I think it's 2 millimeters, not 2 to 3 millimeters, not more than that. Because otherwise it will get tighter and it might cause pulp loss. So if you're getting, if you need more of tissue, then you need to do a oblique triangular flap or a cross finger flap.
Gentlemen from all across India, I'm going to again ask today, how is the Josh? In Bombay, we still have about 50 people in the room. If you are keen, then we can show you a cross finger flap also, which will be of interest to you again. Yes, Burdwan, please go ahead. Sorry, we can't hear you, sir.
The arm of the flap.
How do you?
Measure the arm.
How do you measure the arm of the flap?
That is a VY
So
arm,
the
that is the-
Y is not taken. It is only the V which is taken.
V which is
Ah,
taken.
What will be the length? How
No,
will you
the
measure
length, no, the width. You have to go from pulp to pulp on either side so that you can mobilize it on forward there.
The width should be the base of the triangle. You mean to say it?
Yes, yes.
Base should be the complete till the end of the amputation.
Basically, what you need to do is to get enough mobilization of that tissue so that you can cover the tip of the stump. Sangli? Sangli also has raised their fingers. Yes?
Sir, actually not related to this topic, but we were interested in first CMC joint arthritis, which was dropped.
CMC arthritis, we have a time permitting, we will show you, but definitely give us some time. Let us see how we can run. There were 2-3 videos which we thought, one was a carpal tunnel syndrome, which all of you see in daily practice. And here, Parag Lad has elegantly demonstrated carpal tunnel with opponent's plasty. If you want to see that, we can show you a cross finger flap and we can show you a CMC arthritis fusion. So these are 3 things which we can show you. Tell us which one first. Depending on time, we can go. How many people would like to? Let's have a show of hands. CMC arthritis.
CMC arthritis, Haldwani.
Haldwani also wants CMC arthritis. So does Sangli. Yeah?
Both, sir.
Both. Okay.
From Patna.
Yeah, but Dr. Zaveri now wants to go home. All right. Well, we'll do the CMC arthritis. We've got this thing, Bipin on the line here already. So let us show you a simple cross finger flap here. And we'll go from the cross finger flap to the CMC arthritis. And then we'll finish it
So
off.
this is another flap which is a must know for everyone. So this is a cross finger flap. So yes. Yeah. So yeah. So cross finger flap is usually taken from another finger and it is flipped over to cover the volar amputations basically, or a transverse amputations also can be covered by cross finger flaps. So it is basically a workhorse. So most of the cross finger flaps are done where you are unable to do multiple things like a VY flap or another flap. So in a cross finger flap, yeah. So this is a cross finger flap where usually what you do is you have a fingertip injury or a injury on the, so entire dorsum of the finger can be taken as a flap and can be flipped on to the other finger. So if you have a volar injury on one side and if you have a other finger which is good, then you can take the entire dorsum and can flip on the other side. But here in this case, I'm showing you a thumb a defect on the volar side. But this is a small tip how to do it. Like you raise a flap from the dorsum of the finger and flip it on the volar side like an open book. And the raw area can be covered with a full thickness skin graft and sutured. So this is a volar oblique tissue loss of a thumb. So in case of a thumb, you have multiple options to do, but this is basic. This was a osteomyelitis with a volar loss like this. So I thought that a cross finger flap, a tissue from other finger would have helped better. So if there is an injury like this or a defect on the volar side, you can take the index finger proximal phalanx area and you can flip it on the volar side of the thumb to cover it. You make an incision, take care of the veins. Remember there is a tendon immediately below it and try to preserve the paratenon of the tendon. So do not cross the mid-neutral line here. as in the, not the mid-neutral line is the line between the white and the gray area. So you have to stop your dissection up to the white and the gray area. And remember to preserve the paratenon. Once the flap is raised like this, try to bring the other finger closer. So you can also make this flap innervated flap by taking a cutaneous branch of the nerve, but in this case I did not. So you try and put the flap on the volar side, then you insert the flap. So the raw area on the dorsum of the index finger with the paratenon preserved can be covered with a full thickness graft. So I usually harvest it from the elbow, medial side, so that the scar is not visible. However, you can take the bikini incision in the groin also. So you take a full thickness graft sized according to the defect. Try to keep the fat there itself while harvesting the graft. Do not try to harvest the graft and remove the fat. It is difficult. So you try to keep the fat there itself while harvesting the graft. So once the fat is removed, you can suture this primarily, the defect on the elbow. Suture the graft. So here I sutured the graft and then took tie-over dressing. So tie-over dressing is a dressing where you take at the four corners you take long sutures like this. Then put a bactigrass. Over bactigrass put a sponge. If sponge is not available, you can use the cotton of Gamgee dipped in betadine. So this dressing ensures that the graft is sticking well to the dorsum of the finger, and you did not have to remove this dressing for around 10 days. Take two needle holders. One assistant has to, after you take sutures and press against it, the needle holder or artery, so that you press the dressing against the graft. Cut off the free edges. So this is the cross finger flap. So division, so after you are the skin is connected, you need to divide it. You need to divide it after 2 weeks. I usually do division after 2 weeks. More than 2 weeks, there is chance of developing contracture. However, people have gone up to 3 weeks also. So divide the flap. And finally at 4 weeks you have a flap which is sitting on the index finger flap which is sitting on the thumb, and this is the skin graft area. This is the flap. Only thing is that patient will feel the sensation. If you touch the thumb, he will have feeling on the index finger, but usually it goes away with time, up to 1 to 1.5 years. Thank you. Yeah. Questions? Yes.
Yeah. Any questions for Dr. Bipin?
No, no, no. This is not a vascularized flap. It is a pedicle flap. So, not needed. It's a very, two flaps you should know is Viva and it's a pedicle flap. Any question? Yeah. Okay, thank you.
Ajay sir, Ajay sir.
People don't want questions. People are saying just show us the video.
Okay. So we are going to show, Dr. Patankar sir is going to show now video about CMCG arthritis and a trapeziectomy with ligament reconstruction.
Yeah. Just pause.
वैस्कुलरिटी मिलाते इधर से कट गए वहीं लपेट के टाका मार के छोड़
Yeah. I'll be showing a case and related video about the CMC joint arthroplasty. It's a very common painful condition among the senior citizen group, and most of the cases they will, another common cause of radial sided pain, the commonest being decurvence, but this is also a very common cause, and many patients who come for so-called decurvence are actually CMC joint arthritis, and they have severe pain on working and doing activities with their thumb. As you know, many senior citizens are living on their own and their children are in US, so they have to do all their activities. So the need for surgery has started increasing because they have to use their thumbs for day-to-day activities. So this is a very common condition. And 1 minute. Can you mute it, please? Mute the voice. 1 minute. Mute the voice. This was. Can you mute it? Yeah, sorry. So we'll go back to the original this thing. Sorry. This Zoom is.
Hello.
Yeah.
Hello, we are not audible
Yeah.
at Sangli.
Because I'm not speaking. This is a case, the case which we are going to show the video. So I'll just show the history. So this is the pre-operative picture of that patient. Reduced joint space. There is a subluxation, there is a loose body. A typical appearance, not a very severe appearance on the X-ray, but all the same patient having pain, unable to do day-to-day activities and not responding to non-operative measures. The thing which you must tell your patient and counsel them that this surgery is not an emergency surgery. The patient will get more motivated if you tell them that you are not after their money. Tell them that you are going to be relieving their pain by by asking them to get operated. But the pain will get definitely reduced. So what are options are available? one is a CMC joint arthrodesis, and one is a arthroplasty are available for these patients who come with the problem of CMC joint arthritis. The problem with the arthrodesis, there is no adduction possible, and the load is shifted to the proximal and distal joints, so they eventually land up with more pain, and the patients don't want a stiff thumb. The problem with the traditional arthroplasty is there is instability, and there is loosening or proximal migration of the implants, where the implant arthroplasty is done. So, what is this going on here? So what I would show is a trapeziectomy with a ligament reconstruction and tendon interposition. So this is a video demonstration of that. So reconstruction of the CMC joint, we excise the diseased trapezium, we reconstruct the beak ligament and interpose a tendon in between. So this is the skin incision which I take for the procedure. And it's purposely a long incision has been taken because we require to harvest the slip of the APL tendon. The flexor carpi radialis tendon is identified. Again, it is the, I would say, hallmark of all wrist surgeries. This is the landmark tendon. You save the superficial branch of radial nerve. You identify the APL and EPB tendons and the palmaris longus. Then you excise the trapezium completely. Then you can prepare a malleolar screw, cut off its head, and use it as a corkscrew to excise the trapezium. That works very well. And then you take a curved osteotome, or you can take a 12-number tonsillar blade. That enables you to quickly remove the trapezium. The removal of the trapezium, in spite of all this, takes about 20 minutes. It's a bone which is just stuck to everywhere, including the trapezoid. So the corkscrew helps to excise the trapezium like this. And this is a tonsillar blade I'm using, 12-number blade, a very useful blade. And the trapezium excised, as you can see, in one piece. You can also use a nibbler. Make sure that you don't damage the FCR tendon, because this is what we are following is a Thompson's arthroplasty method. And then you take the palmaris longus, you harvest it with a tendon stripper. If you don't have a tendon stripper, doesn't matter, you can take multiple incisions and harvest the graft. The thing to remember while using a tendon stripper is that there is a once in a million, I think, chance that there is a median artery, and this stripper will strip off that median artery and the hand will bleed like hell. So be careful about that. It's a rare thing, but it does exist. So you take a half slip of the APL tendon and wind it around the intact FCR tendon, which is easily identified after you excise the trapezium. And you take multiple turns of this APL tendon around the FCR tendon, and then use non-absorbable suture material. I like to use thicker Prolene 20 or 30 because I want more foreign body, more material in the space, in the gap created by the loss of the trapezium. So you ask the assistant to tightly or pull the thumb out so as to create a more gap, more than what the trapezium, more than the height of the trapezium. And then you wind the APL slip around the FCR tendon and then take sutures there so that it is sitting as if you are creating a seat for the first metacarpal to rest upon. Ensure that you don't take absorbable sutures here, take non-absorbable sutures and no fine sutures. The needle should be quite stout because it is difficult to pass this needle. So you should use a stout needle with a stout thread also. Three, four horizontal mattress or vertical mattress sutures are adequate in this. And you keep all the fibrous, all the tendon into that defect. So ensure that you create more and more fibrosis there. And at the same time, at all the times you should maintain traction when this suturing is going on. Your assistant should keep on pulling. As you can see here, he's just pulling the thumb apart. And then in the space, the remaining space, you just roll the palmaris longus tendon graft like an anchovy and just put it in that defect so as to create further, get more fibrous material there, more natural material there. This is how we take those sutures.
Finish हो गया
Again, very important, you please maintain the traction while suturing. Don't give up that traction.
बहुत अच्छे से वीडियो बनाया
And the remaining graft can be, or remaining slip of the APL can be just put back into that defect created by the trapezium. There no need to suture all the grafts and all that. Just leave the APL tendon like that only. And now the remaining space is, you will see how we roll up the palmaris longus. If the palmaris longus is not there, doesn't matter. Don't take anything, but use only autologous tissue. So this is the palmaris longus. You take any, this is the other end of the skin hook, and multiple sutures are taken, and the palmaris longus is rolled into an anchovy and inserted into the void created by the trapezium. And then with the same material, non-absorbable material, I repair the soft tissues and CMC joint capsule, which has been carefully lifted off the bone before removing the trapezium.
प्रोलीन है
Yeah, here I have used Prolene.
बोल रहे नन
Smooth material should be used. We should not use braided material.
जो थोड़ी ऑब्जर्व हो जाएगा प्रोलीन है
Then you repair the soft tissues. Yeah, you can see that. No need to place any suture on that anchovy. It just rests in place. You just cover the capsule on top of that. No need to particularly take any sutures in this case. Just ensure that the anchovy doesn't come out of that thing, out of that defect.
क्या रहे 10 मिनट में खत्म हो जाएगा
Yeah, you can see the capsule being repaired now. And when you're taking a non-absorbable material, take inverted knots so that the knots don't hurt the skin, which is generally very thin at this place. That's the soft tissue, that's the capsule which is covering the defect created by the loss of the trapezium and covering all the palmaris longus and other sutures there. Then you close the skin. Keep the distal half of the incision open because you are going to require to pass a K-wire between the first and second metacarpal to maintain this traction and abduction. So out of a total surgery of about 1 hour, it takes about 25 minutes to remove the trapezium and 35 minutes for all the remaining things. So in this case, we have passed the K-wire first, from the first metacarpal to the second. I use a 1.5 millimeter wire. Now here you can see that the wire has been passed through a drill, not really ideal. You pass the wire first into the first metacarpal with a drill and then go to and fro into the intermuscular space, because otherwise you have instances where the where the interosseous muscle gets wound around the K-wire and there will be problems. So you go into the first metacarpal and then with a T-handle go into the, with the to and fro movements so that the muscle does not get wound around that K-wire, and then go into the second metacarpal. So this is the same patient. This is at 6 months post-op. This is another X-ray of a very senior orthopedic surgeon who was operated by me. Now this is his 8 years and 5 years post-op. That was in 2017. He's still operating. He must be 75-year-old now, but he's still operating. So what works is a trapeziectomy, this suspension plasty. So patient gets a good relief of pain and good stability, and with hardly any collapse with this method. I thank you for your attention.
For this wonderful demonstration. Any questions from the house here? So, CMC arthritis, it is not uncommon. We see this very commonly, elderly ladies coming to our clinics, and we kind of wonder what to do, treat them with some non-specific physiotherapy, occasionally some injections into the CMC joint. Eventually, a time comes when the pain becomes unbearable or the function becomes limited, and that is when you try to do something. And this is a procedure which is commonly, which is not very common, but it's not uncommon either to be doing it. Yes, Sangli has a question. Let's have Sangli on the line.
Thank you, sir. Thank you for adding the topic. Thank you for adding the topic.
You are very welcome, very welcome.
Hello, from Haldwani, sir. One question.
Yes.
Sir, is there any indication for bony arthrodesis nowadays? Or where can we
only indication is in a heavy manual worker, very young person who has got a CMC joint arthritis, as, I think most probably post-traumatic. Then you can offer him, depending on his occupation and needs, you can offer him a CMC joint arthrodesis. Otherwise, arthroplasty is a much better procedure as far as stability and pain is concerned.
Okay. We can perform this procedure
I can see that
at any age group.
Hello?
Yes.
In any age group, we can perform this procedure LRTI?
Can you do this at any age group?
Yes, yes, you can do it at any age group. Okay. The degenerative arthritis invariably occurs in senior citizens, but you can do this in any age group for any sort of CMC joint arthritis.
Okay. Ladies and gentlemen, this was, yes, any questions over here? Yes.
Yes.
Unmute. Sir, I have a question. Hello. Hello.
No, you can do only a trapeziectomy also. You can do only a trapeziectomy with a intermetacarpal wire. You can do a plain trapeziectomy without doing anything. But the chances of that whole metacarpal collapsing are very high, and we have instances of, or there are reported instances in literature where there has been an abutment of the base of the first metacarpal against the scaphoid and causing pain and instability. So that's why this is added. It's quite a simple thing. Removal of the trapezium is quite bad. It takes about 25 minutes because it's very tightly bound to the soft tissues there. But otherwise, the remaining procedure is quite simple.
As I can see, the Patna group is winding up, and they've already taken family photographs. And
I have a question.
I would like to thank Dr. Runu over there for coordinating the whole show today from Patna. Fantastically done, sir. Thank you very, very much. I would like to thank all the delegates in Patna before they leave, that thank you for being with us. We have 3 more symposia later in the year. Please do join us for those. I'm sure you will, like you enjoyed today, you will not be upset about having missed out on a Sunday. As people get to leave, I'm getting requests from here and there about wanting to show a carpal tunnel decompression. Somebody has asked whether they want to see a Kaplan's dislocation reduction. What is the Josh like everywhere else? Is anybody interested, or should we wind out? It's a wind off. You know, this is 7 hours
We can
we've had.
continue, sir. Josh is very high.
Because it's been 9 o'clock we started, it's 4 o'clock in the evening, we've not stopped for breakfast, we've not stopped for dinner, so, or lunch. Now it looks like we'll be having dinner together, all of us. And, okay, we will, which one would you like to see first? Carpal tunnel decompression?
Kaplan.
Okay, Kaplan. So we've got Prashant Kamble is ready with Kaplan. Sangli, you have a question, please go ahead.
No, Kaplan only. I wanted
Kaplan dislocation.
Okay, Kaplan. So we will give Kaplan whatever you want. Okay, so that's great.
Sir,
We are going before while Dr. Kamble sets up his Kaplan dislocation. I am going to take some the honor to suggest a vote of thanks. Let me start by thanking. Normally one would thank our team and this team and that team. But I am going to start by thanking the INTAS team. The INTAS team, whether it is in Bombay, from the day I approached Mr. Jagrup Singh ji, the Vice President of INTAS, and Prabhakar, who is the regional head over here, they have been going out of the way to facilitate this program here in Bombay and across the country. I would like to thank each and every member of the INTAS team in Sangli, in Haldwani, in Sholapur, in Kanpur, in Kozhikode, Coimbatore, Kadapa, everywhere. I'm sorry I can't remember everything and I'm missing a few, but each one of you has done a fabulous job. Imagine for 7 hours we have been online. There has been no breakdown of audio visuals. There has been no breakdown of connectivity. It is thanks to the phenomenal efforts by these INTAS people. Thank you. I think we owe them a big round of applause from all of us here. I would then take the opportunity to thank all the delegates from all over the country, whether in Mumbai or everywhere outside, for sparing their Sunday for this academic program, which I'm sure you gained a lot from. But still, it is very difficult to motivate yourselves to give up a Sunday and come and watch a program. Hopefully, we have not disappointed you and we've given you enough mouth-watering stuff so that we've encouraged you to stay in the rooms. Thirdly, I would like to then thank the moderators at every location. Sirs, you all have managed to, it is in an online program, it is very difficult to hold delegates in the room. And therefore, the role of the moderator is absolutely crucial. He or she is the one who holds the people in the room. I can see that even at 4 o'clock in the evening, there are so many people at each location and each room. It is a credit to the fantastic moderators we've had for today. Thank you very, very much. I would like to also thank the audiovisual team here in Bombay with Ivan and his team, the OrthoTV team who have provided all the links, and the audiovisual systems at each and every place across India. So to me, this is Hamara Bharat, a successful India of today, where we can reach the furthest reaches or corners of India with all these kind of fancy programs, and we can do them very clearly and efficiently. Finally, going to my team here in Bombay, I already gave them chocolates, but I still will thank them. All of them have been here since 8:30 in the morning and been patiently here helping us out with every aspect of the program, answering questions, simulating discussions. Each one of you, thank you very much. And of course, my convener, Dr. Parag Lad, who has put in enormous efforts today to get this going. I've been sitting on his head daily, calling him 3 times a day. Have you done this? Have you done this? Every time, sir, it will be done. And it gets done. So thank you, Parag. Without further prolonging this, let's move on to the Kaplan's dislocation. And we've got Prashant Kamble to take us through that. Dr. Joshi, you want to ask a question? Dr. Joshi, you want to ask a question before this starts? Dr. Joshi? All right. Yeah. What was wrapped around the FCR? Half of the APL.
Okay, thank you.
हाफ है का एपीएल आणि तो प्रॉक्सिमली डिटॅच केला माईक चालू आहे
Can you play? So coming to the end of entire day, so this is again not so commonly seen, but sometime when you see, this is quite sometime become difficult because initial days it might be missed at the initial presentation. So what I'm going to show is a volar approach for a neglected Kaplan's dislocation, and this is what exactly you are going to see when you open on the volar side. So this is just a diagrammatic representation: metacarpal head, lumbrical muscles, FDS flexor on either side, and the ligaments which are preventing the reduction. So this is a young male patient, had a history of fall 3 weeks back. This was recorded during the pandemic. He came for the treatment, and this was his range. PIP, DIP is moving, but there is no movement at the MCP, and you can feel the metacarpal head in the palm. So this was the X-ray, initial X-ray. You can see there is a dorsal dislocation and widening of the space, and there is no metacarpal head osteochondral fragment. That indicates that there is no way to go from the dorsal side. So this was the intraoperative picture. Patient is under general anesthesia, and there is hardly any movement at MCP joint. PIP, DIP can be freely moved. Sonder tourniquet. So whatever is the right-handed surgeon sits on the radial side of the patient, and you mark your landmarks. So typical Brunner's incision, try to curve along the crease. So here, when you start your skin incision, you have to be extremely careful. Just below the skin is your neurovascular structure, which is providing to the index side, the radial side of the index finger. So just limit your incision to the skin. Lift the small flap of the skin at the apex. See under vision, and then start dissecting on the, take the flap towards the ulnar side. Even 1 millimeter more deeper incision, you are likely to damage the digital nerves there. So you see there, these are the digital nerve. And moment I lift the flap, you can see the metacarpal head hiding there. So this was a 3 weeks old, so little more dissection is required. Suture the flap, that will reduce your one assistant. Release the digital nerves. and retract to other side, and make sure that it is protected throughout your surgical procedure. So this is what pathoanatomy is, your ligaments which are preventing the reduction, and since this was old, you need to release those things. So that it has formed the flimsy layer on the metacarpal head which you saw initially. So cut that. Again, be extremely careful, prevent the damage to the digital neurovascular structures. So part of the volar plate which was attached there, I'm just releasing, and the superficial ligament. So the flexor tendons that has gone on the radial side, release partially and retracted. So this is what exactly I've shown on the first picture. So part of pulley was released just to get the adequate retraction, and this is A1 pulley. Both the flexor tendons on the ulnar side. Yeah. So this is what your volar plate and natator ligament, which was preventing your reduction, had this been attempted and not reduced. So that is the base of the proximal phalanx. Since it was 3 weeks old, you can expect more of a fibrous tissue there, which is obstructing the reduction. Moment you release, it just pops back and get reduced. It is reduced now, but since it was 3 weeks old, all the dorsal tissues, they are also contracted. So need to flex and let the tissue get relaxed for a while. So reduce and keep it in a flex position for a minute. And then you repair the volar plate so that it will, see, if you don't repair that, what happens? It is going back. So this is absorbable sutures, PDS I'm using here. Is a delayed absorbable so that volar plate is completely healed. And you can check the finger cascade here. And you can just confirm the same under C-arm is reduced. So it is very well reduced. and it is stable as we have sutured the volar plate, so it will not allow it go into the extension. So part of pulley, A1 pulley, you can repair or you can just leave it. And then just close the wound. Again, be careful, extremely careful not to damage the neurovascular structure there. So again, good tenodesis effect. And post-operative, you can give the extension block slab so that he can do active flexion but no active extension till the volar plate heals. So 7 days, once the pain swelling is reduced, you can start him doing the range of motion. So it is good range achieved at 3 weeks. And he's got back to the full strength compared to the opposite side. Thank you. It's a female patient. It was a female patient, yes.
Thank you. So what about, how long is the immobilization you said?
3 weeks. 10 days I start the active range with the intermittent range of
So that was a beautiful demonstration. You can actually see exactly what has been described as a pathology in Kaplan's was demonstrated to you by Dr. Kamble. Thank you very much. Prashant, any questions from anywhere across? As we move on and wait for questions, I would like to thank each and every one of the moderators, Dr. Dingra in Jalandhar, Dr. Tiwari in Kanpur, Dr. Kamboj, Dr. Pradeep Kamboj in Rohtak. Thank you very much, sir, for being there with us through the day. Dr. Bansal in Batinda. Dr. Ganesh Singh in Haldwani. Thank you, sir, very, very much. All of you, such senior professors in the department, spending your valuable time with us. Thank you very much. We are really honored. Going to South India. Thanks to Dr. Dubey in Pondicherry, Dr. Selvaraj in Coimbatore, Dr. Surendran in Calicut, thank you, sir. Dr. Sirsala at Kadapa.
Thank you all for sparing your Sunday, for leaving your wife, your family, your kids, your Sunday OPD, and being with us is really wonderful for us, and it's really encouraging.
And then going to Sangli and Sholapur, both of whom Burdwan. Dr. Ghosh at Burdwan, Dr. Runu at Patna, Dr. Devnath at Agartala, Dr. Deshpande, Dr. Akshay. Thank you very, very much. And if I've missed any of you, I'm extremely sorry. But thank you, each one of you. Any questions on the Kaplan's dislocation? We'll be happy to answer.
Sir, one question. Hello.
Yes,
From
please
Calicut.
go ahead.
So how do you go for select dorsal or volar approach?
If you see the X-ray, if you see the dorsal osteochondral fragment, then you need to go dorsally because you need to fix that as well. And if you don't have that, you can go with the volar approach.
Okay, thank you.
I would like to talk for a minute. See, I must appreciate.
Parag sir.
Yeah.
Parag sir, thank you so much. From the Kanpur Orthopaedic Association, from Kanpur, I, Dr. Aziz, thank you all for putting your effort, for enlightening us, for showing the so many showcases of videos and cases We are really obliged, and thank you so much for your participation and giving this kind of enlightenment to us. Thank you so much.
Thank you, Ajit. You were the blessing there because being a hand surgeon, you could generate good discussion. And here I also thank our
hello, sir, from
Honorable President, Dr. Gautam Zaveri, sir. I mean, as a convener, I understand, every time my judgment was getting, wrong, because I was telling sir that we will put 10 minutes video, 15 minutes video. And he was telling from the beginning, no, you put one video for 40 minutes. I thought, what will you show in trigger finger for 40 minutes, And that is how this program took almost 1.5 to 2 months. And I am really fortunate to have him as a president and to work with him as an organizing secretary for upcoming YROC. This was my first interaction with him. It was really a wonderful show. I mean, I must thank my faculty, colleague, everybody. But the engine or the driving force was sir. So many things I learned and everything was guided through him. And thank you very much, sir.
Thank you very much on behalf of Sangli, the beautiful symposium for Bombay Orthopaedic Society. Thank you once again.
Thank you all of you, and hope to see you at YROC 2025. All of you, if you all register, if all of the people who are there in the various centers, if you register, you just contact Dr. Parag and he will give you an early bird rate to register for YROC. As a special gift, because you've been delegates today, we have arranged a special rate for registration to YROC. We will give you an early bird rate. So please contact Dr. Parag within 1 week and we will be happy to extend these privileges to you. With this, good evening and have a great time with your family this evening. Thank you.
Thank you, very, thank you.
Sir, from Solapur Society, we thank all of you for sparing your time and teaching
All
us.
faculty,
Thank
please
you so
be
much.
here to take a photograph. Yeah.
Point to a great thanks to all of you for doing a wonderful job. Thank you. All the best.
Thank you from joining us.
From Patna, sir. Very, very thanks to Gautam, sir, Bombay Orthopedic Society, and INTAS people for organizing such a beautiful program today. We are thankful to all the faculties for sharing their knowledge. Thank you, sir.
Thank you very much.
Thanks to all the participants and INTAS people around. Those who made it possible, and it was a great Sunday.
Thank you very much, sir, for being with us. And for your kind words.
The experience for this session was very nice and it was a wonderful experience.
Thank you.
It was a wonderful experience and I hope this will be planned for the future again. And we will